Good morning, everyone, and welcome to the 17th Annual Future of Healthcare Conference. To officially welcome you this morning is Laura Dunham, the Dean of the Opus College of Business. Thank you.
Thank you. Thank you, Abby. And good morning, everyone. It is wonderful to see you here this morning with us. And it's my very great pleasure to welcome you to the Future of Healthcare Conference here at the University of St. Thomas and the Opus College of Business, a place that is dedicated to the future of healthcare through education, collaboration, and innovation. At Opus, our programs and initiatives are designed to meet the critical needs of this vital industry, but also to cultivate the leaders who can navigate and transform the healthcare landscape. Today's conference is going to delve into some really critical areas, providing insights into the latest trends and some of the developments that are shaping healthcare. We're going to explore the integration of cutting-edge technology, AI, going to look at new models of patient care, try and grapple with the evolving regulatory landscape and financial constraints. Each session is designed to deepen your understanding and also to spark some meaningful conversation among you. The challenges and the changes that are buffeting us all about right now are dare I say, unprecedented. Now that is a word I think we all hoped we'd retire after COVID, right? But it isn't precisely in times like this, when uncertainty is high, when challenges are steep, that the true value of this kind of communal get-together, having a place in your own backyard where leaders can come together, share ideas, share best practice, learn from each other, support and inspire each other is so, so vital. We are really grateful and proud here at Opus, here at the University of St. Thomas, to be your backyard gathering place. We welcome each and every one of you here and hope this is a fabulous day. And kudos to you for carving out this day in busy lives, to come together, to learn, to grow, to leave inspired. I have to thank many, many people who have helped us put this big event together year after year. I definitely want to thank our fabulous team at the St. Thomas Opus College of Business Healthcare MBA. Kudos to all of them and to that committee. Thank you to our sponsors, Frederickson, Clifton Allen Larson, Bank of America, and Tegria. So grateful to all of you for making these kind of events happen, which are so important for feeding our souls and our brains, right? And now it is my great pleasure to return the favor of introduction back to Dr. Abby Miller. Dr. Miller is the Chief Medical Officer for Commercial Business at United Healthcare. She received her medical degree from the University of Minnesota and is board certified in family business, I'm Opus, right? Family medicine. She is also a volunteer nonprofit board director for the Children's Cancer Research Fund and was just named to the Twin Cities Business Journal's 100 People to Know in 2025. And look at this, fresh off the presses and you get to know her. One of our top 100. She just so happens to also be someone we are proud to claim as an adjunct professor in our healthcare MBA program, and a proud alum of the University of St. Thomas Healthcare MBA. So please join me in welcoming back Dr. Abby Miller, who will be your MC today. And thank you all for being here.
Thank you very much, Dean Dunham, for that wonderful introduction. So again, everyone, thank you very much for being here today. I always look forward to doing this every year. I just really enjoy this. It sort of fills my soul, so to speak. So I'll just kind of go over a few housekeeping items for everyone. So as people know, there are some cards on your tables with QR codes. The QR codes will lead you to the detailed agenda. That QR code also will be where you can take questions. So we're taking audience questions again through the Poll Everywhere app. So access is found on those cards on that QR code. High-level schedule for today, we'll have 3 sessions with breaks and networking this morning. We'll have lunch at about 11:45 and then 3 sessions in the afternoon. Our plan is to end right around 3:45 today. Again, I'm going to just thank our Future of Healthcare conference planners who have worked diligently throughout this year to put this excellent program together for all of us. I would also, again, like to thank our sponsors, Bank of America, Clifton Larson Allen, Frederickson, Tegria, and obviously the Opus College of Business St. Thomas Healthcare MBA program. A couple other housekeeping items. If you need a quiet space throughout the day, we have reserved rooms 342 and 343 just down the hall. Restrooms also can be accessed by exiting the double doors, taking your first right. And while you're here in the conference room, please make sure to have your phones on silent. All right, housekeeping items done. Now I am very pleased to kick off our 17th annual conference. We're going to hear about how healthcare leaders are navigating new challenges. Moderator for this panel today is Dr. John Cumming. Dr. Cumming is a healthcare executive with over 25 years of clinical and leadership experience. He's worked to improve the value of healthcare delivery through efficiency, quality, and financial sustainability. Dr. Cumming spent his clinical career as a general and critical care surgeon with a specialty interest in emergency general surgery. His executive experience includes serving Hennepin Healthcare System as the president of the medical staff and vice president of medical affairs for several years, followed by board appointment to the role of system CEO and board member. He has held regional and national leadership roles in trauma and critical care delivery. Dr. Cumming holds additional positions as principal, QC Healthcare Consultings, and trustee of a regional healthcare system. He is also a proud graduate and adjunct faculty at the University of St. Thomas Healthcare MBA program. Please welcome Dr. John Cumming.
Join us as well so that they can kind of assemble while I'm getting settled in here. Thank you and good morning. Yep. So as Abby mentioned, my name is John Cumming and I'm adjunct faculty member in the Opus College of Business. And I will be moderating, I'm going to stand. I'll be moderating the CEO panel discussion this morning. It's funny, I had scribbled down some notes and the usual format was that the podium was down here and the seats were on the right. So my notes say from my far right. Well, it's now my far left. So I'll just briefly introduce our panelists and then I'm going to have a couple of comments and then I'm going to ask them to say a few introductory comments on their own behalf. But from my far left, we are joined by Lisa Shannon, who is CEO of Allina Health. Who do we have? We have Ashok Rai, Dr. Ashok Rai with Previa Health, and Jennifer DeCabellis with Hennepin Healthcare System, and Trevor Sawalish, who's CEO of North Memorial Health. So again, I will have them, have their open introductory remarks in just a minute. But it is an honor and privilege to moderate this session entitled Leadership for New Challenges. And the reason I say it's an honor and privilege is because this is an outstanding opportunity for all of you to engage through the questions that you will submit with and to learn from 4 of the region's top healthcare leaders. During this session, each of the CEOs will share their individual perspective on current challenges and future opportunities in a direct conversation with you. The questions that you submit will direct that conversation. Each year, whether I'm in the audience or up here at the podium, I gain several key takeaways from this part of the conference, and I'm confident that the insights and experiences shared by our esteemed panelists will provide valuable perspectives on the future of healthcare. Their collective wisdom and forward-thinking approaches will undoubtedly inspire us to envision and work towards a healthcare system that is not only resilient, but also adaptive to ever-evolving needs of our community. So thank you once again for being here and engaging in this important panel discussion. I would ask that you start submitting questions right away because they're going to go through a curating process where they'll be collated by my colleagues here to the right and then submitted up to the podium to engage the panelists in the conversation. So again, please get your questions in early. So with no further ado, I will now ask each of our CEO panelists to provide some introductory remarks. And with the final remark that you make being, what brings you joy or energizes you to get up every day and head in and meet the challenges that you face in a complex healthcare system? So what is it that really uplifts you and brings you joy as well? So some brief introductory remarks, and I guess we'll start with Lisa Shannon from Allina.
Yeah, good morning, everyone. And it's terrific to see so many people gathered to talk about an industry that I really, really care about. And so the last question will be easy. Lisa Shannon, I've been at Allina Health now for almost 8 years, in the community actually for almost 8 years. And in this role, going into my 4th year, I'm a dietitian by training, worked on a burn and trauma team. And one of the things that I'll just pull through in my remarks is I believe deeply that the best care for patients in our community is delivered by equal people with different roles, all working together for the best outcome of our patients. And so at Allina, I have the great honor to lead a system that has almost 28,000 care team members, 12 hospitals throughout Minnesota, Western Wisconsin. We have a couple hundred ambulatory locations. Telehealth, like my colleagues here on stage, is a huge part of how we see care being delivered at home and in the community. And I'm really looking forward to today's conversation. I guess what brings me joy, maybe I would offer that I've only been in healthcare. That's been my whole career. And as I think about the work that we get to do, I can't think of another industry where you get to lead with some amazing individuals who are really devoted to health, that are devoted to communities. And in that leadership role, you're also shaping services for the people you love most in your life who use your services as well. You yourself use them at really vulnerable times, and the people you care about use them. So that, to me, that mission and purpose of why we do what we do is a good reason to wake up every day. Thank you.
Right.
Morning, everyone. My name is Ashok Rai. I'm the president and CEO of Prevea Health, which is the largest multi-specialty group in Northeast Wisconsin, headquartered in Green Bay. But don't worry, I'm not a Packer fan. I'm actually from Detroit, so I'm a Lions fan, and I think we beat you all twice. So we're uniquely structured where 50% of our company is actually owned by its doctors, myself included. And the other 50% of our common stock is owned by our hospital partners, HSHS. So it's a true 50-50 partnership. Been around since 1996 and continue to maintain that 50-50, which is pretty unique in the country. What brings me joy is on top of being the president and CEO, I'm still a practicing physician. So seeing patients every day, understanding what my partners go through every day. I yell at Epic just as much as they do. Have some of the same frustrations, but also the ultimate joy was taking, the ultimate honor was taking the Hippocratic Oath, and to be able to live it in two distinct ways, both as a leader and as a practicing physician, brings me the most joy.
Good morning. Jennifer DiCibellis, CEO for Hennepin Healthcare System. Appreciate being here today. I have been at Hennepin Healthcare. I came actually behind Dr. Cumming. He was the one that gave me the gracious baton and have not regretted a day ever since.
Oh, wait, can I interrupt for 1 second? Literally 2 weeks before the COVID pandemic hit, Jennifer was in the hot seat.
So you know which of us is smarter than the other one? Because he knew it's time, and I went in thinking, yeah, I've got this great 90-day plan, and we threw it out the door, and we've been running ever since. If you don't know, Hennepin Healthcare, so yes, Dr. Cumming, I did start 2 weeks before COVID. We were shutting down the hospital. 4 months later, the murder of George Floyd, we were the responding hospital. Civil unrest across Minneapolis, we were the responding hospitals. It's been a wild ride, and yet I wouldn't change a day. It really has been Hennepin Healthcare, if you don't know, is an academic medical center, safety net serving the entire state of Minnesota and a lot of areas. We serve the entire region for some of our specialty around burn, hyperbaric, traumatic brain injury. And that academic medical center is so important because it is about teaching. And right now, more than ever, we need to transform healthcare. We need to teach differently. We need to make sure that Minnesota goes from being a top healthcare state for some to a top healthcare state for everyone. And that transformation is in the roots of the systemic issues we've got in healthcare that truly need to change. What brings me joy is showing up every day with 7,000 team members that are doing that work, that are rolling up their sleeves, having the hard conversations, having the courageous conversations, figuring out alongside our patient population what needs to be different so that healthcare is delivered that is meaningful and impactful and driving the health outcomes that they need and deserve. And that keeps me going. So on tough days, that's what I do. I jump on an ambulance, I go out, pop into a clinic, I walk the hallways, walk the floors, and hear from patients that lives are better. Because we show up every day and we need to keep showing up and figuring it out.
All right. Good morning. Travis Wallace. I'm CEO of North Memorial. I have had the privilege of being there for the last 2 years. If you don't know much about North, we are, I like to call us the smallest of the big. We're about $1.3 billion system, 2 hospitals, very different hospitals. One is a level 1 trauma center that really, I think, with Hennepin Health, serves a really unique need in terms of serving Minneapolis and the greater Hennepin County. We also have Maple Grove Hospital, which I like to say is births a new Minnesota town every single year, 5,200 births in that hospital. So really a unique facility in that regard. We also have clinics, about 20 clinics, and a very large EMS system, including about 150 ambulances and 9 helicopters that serve all of Minnesota and into the region. I have also had the privilege of serving many other health systems in the region, including Children's of Minnesota for 8 years, and in Wisconsin at a integrated health system that has a lot of the same dynamics that Dr. Rye described. So had a lot of different experiences through healthcare and seen it over 25 years. What brings me joy is, I think, a very similar theme. I mean, everybody's job probably has frustrations every single day. But I get to come to work knowing that what we do makes a difference for people. And that's, going to probably be a theme in some of the things that we talk about here today is that's a real privilege. Being able to do something that, we could make stoves, we could make cars. Those are great things, but we get to actually make a difference in people's lives every day. So,
thank you very much. So, we're going to get started with the questions. I've already got a few, but I'm going to exert moderator privilege and ask the first question. But it actually dovetails very nicely with a question I've already received. But basically, to the panelists, during the pandemic and immediately following, maintaining a robust and healthy workforce was the #1 challenge of healthcare leaders across the country. In the most recent annual survey by the American College of Healthcare Executives of over 1,200 hospital or system CEOs, workforce and financial challenges were tied as the #1 concern. So basically, workforce challenges continue to this day after the pandemic. And the question we received from the audience dovetails very nicely, and it says, how are you changing your service models to combat an ever-tightening talent pool and increase of costs? And basically, my question, along with that, is just provide us with your perspective on meeting the needs of the community with your current workforce, and what are those challenges you're having, and what is your vision for addressing those challenges? Again, this is going to be kind of a conversational thing, so any one of the CEOs can kind of take it, and we'll go from there. Lisa?
Well, maybe I'll add to the context, and then Trevor said give him all the hard questions, so we'll do that. I'll add to the context and my perspective. So first of all, we know that as a country today, 1 out of 8 people who are employed, work in healthcare. That's what we know today. If we fast, so we're so glad you're all here. And if you're contemplating healthcare, the answer is yes. Just that's the answer. Then as you fast forward and look out 10 years with the aging of our communities and the disease burden that accompanies that in cardiovascular care and cancer and neurosciences and the like, we know that if we did nothing different and we just kept doing what we do the way we do it, as our workforce retires and transitions, which happened at a much faster clip following COVID, and we're still seeing it. It has to be our number one concern. And the aging and the needs of our communities, to meet those needs 10 years from now, 3 out of every 4 people that enter the workforce would have to go into healthcare. That's never going to happen. Some people might choose academics. Some people might choose other industries. So as we think about the gravity of the issue that we're facing, we have to find new ways to care. As a dietitian, I would say we have to find new ways of keeping people well. We have to find new ways of earlier detection, of prevention. It's both a supply issue and a demand issue. And when I think about keeping people well, I think about our healthcare workforce. And I think about the burdensome and joyful jobs that they do really every single day. And I think about how do we make sure that we as leaders are all thinking about the health and well-being of our workforce, whether it's their safety, the safety of their patients, whether it's their own. We know what keeps us well, and unfortunately, it hasn't changed too much over time. And so how we know that it really does matter that people have access to healthy food, that they can move their body or engage in some physical movement according to their capability, and rest and restoration. And for our healthcare workers, it is very much an environment. I know many of my colleagues are often the last to care for their own health. So we are going to have to do 2 things. We're going to have to work on the demand and the well-being of our people, and we're going to have to bring new technology in. And I know we're going to talk more about that today. There are new ways that actually I'm quite excited for all my career over 30 years. I think we're at the precipice of real change in how we take care of patients from an innovation standpoint.
I can just add, more of a granular solutions that we're working on as an organization. I mean, since I got my job or started at Purveyor in 2001, every strategic retreat I'd ever been to, every governance retreat, you can boil down all the fun language that we use, but it really was around patient acquisition. How much are we going to spend on marketing? How are we going to grow revenue streams? It was really around patient acquisition. I would say that the theme is definitely flipped. We're still trying to acquire patients and market share, and all of us measure that, but there's just as much focus right now, if not more focus, on talent acquisition as there is on patient acquisition. So what we're doing as an organization, and I'll just pick on doctors right now because I am one, and talent acquisition at the physician level for us is revenue. It's a business crisis. Without physicians, we're not going to be able to see patients, generate revenue, keep the business going. So the 2 areas that we're focused on right now is 1, having our own AAA farm team. So we've partnered with local med school and started our own residency program in family practice as an example of, well, let's train our own. Because we don't have an academic medical center in our area, we decided to become a mini version of one. So directly training our own. Now, are we going to hire all of them? I wish, but that's not a reality. But if we hire one out of every graduating class, the ROI is actually pretty significant for us on the investment we made. And the second thing is, and to your point, we're not going to get enough talent out of the U.S. population. It's just not going to happen. It's just not available. So we're working with our legislature and our licensing boards to start bringing in physicians who have done a residency outside of the country, who have practiced for, say, 5 years. I don't know where the legislature is going to land on that. It's between 2 to 5 years, and allow them to have a provisional license in the state of Wisconsin without having to repeat their residency. So they still have to come in, take their USMLEs, take their ECFMG, get a visa, which that's going to be interesting, but not having to retrain. So Dr. Pritchard, our chief medical officer, is in the crowd right now. As soon as this passes, we're going to move to Toronto and start recruiting. Because, hey, the weather in Green Bay and Minneapolis isn't great, but let's tell them they can move south. To us. So it's an opportunity to recruit to a different climate. So that's, two distinct examples of what we're doing around talent acquisition that specifically we've seen and traced to an ROI that it makes sense for us to put money forward to solve a problem that we all know we have.
I think a lot of strategies are the same across the board. I would start with just talking a little bit about the wellness, because we heard that coming out of COVID immediately, and it hasn't changed. Making sure we're investing in our team members' stability, safety, wellness is essential. So we do a lot of work around, it's hard to be a caregiver all day long, and it's hard to go home and be a caregiver as well. It is how do we take care of the caregivers, and how do we make sure we're leaning in together? And some of that is culture. I will say we have a great culture of tapping people out. We've got some of our team members here as well. And I go, it's not unusual for somebody to tap me out and to say, go take a break. We know you're holding a lot. And for me to be able to come back more refreshed, revitalized, resiliency, and then be able to see another leader to say, I want to check in on you. Let's tap you out, like take a break. There is critical response efforts that are essential. So our ambulances, as one example, have an app and an ability to pull over, to check out of runs, not grab their next run, but to say what I just went through with a family, with a child, with a response in the community was awful, and I need somebody to talk through, to debrief. Instead of carrying that burden, how do we do that resiliency training in the moment, in the field, do it together and do it constantly? We have a critical intervention team that can also be telemedic. It's an app on our phones that we can just call in and say, this team over here needs some support, and let's deploy. So I think in the workforce, what we're finding is our need to actually hire. We have a mental health team dedicated to our residents and to our internal team members. It's how do you make sure that the caregivers have what they need every single day? And then I would say from a larger workforce perspective, we've got incredible people. How do we keep them? Some of that is that well-being. Some of it is the flexibility. It's how do we create career pathways for them? And then the pathways that we're creating in the community. How do we have more people interested in learning about healthcare before they've had to do 4, 6, 8, 10 years of formal education? This weekend, we have on Saturday a talent garden event. What that is we are reaching into 12 to 18-year-olds from underrepresented communities in healthcare, and we're bringing a couple hundred in on a Saturday. They get a white coat, they get experience, but they come in and they do Sim Center robotic surgery. They deliver a baby. They do blood draws. They get to do ultrasounds. We just immerse them in the excitement of healthcare to create a whole generation that's interested in coming in. We've also found we need to pay people for training. So our paramedics, and I know you have a large system as well, our paramedics, we train them to come in to learn to be EMRs, EMTs, move into paramedics. They've got a livable wage while they get into the careers. All of that is creating that workforce for the future. And then finally, I would say, and the work we do has to change. It is creating additional layers in those teams and training together. So as we bring in more physicians, not having those physicians training in isolation, but having them training next to respiratory therapists, to nurses, to PT, to OT, and really creating that team environment where we've got lots of people progressing care versus the top of that tier having to do all the work. So a lot of work ahead of us.
We don't have any workforce or financial challenges. No.
Thank you.
If any of you know the North story, you know how silly that is. I don't like being last, by the way, but really great comments. I think we're doing a lot of the same things. And I definitely want to echo Jennifer's comments about the strategies of bringing people who typically have not seen themselves in the workforce for healthcare into the workforce for healthcare. There's a lot that we need to do to really make sure that we reflect the people that we care for in the workforce that we have. And I think that's a great opportunity that we've not tapped as well as we could have. The one thing that I would add is waste is workforce, right? We have to just be good at using every minute of our caregivers' time efficiently and effectively, and really truly listen to them in what we do as health systems. We have to make sure they feel valued. We have to make sure they feel the autonomy that they've trained for, and we have to be respectful that every single moment we spend on wasteful activities is a misuse of a workforce we don't have. It's just as an example, a year ago, we did a study of patients that were stuck in our hospitals for over 20 days beyond when they should have been discharged for all kinds of reasons. It was 1,600 patient days for a system of our size. That's huge. That's 1,600 days of care that took away from what those workforce could have been doing for other people. So we really have to just make sure that we're doing things efficiently, we're doing things effectively, and just work the process that is healthcare. The second thing that I would add is I honestly feel we don't do a good job in the narrative of healthcare right now. If you're a young person hearing the stories of healthcare, it's not that great. Why would you want to go into it? And I think we have to do a better job, especially at the leadership level, of just reminding people how cool this job is. Every single day, you get to come in and make a difference in somebody's life. And somehow, through all of the distractions that we spend time on every single day, we've missed that narrative. We've missed the opportunity to tell that story. So I think one of the things that we really just need to focus on is we're here for patients every single day, 24 hours a day, 7 days a week, 365 days a year. We make a difference every single one of those days. That's pretty cool.
And I would add to that, an opportunity that we saw with nursing school is that we've heard from a lot of young people, I want to be a nurse. Like I have that calling. And there wasn't enough slots to get into the educational positions. The risk is I came across a young person who went and worked for the Mall of America in retail. Not a bad job, but I went, gosh, what a missed opportunity. Come in our walls, we can train you as a healthcare assistant, we can get you the experience, and now what we've got is hopefully a lower failure rate in nursing school as well, because those individuals have been able to work inside our walls, strengthen their application, get to know exactly what they want and whether this is their calling, and then progress on. So I think we've got a lot of ways to get upstream in the workforce as well.
So this is going to be maybe a little tougher topic because the new administration is, that's right. We'll start with
Didn't agree to any of this, but
You said you didn't want to be last.
right. But quite frankly, you'd have to be on some disconnected, trip in Alaska somewhere where you haven't had any contact with the outside world not to know about what's happening in our political arena. And obviously, government and healthcare policy are significant stakeholders and influencers within the healthcare system. That's without a doubt. And I think to try to navigate this in a level way, it's easy to say that there's going to be some changes afoot, and some of those changes have already been put forth, But this will be a difficult kind of conversation or question because it's been such a short time frame, I guess. And so how people are reacting to that, it will be interesting to hear. So a couple of questions, and I'll just read them rather than try to kind of summarize them. But one question was, how does the change in the federal perspective on DEI affect your organizational management and thoughts going forward? With the current political landscape, how are you creating psychological safety within your organization? I think that's pretty important. And what changes will result from the new government structure? Are you proactively addressing these new challenges? And so I guess lumped all together would be basically, what is your organizational, not personal, organizational perspective on kind of what's happening at the federal level, and how are you either digesting or reacting to those changes?
I'll take a stab at that easy question. Yeah, I guess. So first is, again, let's try and separate the signal from the noise, right? I think there's a defined tactic to create a lot of signal and create at the same time a lot of noise. So one of the things that we're really trying to focus on in the organization is let's react to what we have to react to when we have to react to it, because there's a lot of stuff out there in the discussion that isn't quite real yet, isn't quite actionable yet. So we're really just trying to amp up our communication so that we can separate out for folks what is real and what is actionable. We're always going to follow the law. We're always going to meet the regulatory need, but we're not going to compromise our principles, especially when it comes to noise. The second thing that I'll just tackle is the DEI component, and I think it's a direct result of the workforce conversation that we had. Whatever you label it, healthcare needs to do a better job of diversifying our workforce. Because we have to meet the needs of our patients, and our patients are not one background, is not one ethnicity. We need to match the people we care for. The second thing is we do not have the luxury of not welcoming anybody who wants to go into healthcare. And that means that we're going to have a more diverse workforce than we've ever had before. And we have to make sure that we have welcoming environments that respect the fact that everybody brings something different. And there's a few challenges in healthcare right now. We need the difference in thinking to make sure that we can navigate the challenges. So call it DEI, call it whatever you want. We want to create a welcoming environment for our patients. We want to create a welcoming environment for anybody who would choose to go into healthcare. And we want to do what we can to make sure that we've got diversity of thought in solving some of the problems of healthcare. So for us, it's a label to some degree. We can debate the label, but we're not going to change what we have to do in order to make sure that we can take care of patients.
Thank you.
I would say that what we learned early on was don't react in the first 24 hours. Lots getting tied up in court. Catalog it. So we really stood up incident command, which healthcare is really good at, and said, let's get the right people, let's get a process defined, let's capture all the changes and look at what are our short-term things we need to do, what are the long-terms, what are our contingency plans, because some of it is signaling. It'll look totally different by the time it comes out, but we know directionally some areas of focus that we need to have our numbers, our data, our analytics ready, and we need to have our action plans ready for A, B, and C, so that as a system, we're not getting thrown into the crisis when indeed that comes up. The other thing is, how do we change that messaging? To your earlier point about how we message things is really important, to say this is actually an opportunity. We need change in healthcare. So how do we grab this as an opportunity to change the right things? And can we take every angle that we see to say, let's do better in this space? What can we grab that is an open door to get out of some of the rules and regulations that are actually overburdening healthcare beyond any other industry I've ever seen? So there are opportunities we need to watch for in those optimisms. And then I would say on DEI, it's politicizing a term, because I go, if you break it down, I would bet we have a federal leader that diversifies. Let's look at stocks. Let's look at market plays. Diversity is a good thing. Equity is a good thing. Everybody needs health. We saw it in COVID. If some of our community isn't healthy and getting the care they need, it impacts everybody. So how do we take the power back in those terms? How do we double down? This is a work we've always done in healthcare. We are in a caring field, and it is now not a time to back away. It is a time to double down and take back the narrative and take back the language.
I think it's key right now that we also focus on helping our employees. We have 2,400. You all have much more than we do in navigating this and kind of discerning the noise and understanding it. Great example with one of the executive orders around birthright citizenship. We have physicians who are here on H-1 and J-1 visas and other employees that have had children born or are pregnant. And that EO created a lot of consternation. We have an immigration attorney on retainer. We made sure we got in front of that right away, had meetings with them so they understood they're not at risk. I think it's really important to communicate and help our people, our employees, our family members sort through the noise, those who are providing gender affirming care. You know, what's going to happen, what's really going to happen, what you can continue to do every single day. And making sure they understand that and separating it out. So having our legal teams, every time there's an EO, dissect it, both internal and external legal teams, and then being very transparent. So I have a monthly town hall. I've done this since COVID with all of our employees and don't hide behind the fact that the EOs are creating tension amongst our people and our patients and just communicating and helping them sort through the noise. That's, I think, from a leadership perspective, the best thing we can do right now, as well as plan and understand that we need change, but really help our people from CNAs all the way to MDs understand what's actually happening versus what whatever news station you might watch that day says is happening.
Maybe I would just add a couple things, and I agree with everything that's been said. This, from my perspective, is a time to really double down on who we are, who we serve, how we serve, the values. We sit here at St. Thomas, a values-driven organization. We are all values-driven organizations. It's hard, and there's a lot of fear for a lot of people right now. Can we provide in our work environment and in our healing spaces for care a place where it's a little less fearful, where we have the welcoming, focused environment? The thing we know about healthcare is that mistakes cause harm. The mistakes that most often happen under distraction. And so maintaining an environment that is really safe for speak up and psychological safety. If Jennifer used the word, sometimes you have to tap out. If you've lost a patient, there's been another critical incident. Well, sometimes it's the overwhelm of the incoming. And with 28,000 employees, I have a range of care team members' perspectives, and we need to honor all of them. But what we won't vary from is the values, how we serve, who we serve. And the last thing that was really mentioned, this is a time to pace ourselves, to be very patient, to not stray from what's really important in the mission, and to be in a mission-driven environment and to say, okay, let's look at that and remind ourselves how very vital it is. And nothing takes away from, it's hard for a lot of people right now, and there's a lot of fear, and we should listen and validate that while we help them get focused on what we get to do every day.
Thank you. That was, tough question, right? So, but thank you for your perspective on that. We have a group within the Opus College of Business that meets every month. We discuss kind of current trends and issues within the healthcare sector. And it seems this past year that we discussed a lot about emerging technology and in particular AI. And so the question that I ask, and a couple of folks have already forwarded questions on technology and in particular AI. as you look out on the horizon for your organization, how is emerging technology shaping your priorities, conversations, and even decisions, and maybe even with your boards on how you're looking? I think Lisa mentioned that significant change is hopefully around the corner, much needed change. And I think you're right that it will be driven by technology and how we provide services to those communities we serve. How is technology being thought of in your organization? And again, how is it shaping those conversations? So again, anyone can go first. Ashok?
Yeah, I'll go in the middle this time. All right. I think we look at it in a couple different buckets. We talked about our workforce needs, our talent acquisition needs, and let's just be honest. We can keep focusing on that. We'll never find enough talent to take care of the future population. So we look at technology in one bucket as labor replacement, and that sometimes gets mischaracterized as AI is going to take over the doctor's job or take over the nurse's job. No, we just don't have enough of X, Y, or Z. So we have to look at technology from a labor replacement standpoint. Where does it make sense? Where can it be more universal? The other is, I know it's no different in Minnesota, but in Wisconsin, the significant collapse of rural healthcare. We just don't have enough labor and the ability to provide really good care in the rural environment. So how do we leverage technology in the rural environment? And a lot of that is, obviously done through telehealth technologies, but now robotic technology coming forward, and AI assisted robotic technology to provide rural healthcare is another significant area of focus. And I'd say the biggest area of investment right now for tech for us is how's it making the physician or the provider's job easier or better. So like many, we've launched AI in the exam room for documentation needs. We have AI going through our Epic in-basket and creating responses. And about 40% of those times, those responses are good. 60% of the time, they're not. But hey, it's 40% less in the in-basket to worry about. So, we've all purchased EMRs, and we've all made, I think at this level, made Judy a very wealthy woman at Epic. But how do we actually leverage that technology now to make things better versus making it more labor and less satisfying at the provider and physician level? So, we look at tech, and I'd say those three specific buckets right now, how we analyze it. And it is a focus of every single board retreat. And I would say there isn't a board meeting where we're not talking about something around tech and how to make life better.
And I would add to that I think there's a fast pace of coming through with what are some of the tasks that don't take that higher level functioning that we can make easier. And there's a lot of fear in loss of jobs. And we keep reinforcing to people, like, trust me, we got so much more for you to do. And we want you to do the stuff that's the really meaningful work. And we want to take some of the more mundane tasks out of your workday. But there is real fear of enough instability in healthcare, and will I have a job? I will share, like, I've had conversations with our coders, and part of that is it's an algorithm. If you meet this criteria, well, technology is getting really smart about how do you look through records and say, does it meet this algorithm? That's the right work for us to do. Where I need our coders focused is on the higher end thing of there's a complex case where that algorithm isn't going to work, and I need your person power to dig in. It's the stuff that we often don't get to in healthcare because we're so busy doing the more mundane. So I think there's some significant opportunities in that business flow to leverage AI. Things like our ambulances, programming in, if we think of frequent calls that we get, the ability for a paramedic to have top of mind, easy information at their fingertips that says what's going on with this individual the last 10 times we responded. Really labor intensive to read through that. AI can pull out the key, here's the things we're seeing, here's the responses we've done, and get them real-time information. That saves lives. So it is figuring out along that continuum, what do we do? And then some of that is the diagnostic. That's pretty incredible. You don't ever want to replace a trained clinician in diagnosing, but the things that we can see in images right now, that the trained eye might not pick up, and it says, just look over here, zero in over here, is incredible. All of that means we can save lives, hopefully sooner, diagnose sooner, get less people in acute care. And I just think there's incredible opportunities. We do need to embrace it, and we need to watch for when AI doesn't get it right to your 40% and not run too fast without double checking.
I want to build on the detection part of this and the change part of it. So when folks say, well, healthcare really can't change, education can't change, we changed. 2020 was a year of rapid, immediate change to meet the needs of our students and to meet the needs of our patients. Literally overnight, we made material changes because the need was there and the capability was present. So I do think that a key part of our philosophy and my personal philosophy for the bringing in technology that will improve lives of our caregivers and our patients is to make sure it's clinically led. We are detecting cancers faster than ever before. We're getting ready to have some of the first incision-less surgery here in the Twin Cities to remove tumors without incision. We have the capability now for patients in rural facilities, and I'll just use plain language, to essentially put a headband on them to detect if they are seizing, to give them a treatment plan so that the ED physician in a rural community doesn't have to, and that family doesn't have to bring that patient in for higher level care. We need all of that. People want to have care in their communities. And when the clinicians lead it and they're excited about it, the notion that this is taking jobs away, it's taking less meaningful work away and allowing us to use these precious and not enough resource in other areas. So I'm quite excited about it. I also think that for our physicians, the things you mentioned, and our providers broadly, being able to have ambient listening technology to help them with their medical records and their incoming notes in their MyChart, we went from 1 million messages a year from our patients to 5 million in 1 year. 1 year that happened. So we have to find ways, and it can be really career changing for many of our providers. I had a doc tell me, I got home for dinner and took my 16-year-old out to find her first car. I've never been able to do that before the new technology in the exam room. We have to do that.
Yeah, and I would just add, I think this dynamic of how do we get technology into a fundamentally human business is probably the key thing we've really been focused on. I feel there's an epidemic of underrealized benefit from a lot of technology that we have implemented. At North, we just eliminated our chief information officer position, which was the thing of the month. That's, are you crazy? Maybe. But the reason that we did that was because our technology department, the people that focus on that 24 hours a day, 7 days a week, felt passionately about getting this out there. But it wasn't fully adopted. It wasn't seen as a benefit more often than not to our clinicians, the people doing the work. And the lack of alignment between what our clinical teams were wanting to do and our operational teams are wanting to do and what the agenda of the IT team was fundamental and profound. So we eliminated that position and we rolled the different parts of technology into our business, so just for the sake of making sure that whatever we deploy ultimately is adopted, is bringing benefit for all the money that we're going to spend on it, and at the end of the day is something that is aiding our clinicians and not in any way getting in their way.
Thank you. By the way, thanks for all these great questions. It's very clear that the audience is hungry for some challenging conversations. So, and I have to figure out how to phrase this up. But I mean, if you look at and I'm sure most people in the room have seen this OECD data, right? That shows that our healthcare expenditure in the U.S., right? U.S. healthcare expenditure far outstrips any of the other OECD countries, right? But yet we lag in quality outcomes, right? And so quality and longevity and infant mortality and all those things, we're not the leader in that, right? And so it gets down to value and our healthcare system is incredibly complex, really, really difficult to navigate when you think about other developed countries and how they access healthcare. And as a physician, I'm getting to the age where I need to access healthcare a little bit. And even as a practicing surgeon, I'm challenged at times navigating our healthcare system and how it goes, and it gets incredibly frustrating. And so you can imagine someone that doesn't have that insight into healthcare. And how do we've been talking this morning a lot about challenges for your healthcare systems and providing the care, right? But how do we address the frustrations that our patients are experiencing? And how do we keep the patient at the center of what it is we're trying to accomplish? There's some rather significant examples lately of how patient frustrations have boiled over, but we each have our own organizational examples of that, about the frustrations that people are feeling with the healthcare system. And so how do we address that part going forward? How do we engage the communities we serve in truly serving them, and making their lives easier when they have a healthcare issue that needs to be addressed?
I would say, Dr. Cumming, one of the concerns I have is that we're nibbling around the edges. If I just even look at what's happening at the legislature, at the state, we're trying to change healthcare in these itty bitty things. And access is huge. Access is important. And what gets in the way is a lot of things. We need more money getting to the actual provision of care. So we have all these layers and complexities that need to get removed. We have a system that was built when access used to be roadblocked, where we had barriers, prior authorizations, anything that means we were gatekeeping access to care. Those days are gone. You're not seeing healthcare systems, or should be gone, I should say. You're not seeing healthcare systems over-serving right now because we can't even get people in. The demand is outpacing the capacity. So what do we do to get rid of that gatekeeping? If I just think of the number of team members that do prior authorizations and chase some of that, and if we could take that and say, you know what, we're not overdoing too many radiology exams. We're not doing too many surgeries. We're doing the stuff that we probably should have done years before because of the delays and the wait times. So get that administrative waste out of the way. But that's going to take big, bold moves fast in healthcare to make sure we turn the dime and say we need access to be our focus and not all the rules and regulations that gatekeep people from care.
If you think about comparing us to the rest of the world, I mean, our business model is purely based on bad things happening to good people. We don't get paid unless bad things happen to good people. That's how the infrastructure is set up, and the worse the bad thing is, the more we get paid. When I would admit a patient to the intensive care unit, I got paid X. Their blood pressures dipped, and I needed to put a line in. I got paid more. If I had to tube them, I got paid even more. I mean, we get paid more and more and more when bad things happen to good people, and our entire business model is really based on that. So till that changes, I don't think our ability to change it is going to be there. Site of service transformation is something we're focused on. There's how many colonoscopies happen inside a hospital and why? They really shouldn't, from a cost perspective, be happening there, except for the ones we have to do inpatient post-op for a colorectal surgery. You really shouldn't be putting a scope in a patient in a hospital. Yet, I'd say more than 75% are in our market all happen inside hospitals. We're the only ones who don't do it inside of a hospital. So, site of service transformation needs to be incentivized, and right now it isn't, because all that's incentivized right now is where can I get paid most to take care of this person? And while that economic driver is there, And let's just be honest, we need that economic driver because we have to pay for the labor, and the labor is costing us more, and everything is costing us more. So till we can solve around that and fundamentally change how we get paid, I don't think our worldwide ranking is ever going to change because we're going to keep spending more. And yeah, quality is never going to change because the incentive isn't there to change it. As far as navigation goes, used to be a big deal to me. Now it's a critical thing to me because we came out of the pandemic, April of 2022. I went from bedside to bed, needing open heart surgery all of a sudden, and got diagnosed with diabetes the first real month coming out of the pandemic. Had to come to your great state because the surgery wasn't done in Wisconsin, so I had to come to one of your institutions, not here up on stage, to have it done. And I will tell you, there's nothing more transformational than being a healthcare leader and a physician than all of a sudden becoming a chronic disease patient. And that to me, so navigation's a huge deal to us. Because when you're a health system CEO, you get to text the other health system CEO and say, hey, I need to get this done today. And I was able to do that. Our patients can't do that. So navigation is a huge component. So we're investing a lot in care navigators. We don't believe if a woman finds a lump that they should have to wait more than 24 hours for a diagnostic test, including mammogram, ultrasound, and wait more than 48 hours for the results. So we have an easy button, for lack of better words, if you find a lump. And we're trying to get more and more of that navigation out there on the front end, rather than just once I get diagnosed with cancer.
Yeah, I would lift up the comment. People use language like healthcare is broken. I actually don't agree with that language. I think we have a lot of unbelievably exceptional healthcare. We have a fundamentally broken business model, to your point. We have an incentive structure that's broken. And when you look at our models of care, they have been built over decades and decades on a model that has a lot of middle layers to it. And if we put on stage a $100 bill and sliced who got what from it, I won't do that and I won't get too deep into it. But what I would say is it's not any of us here on stage. Let me just say that. And when you look at where the funding mechanisms are actually going and what they're incentivizing at a national level, I have the great honor of being on the American Hospital Association board. And what's really clear to me is the complexity of the industry with a broken incentive structure, with a legislature that has turnover and term limits and a lot of community priorities. We are going to have to spend more and more time in public policy and education and in fundamentally creating systems that actually prevent disease and look for incentive structures that really align there. When the most important vital sign to somebody's health is actually their zip code, that's a problem. And so how do we get after those social determinant of health issues? And it is going to be complex in collaboration, and no one of us can do it alone. But I am optimistic that we can, between technology, we have to change. We're at a 2020 mark that says, COVID forced our change. We're pretty close to that for the business model right now. And in many communities with rural hospitals closing, they're way beyond it. So
The only thing I would add is I feel like the entire healthcare industry is a bunch of toddlers doing parallel play. If you look at providers, payers, the government, any other sector, we're all trying to solve this thing together. And as a result, we're pointing resources at each other, just fighting each other. The government puts in new regulations that raises our cost. Payers put in new prior authorization work that raises our cost. We have some super duper bright idea that raises other people's costs. I do think that between providers, payers, the government, and ultimately the business community, we've got to get together and solve some of these problems more fundamentally. At the end of the day, the business community, including many of us who are self-insured, are paying the bills for the dysfunction here. There is a tax that nobody likes to talk about on small businesses, on individuals, in order to pay for the fact that Medicare and Medicaid don't cover the cost of the care that we deliver. That's a tax. I would love for people to start calling it a tax, because that's truly what it is. And that doesn't mean that anybody's doing the wrong thing, but it does mean that we need to get together. We've been working with a lot of our payers after the Change Healthcare crisis that we had last year. We had claims that were getting paid in 2 days because cash flow was a huge issue. And I reached out to several of our payers and I said, if you can pay claims in 2 days after this crisis, why do we have hundreds of people pointed at each other, wasting each other's time, making this problem worse? So I do think, I don't know exactly how you do that, but I do think it's not going to get solved until we stop the parallel play toddler mentality here.
I mean, not to kind of keep belaboring this, but I was having a conversation before the conference with some colleagues, and we were talking about this, and this is not a plug for the book, by the way, but it kind of generated the conversation, and that is that, like you said, Trevor, it's the stakeholders within the sector that are all kind of like blocking out and doing whatever and positioning themselves within there. But is the change going to be driven from the outside of those stakeholders, from outside forces bringing in? If you look at, Lisa brought up the pandemic, right? Look how rapidly change occurred in the setting of the pandemic. And so it makes you wonder if, the frustrations and things that are happening with the consumers of healthcare, right? If there may be change external that these stakeholders must respond to, that eventually is going to drive that change. And I'm just throwing that out there. I don't know if it's a question or a comment, but I don't know if you want.
Yeah, if I could, one of the things that I would add to what Trevor said and your comments, the business community, we are the biggest employers in most of our communities. 50,000 plus covered lives at Alina with our 28,000 employee workforce. Our number one variance in our financials last year was our employee benefit cost. So when a health system can't afford health care, we have a problem. And so I think it starts, I think it's a both and. I don't think it's either or. I think it starts internally. And with many of my colleagues, I say, why aren't we modeling what we expect other employers to model? Why don't we find ways to get upstream and make sure that we are changing what we can change in our self-insured plans, and then that ripple leads to it is going to take our employers, it's going to take us, and it will take these incentives, particularly with the middle processes that are in place, of where the funds flow is actually going, has to have really structural change.
And I would add the time is now. We're hitting a crisis. We're seeing rural Minnesota really struggling and shutting down services. More comes in. The services that get shut down are the services that are underwater because they don't cover your costs. Well, as a safety net hospital, we pick some of that up. It puts us further and further underwater as well. And you're just seeing the crisis coming. So like COVID, where we moved really fast as healthcare, I do think the crisis is going to push us to say we got to get together and rethink how we rebuild healthcare so that it works better for the patients we serve.
Thank you. Our region has seen a fair amount of M&A activity, merger and acquisition activity, again, within the region, and not all of them come to be that are proposed. And again, this question comes from the audience, not directed at, again, you or your organization and whether or not you're considering that, but how you view those proposed consolidations within the marketplace. Good, bad, indifferent, what do you see the benefits as, et cetera?
I don't have a necessary answer to any of the specific ones that are out there because there's been interesting development. Every week there's some interesting development, right? But what I would say is clearly when we're struggling as much as we are, scale helps, right? If you have one IT department, one HR department, one function, it does help. So there's solutions in that thought process that bring benefit too. But the one thing that I've worked for very, very large systems. I was part of a system that was 5 states, 45,000 people. And I've worked for a place like North Memorial. And the thing that I just want us all to be cognizant of is M&A and scale does have an implication for meeting the community need. And really focusing on the communities that you serve. I'm proud with the panel that we have here. I know each and every one of them focuses on those communities very, very closely. But it does have an implication, and I guess I just more of a cautionary tale. Scale is a part of the solution, but it is not the answer when it comes to our responsibility to make sure that we're doing everything we can to make sure that our communities and those unique communities are getting what they need.
Yeah, I think about it in capabilities. And so as we think about what happened nationally, again, a little context, from 2020 to 2023, the top 15 health systems in our country grew by 30% in revenue. They're in the, we're shy of 6 billion, 5.5 billion. The average health system in those tops are well north of 30 billion. Now, why? Again, I don't think it's a good or bad. I think it's how do we, in our communities, we need all these health systems to do well. We need them all, those that are here on stage and those that aren't, and our physician colleagues who are innovating new ways. We need all of it. And so how do we ensure that we have partnerships that enable access, that enable capabilities, that if we're all doing that by ourselves, are we going to be able to serve the community as meaningfully? And so I would just offer, as I think about it, I know sometimes it gets difficult for people to hear size, scale, what does it do for cost, et cetera. I think about it through capabilities, and do we do it all separately, or do we come together and figure it out? Because we are nonprofit healthcare in our organization. We're a charitable asset of the community. I don't own Alina. I have this honor of stewarding this resource and making sure we have capability for our community.
I would agree with that, Lisa, and I would add we need systems of care that work, and I'm not talking about M&As and really big systems as a really scrappy system. The benefit is we move really fast. We go vertical and we go horizontal. The negative is we have a shortage in supplies, and I can't call my other hospital and say, can you get some of these supplies over here because we desperately need them. But there is collaboration because we've recently had that, and we've been able to call other hospitals and say, we're serving the same community and we need help right now. We've been able to do that. So I think there is that system of care. And I think when we compete with each other in some areas, it actually is driving our costs up. An example would be pathology labs. Technology is getting bigger and bigger and faster. So if we've got equipment that can run 50,000 more tests at one time than we have in our system, and we're all competing for the same limited expertise of pathology lab, it doesn't make sense anymore. So it's, to me, less about mergers and acquisitions and more about what's the system of care, who does what, how do we partner together? Antitrust laws can make that more challenging of what conversations can you have and not have. But that shared services model of how we work smarter as a community and less about any individual system, I think is essential.
So I don't live in Minnesota. I live obviously in a different area. We're the only healthcare provider that's actually got the same brand over the last 20 years. We're the only one that's not involved in M&A right now in our community. And so I'll give you a doctor's perspective, the voice of the physician, the voice of the people at the bedside in those systems have been eliminated. And you start to see, yes, I understand the need to come together, but they came together for contracting power, which is a reason to come together, a financial reason to come together. Some resources, one IT department, one rev cycle department, completely get that. But the effects of the bedside, we get to see. The level of investment at the bedside has fallen because they got to change the logo. Spending millions of dollars right now on a rebranding campaign. Where do you think those millions come from? They don't come from anywhere else but the bedside in healthcare. New England Journal of Medicine, I think this month or last month, has an article on the effects of private equity on physicians right now in practices and what we're seeing. So it's more than just M&A. It's PE and M&A combined. And what we've seen as a group of doctors in a community where we're still now we're the only locally run health system. That, you think about the third largest area in the state of Wisconsin, second largest media market, only has one locally run health system now. So we're starting to see decisions are just not going well for the physician there. My former board chair, who's now retired, used to say, the farther the decision is from the bedside, the worse the decision will be made. That's why I still practice. And I love practicing. But, the negative effect of M&A isn't seen on the balance sheet. It's, I think, what we see as a group of doctors, we see it at the bedside.
Can I just add a comment about the private equity? I really appreciate you bringing that up. We're seeing this play out in really significant ways, particularly with our physicians who are receiving the promise of these private equity. And private equity isn't bad. It has a place and there's innovation. What we are seeing, though, is those of us that came into healthcare because of our calling to serve patients, it is worsening I would offer, that is actually worsening some of our workforce issues. And so when you see private equity, the data shows when it comes into a physician practice, the most senior partners get the largest, the less senior partners get less. It creates some dissatisfaction and creates some earlier transition of very experienced providers that our communities need. How we do that smartly and well so that we can have innovation and dollars for innovation without dismantling the culture and the workforce priorities, which has been about patient care, is a really hard line to walk.
I would just add, I think private equity, to continue my analogy, that's one more toddler. And it's a toddler that's going to come and take all the best toys and just leave all the rest of the toys for the nonprofit systems that are hard to afford. I mixed the analogy poorly there at the end, but you get the point.
Thank you so much. We are nearing the end of the session. We want to make sure that you have time for kind of a break and then a little bit of networking. So we're scheduled to wrap up at 9:15. If we go over just a few minutes, please bear with us. But I think that what I'd ask each of you to do is kind of maybe just provide us your thoughts on what you're seeing out in the future, out in the landscape, and how you are working with your teams to address what you're seeing. What are the biggest thoughts on your mind at this time? And again, start with anyone kind of like.
Maybe I'll start. I think we've talked a lot about it already. We are going to have new ways of taking care of each other. And some of it's going to be through our phone. We're not going to leave home for certain types of services. Right now, we know other countries that they don't even have lab draw stations out in their community because somebody pulls up to their house, collects their specimen, not surgical, of course, but collects their specimen, takes it away. We are going to see more and more technology, having a more adaptable workforce that feels part of, not having it done to them, but they are actually leading the charge is going to be our responsibility. And the last thing is the incentive models have to change. Zip code cannot be the primary indicator of someone's health and well-being. We have to find a way to be able to really financially fund the areas that are insecurities: food, shelter, safety, and transportation. We have to find ways to really get after that. And I'm actually optimistic that in our communities, Midwest, we have facilities in Wisconsin as well. We are quite collaborative. And if we can come together, can we create a new model?
I think we learned during the pandemic that crisis can drive change faster than anything. You never waste a good crisis. And we learned so much, not that I ever want to have another pandemic again, but we learned so much. The rate of change amongst us, how we practice medicine, how we were able to see patients, and how much we've learned and now deployed within our health systems, we never saw a change to that rate again. We're in crisis again. It's not a pandemic, but we're in a economic crisis. We're in a labor workforce crisis, and the health of America is the worst. Probably it's been. Our life expectancy is going in the wrong direction. So let's not waste this crisis. I mean, it's an exciting time to be in healthcare leadership. We get to try things that we were always told no. You can't do that. You can't do that. We're not going to get paid for that. Well, this is the time to actually implement some of the things that we've dreamt for 10, 20, 30 years because we're in crisis, and we shouldn't waste it.
I agree, and I think it's getting the technology to take care of some of the business work so that we can focus on the human touch, the human caring that people get into healthcare for, and how can we turn that paradigm through the innovations. I think it's an exciting time. I think we'll get there. I do think we need to buckle up a little bit I see toddlers throwing temper tantrums after listening. We've got to get through the bumpy road to what is the vision forward, but I actually do think we'll come out better off as healthcare.
I shouldn't have framed us as provider groups as toddlers, where I think we're the adolescents at least.
Those can be worse sometimes.
It's a fair point. I would look at this internal and external. I don't know how we solve some of these problems, honestly. There's so many different factors to it. Internally, I think what we really just have to focus on is making sure that our teams feel respected and supported through this crisis, because there are a lot of things outside of our control. As much as we'd like to think we can control everything as CEOs, there's so much outside of our control. Internally, we just really need to stay focused on how special our work is and make sure that our workforce feels respected and supported. Externally, I think we've really been focused on telling the story. Starting first with legislators, government officials. It is so complex. Healthcare is so complex. Frankly, people's eyes glaze over within the first 30 seconds of starting to tell some of these stories. As soon as you tell one part of the story, you're in a rabbit hole, and it's tough. But it's worth that investment. People need to understand a bit more about the implications of choices, the implications of the crisis that we're in. I'm really fearful right now that people will start to really pay attention from the outside when health systems start failing, when hospitals start closing, when services continue to be shut down. We've seen some of that. We haven't seen a ton of that. And frankly, there's a precipice that we could push ourselves over really quickly and fairly soon if we don't start solving some of these problems. So investing in the conversations, certainly with government officials to help them understand, but also then trying to break down some of these silos in the parallel plan mentality, reaching out to our payers and saying, okay, you've got 30 people pointed at me, I've got 30 people pointed at you, how can we do this differently? We had a great project that we did with UCare, one of the nonprofit payers in town, where we said, we're gonna hire a process engineer together and we're going to look at our process and your process together as one continuous flow. What can we take out in terms of waste from that system? And I think that kind of work, as tough as that was, is really going to be an important part of the solution.
And then how do you spread that to the other 5 health plans that operate in our ecosystem, and how do we actually reset how we work?
I was pretty proud that we started where we did, Jennifer. Just enough.
We're going to push. We're going to keep going.
Yep, you just got to patent that and move on. Oh. Well, oh my gosh, my head is spinning. I mentioned earlier that every year I take away so much from this CEO session, and this year did not disappoint at all. I've got a number of things I got to jot down and follow up on. So thank you so much. Incredibly rich conversation. I apologize I didn't get to all the questions. I tried to loop them together or bunch them together. I literally have 30 cards here. So thank you so much for your interaction and your engagement. And please join me in thanking our incredible panelists for their time. (9:45). All right, so Abby has directed me to let you go and enjoy your break. We'll reconvene at 9:45. Thank you so much.
Our next session is discussing the coming healthcare revolution. To introduce our speaker of this session, we're going to welcome Jennifer. Jennifer is a highly successful public policy, legislative, advocacy, and political affairs leader, including working in both the state and federal government, as well as the private sector. She has over 20 years of public policy and government relations experience, with well over half her career spent dedicated to healthcare policy and the healthcare industry. Her role at Clifton Larson Allen is to provide thought leadership, policy analysis, and strategic insights to healthcare providers across the continuum related to the industry's ongoing transformation toward value. Please welcome Jennifer Basie.
I told her not to introduce me, just like a sentence. Okay, I have the pleasure this morning of introducing our keynote speaker, David Johnson, who is the CEO of Foresight Health, a thought leadership and advisory company at the intersection of strategy, economics, innovation, and capital formation. Prior to founding Foresight Health, he served in healthcare investment banking for over a decade. He's been with Foresight Health, and then prior to that, he served in investment healthcare banking. He employs his knowledge and experience in healthcare policy, economics, statistics, behavioral finance, disruptive innovation, organizational change, and complexity theory. And he writes and speaks about this frequently, including multiple books that he has. And one of them is on the registration table if you didn't get a chance to pick it up. And with that, I'd like to welcome David to the stage.
Nothing like a little reggae to get us going in the morning. There's a story about that I'm going to tell you in a second. But first of all, I was born in Minnesota at the old Ramsey County Hospital and lived here for 12 years. And I always love coming back, even in February. Thank you for the nice weather. In fact, my dad grew up on McAllister Street, not far from here, and our parents both went and met at McAllister College. Even though we moved away when I was 12, I still cheer for the Vikings and the Twins. Wish I didn't. The worst thing you can give a Minnesota Vikings fan is hope. And I thought they were going to beat the Lions and have the #1 seed. You know, we're humble from Minnesota and we come by it the hard way. Boom. So get up, stand up. April 4th, 1980, I was a Peace Corps volunteer in Liberia, West Africa. It was a Saturday. I was in the market and buying some food from the ladies in the marketplace. And suddenly all the shops closed down. There were rumors the president was dead and it was deserted. So I went back and turned on the national radio. And the only thing playing was Get Up, Stand Up by Bob Marley and the Wailers over and over and over again. And so when I was looking for a theme to talk about revolution, it's time for healthcare to get up and stand up and deliver for the American people. So that's where that comes from. So I have no idea how I'm going to get through all this content and leave time for questions, but I'll do my best. This new book, Gradually Then Suddenly, or actually the new book is The Coming Healthcare Revolution. Paul and I wanted to call it Gradually Then Suddenly. The Sun Also Rises by Hemingway is one of my favorite books of all time. And there's a scene between two grizzled old war veterans, big drinkers, and one had gone bankrupt and the other said, "How'd you go bankrupt?" And the answer was gradually, then suddenly. And that's where I think we are in healthcare right now. We're a whole lot closer to the suddenly phase than I think most people in the industry realize. And I'll take you through why I think that. The reason we didn't get the title is Wiley, our publisher, had a group of 20 people that I never met who were smarter than we were. And they said, nope, the title's got to encapsulate the meaning of the book. And I said, no, it doesn't. my favorite business books of all time, the content defines the title, not the reverse. Tipping point, range, flow, good to great. No, we know better. Anyway, the next time I sign a book contract, I'm going to have veto proof or veto over the title. So this book is a megatrends book, and our basic message is this combination of incredibly powerful macroeconomic forces pushing down on the largest industry ever created by human beings is starting to crack it. And at the same time, these incredibly powerful market forces are coming up to fill in the cracks. And together, the punchline is more change in the next 10 years than in the last 100 years. That's going to be the story I'm telling you today. I really enjoyed the CEO panel discussion. I thought it was nuanced, in-depth, accurate, and there was a lot of talk about change and transformation. My guess is we collectively have no idea what's coming down the mountain on us right now. And let me give you a perspective on that. So when I was doing research for the book, I found an old Fortune magazine from January 1970. Some of you are old enough to remember Fortune magazine in its glory, folio size, professional art on the cover. Every CEO had them it was the most important business magazine in the country. Every CEO had them on the desk. Every aspiring CEO had them in their cubicles. It was really the business publication. And here's the cover from this one. And the title is Our Ailing Medical System. And the depiction here is a play on the medical symbol. It actually gets it right. One snake, not two. Sorry, medicine. And it's in the shape of a boa constrictor strangling the American flag. The artist was a Bauhaus artist, made this wry comment: any resemblance of the snake to a dollar sign is simply coincidental. So that was January 1970. So this came from the letter to the editor, and I'll just read it out loud because every time I read it, I just can't believe it. Much of U.S. medical care, particularly the everyday business of preventing and treating routine illnesses, is inferior in quality, wastefully dispensed, and inequitably financed. Medical manpower and facilities are so maldistributed that large segments of the population, especially the urban poor and those in rural areas, get virtually no care at all, even though their illnesses are most numerous and in a medical sense, often easy to cure. Whether poor or not, most Americans are badly served by the obsolete, overstrained medical system that has grown up around them helter-skelter. The time has come for radical change. That was written in January 1970. Change the word manpower to personnel, and it applies verbatim to today. That's pathetic, right? I mean, that is pathetic. So January 1970, adult obesity was 15%, childhood obesity was 5%. Today, they're 43 and 19. There's no better predictor of rampaging chronic disease than levels of obesity. And yet, here we are. And in 1970, we only spent 7% of our economy on healthcare. Today, it's 18. CMS projects it to be 20% by 2032. So let's do a little diagnosis before we get into the cure. But can't do it that way. That's going backwards. We need to go forwards. So healthcare is the largest industry ever created by human beings, U.S. healthcare. So this is from a group called IBIS World that tracks the largest industries in the U.S. Look at the top four: hospitals, drug, cosmetics, and toiletry wholesaling. Can you say McKesson? CVS. Pharmacy wholesaling. Can you say McKesson? health and medical insurance in the U.S., United Healthcare. It's not until you get to commercial banking that you find a non-healthcare industry, you know, at number 5. I mean, that's just remarkable. And not only is it the largest industry ever created by human being, it's also the largest industrial complex created by human beings. My second book, I've written 4 books. The second book, the organizing thesis was, why is healthcare not improved more substantially, say, since 1970, or actually could probably go all the way back to 1920. We're still using the same model for medical school largely. And the answer for me came in a speech by former President Dwight Eisenhower's farewell address. I think one of the great presidential addresses of all time. And it was in that address he identified the military-industrial complex as a grave threat to American society. He said it was grave economically, politically, and spiritually, that historically America had flexed up for war and then flexed down for peace. But because of the post-war environment, nuclear weapons, the Soviet Union, we now needed a permanent armaments industry. But the risk was that the conjunction of the business with the bureaucracy and then the elected officials, that they would work in conjunction with one another for their own benefit at the expense of greater society. So in 1961, January 61, so 10 years before that Fortune magazine cover, the US economy was 9% military and 5% healthcare. Today, military is 3% of our economy, and we do have a military-industrial complex, no question about that. But healthcare is 18% of the economy, and my conclusion was that the healthcare industrial complex is the equivalent of the military-industrial complex on steroids, that this massive industry, massive bureaucracies, and then not only federal government, but all the state governments are working together collectively for their own interest at the expense of larger society. Now, in 1970, the number of doctors to administrators was rather small. Today, that's now up to 10 to 1. And administrative costs are somewhere in the neighborhood of 25 to 30%. In other industries, like law and accounting and so on, that ratio of 10 to 1 is more like 0.85 to 1. So administrator to a frontline employee. So 30% of $5 trillion, which is where we're at in terms of annual expenditure right now, is close to $1.5 trillion. And by the way, $1 trillion it's beyond human comprehension to understand how big that is. I told you I was in Peace Corps in Liberia, and my local dialect, Grabo, the counting went from 1 to 20, and anything after 20 was just a lot. That's how I think about $1 trillion. I think most people go, $1 billion, $1 trillion, how much different could it be? Well, to live 1 billion seconds, to live 1 billion seconds takes about 32 years. To live 1 trillion seconds takes 32,000 years. So if we've got administrative costs in healthcare and waste probably north of $1 trillion in the industry, that's $1 a second for the next 32,000 years. I mean, it's just a massive number. So there's a lot we need to fix in healthcare. So I'm going to go through these next ones. Geez, there I did it again. I really do want to go forward, not backward. So our performance, and the panel mentioned this, pretty much any advanced economy you see is much lower cost and much better on life expectancy. When you'll see I like matrices. this to me are the sort of the three faces of healthcare. And on the y-axis, you've got medicine, good and bad. On the x-axis, market, good and bad. And lower left, that's a really bad place. Overtreatment, undertreatment, overbilling. It's just you don't want to be there. The more interesting ones are good medicine and bad market, and good market and bad medicine. You heard the CEO panel talking about how many colonoscopies get performed in hospitals. Northwestern just got written up, the Bill of the Month Club. That is not a club you want to be a part of, for charging 20 grand for a colonoscopy for the same thing you can get for $500 in a doctor's office. So good medicine is you need the colonoscopy, but bad market is you're paying thousands of dollars for it, $5,000, $10,000. In Northwestern's case, $20,000. Good market, bad medicine is, with an MRI, you're only paying $500 for it instead of, maybe 10,000, but you don't need it. So overpricing and overtreatment are rampant in U.S. healthcare, and the three together, overpricing, fragmentation, and overtreatment, probably constitute at least 90% of the marketplace. So there are a few bright spots where the market and medicine get it right, but they're relatively small on the horizon. They're going to get a lot bigger. And I want to talk a little bit about this bullet point, mature services with immature structure. What the hell do I mean by that? What I would say is that in U.S. healthcare, 80, 90% of the issues, the conditions that patients present with, we know what to do. It's largely commodity. Think about colonoscopies and MRIs and diagnostics, even surgeries. And in other industries, when they get a mature product or service mix, they decentralize. They decentralize to cut costs. They decentralize to get closer to customers. They decentralize to improve the customer experience. So we've got a mature services mix. And what do I mean by immature structure? We still largely are dependent on the high-cost, centralized delivery mechanisms for healthcare in the country. It's why we're doing colonoscopies in hospitals. Makes no sense. So we've got this incredible problem with a mature service mix combined with an immature organizational structure that's exceptionally high cost, overly centralized, not customer friendly. My friend Terry Shaw, who's the CEO of Advent Health, I think Terry's one of the best CEOs in the country. I used to be his banker when he was the chief financial officer for Advent. It was called Adventist in those days. Anyway, he likes to say healthcare has been and continues to be a cottage industry, except now the cottages are all hotels. It's just that big. I live in Chicago, and 2 blocks from me, Advocate, one of the big hospitals, is spending $1 billion to build a new patient tower. That's a lot of appendectomies. And on top of that, we're not doing that great a job of matching services to need. So this is, I won't go through the details, but the punchline here is that Americans are working harder than ever. They're more productive, and yet they have less take-home pay. So if you want to know why people are angry on both the left and the right, the underlying reason is the same. They are working harder than ever, and they don't have anything to show for it. The underappreciated fact is how much healthcare accounts for that gap in wages. And so a few years ago, Zeke Emanuel, the physician who helped write the Affordable Care Act or create the Affordable Care Act, and I created this thing called the Affordability Index. It's really simple. It's the cost of a family health insurance premium, employer plus employee contribution, divided by median household income. And in 1999, that ratio was 14%. Today, it's 32%. If we'd been able to keep the cost of a health insurance policy at 14%, we'd close about 2/3 of that gap. About the average family would have an additional $12,000 in their pocket. That's not chicken feed. And on top of that, when you ask people what they're afraid of, Gallup and all these others, Americans today are more worried about paying a hospital bill than they are about contracting a disease. How did we ever get here? Uh-oh. Oh, got to hit the right button. So we're in the 2020s. I've been doing a lot of thinking about how the 2020s are a lot like the 1920s. The 1920s are the only decade with its own nickname, the Roaring Twenties. It started like our decade did, with a lot of death and uncertainty. World War I, the war to end all wars, well, not exactly, but just massive amount of death. And as that was occurring, we had the great influenza, which killed 650,000 people in the United States and as many as 50 million worldwide. So we start the 1920s with a lot of death and a lot of uncertainty. And then the decade just takes off. And many of the things that we think of as fundamental to modern life, the ubiquity of the telephone and the automobile, mass entertainment, urbanization, appliances, the 40-hour work week, universal education, all of those came of age in the 1920s. So much so, by the end of the decade before the stock market crash, it was almost hard to remember how humble the origins were. So we're here now in the 2020s. We've got these epic-defining technologies, artificial intelligence and synthetic biology, fundamentally changing the way we do everything. And that's coming on top of the internet and apps, which Tom Friedman wrote the book, Thank You for Being Late, a guide for thriving in an accelerating world. So we've got this going on, and I think by the end of the decade, we're going to all have a bot on our shoulders that's going to help us navigate a much more complicated world, but we'll be less stressed because the machines are taking a load off us. So this is going to be the audience participation part of the platform. I'm going to ask you 3 questions, and just got to raise your hand. It's really simple. So the United States spends, as I said, 18% of its economy on healthcare. The next big countries with the next highest percentages are France and Germany at 12%. Does anybody in this room believe we need to spend more than 18% of our economy to provide great health care to everyone in the country? Anybody? I dare you, raise your hand. Okay, second question. According to the CDC, 90% of what we spend on healthcare every year goes to treat individuals with chronic disease and mental health conditions. Anybody believe we're winning the war against chronic disease and mental health? No, okay. All right, those 2 are a setup. Here's the third one. So on a relative basis, how many believe we need to shift resources out of acute and specialty care into primary care, chronic disease management, behavioral health, and health promotion? Well, that took about a minute. So what did we learn? It's not a money issue. It's not funding. There's enough money. Remember you said no more than 18%. So it's how we spend the money. We're not attacking our biggest challenges, which are these exploding chronic disease and mental health conditions. And the industry needs major restructuring. So it's not really what to do, it's how to get it done. And you heard the CEOs on the panel talking about a lot of this. We in the United States like to call ourselves the land of the free and the home of the brave, but increasingly we are becoming the land of the sick and the home of the frail. And ever since Brian Thompson's murder, I think I've been channeling this inner Abraham Lincoln, because I've been thinking about the level of harm created by a healthcare industry. I mean, the third leading killer in hospitals, the third leading killer from medical errors. the amount of physical, emotional, financial harm on top of that. I mean, it reaches kind of Civil War level dimensions. And Lincoln also gave a speech where he talked about famous house divided speech, a house divided against itself cannot stand, where he made the statement, the nation cannot endure permanently half free and half slave. And I've started wondering whether we as a country can endure half sick and half healthy, because that's where we are. I mean, almost half of Americans are either diabetic or pre-diabetic, and that is the trigger for all of this chronic disease that we're doing. So we're, as a nation, as a healthcare system, we're very good at saving people when they're drowning. We're terrible at teaching people how to swim. So how do we teach Americans to make healthier lifestyle choices? How do we make it easier for communities to be healthy communities, to prosper, to be happier, to be more productive? So that's where we're going to go now. I don't know why I'm having so much problem with it. Oh, there I go again. So I talked a little bit earlier about Tom Friedman and his book, Thank You for Being Late, An Optimist's Guide to Thriving in an Age of Accelerations. And he, for that book, which was trying to deal with, as I said, the internet and apps, he sat down with the head of moonshot projects at Google, whose name, he's got a great name, Astro Teller. So a great name and a great job title, head of moonshot projects at Google. And Teller made the rather remarkable comment that for the first time in human history, the rate of innovation, technology change is happening faster than the ability of human beings to adapt to it. That's why we're all so tired. And their prescription was learning faster, so lifelong learning, go Tommies, and then governing smarter, both of which are exceptionally important. But the one thing he didn't talk about that I think is the biggest difference maker are human-machine collaboration. We are within 3 to 5 years of what they call artificial general intelligence, where the machines are as smart as we are, already are smarter in many respects, and then superintelligence when they are smarter than we are. And I've been reading a lot about artificial intelligence. I almost can't read about it anymore. But figuring out how to work with the machines in ways that improve productivity and outcomes, I think is the challenge of our decade. And the change across all society is going to be exponential, not incremental. Healthcare is even worse because, as we saw in that 1970s quote, industry hasn't done a great job with technology, so we're having to make up for lost time while the rest of the world, the other industries are accelerating. So that gets us to the heart of the book, the macro forces that are cracking this healthcare industrial complex, and then the market forces in a second. So we've got 5 of them, and I'll go through them quickly. I really can't thank the sponsors enough for giving out copies of the book. It's selling pretty well and seems to be resonating. But I'm happy as you go through it to, if you want to send me questions, Foresight Health, we'll answer them. But the number one is demographics. I've got 2030 up there because that will be the first time in the history of the United States where we have more people over the age of 65 than under the age of 18. So that creates both a supply and a demand problem. The demand problem is when people get old like me, they get sick. So we're going to need more resources to treat them. The supply issues, we don't have enough workers. And oh, by the way, when Medicare came into being, it was 10 workers for every retiree. We're on our way to 2.5. So the expectation that future workers can pay for the burden the way we're currently doing things is just ludicrous. So 2030, remember that in your funding fatigue. Until the last couple of years, we'd been in a period of 10 years, starting 2010, 2011, where healthcare grew at the same rate as the overall economy. It's the first time really in the history of the industry that that's happened. The only time it didn't happen were the 2 COVID years, and that was because the government pumped so much money in. And the fact the government had to bail out hospitals while insurance companies made record profits maybe indicates we got some structural issues. So we had hit something close to a plateau, a limit, an inflection point on funding. And if you read the book, you'll see I go at that in 3 or 4 different ways. And then the last couple of years, including the most recent one, the numbers just came out for 2023, we saw a 7% increase in healthcare expenditures, or 7.6. It was greater than the economy as a whole, and 2024 is going to be more of the same. And I could almost feel a sigh of relief in the industry saying, okay, things are back to normal. We get to take more resources from society and fund our inefficient operations. But I don't think that's it. I think we're in this period of disequilibrium, and all this does is add more pressure to a system already about to explode. It's like overinflating a balloon. It's just getting bigger and bigger. The chronic pandemics, if you look at the 4 horsemen of death in this country, heart disease, cancer, diabetes, and dementia, Alzheimer's, they're all growing. They're all uncontrollable. We come in at the late stages and do the best we can. But obviously the best thing to do is not get sick in the first place. So how we attack chronic disease, I think we'll have a lot to say about what kind of country we are over the next 10, 20, 30 years. Technological imperatives, and unlike the first 3, this is a galvanizing force. The way we're working in healthcare clearly isn't working. First thing you do when you're in a ditch is stop digging. So what are the new ways that we can organize the supply-demand dynamics of the industry in order to drive better outcomes? And technology gives us incredible resources to do that. One of the things I've focused on is something I call preemptive diagnostics. So when most people think about precision medicine, they think about altering the human genome. So incredible. I mean, today we can cure genetic diseases like sickle cell anemia, right? I mean, it's incredible. It's enormously expensive. But we are not that far away from having the ability to spot in almost a pre-disease state markers in biological metrics for chronic disease. So you get the marker, you study it over time, you look for small changes, you correlate to chronic disease. And so we are on the cusp of being able to tell people 3, 4, 5 years in advance, if you do nothing differently, you're going to have Alzheimer's. And if we're able to do that, and I believe we will. By the way, I just met an Israeli company last week that's using the breath to do exactly this type of biometric data. Evidently, our breath contains all kinds of biometric information that if we understand it and can correlate it to disease, we'll be able to say with precision, this is the disease you're going to have, and this is what you can do to either prevent it altogether or manage its onset. So today we spend 3% of our healthcare budget on prevention. What's it going to be in 10 years? 10%, 15%, 20%, 25%? Whatever it is, it's going to be hugely disruptive to the current model. And then pro-consumer, pro-market reforms, interoperability, transparency. For me, one of the worst things about healthcare is that the industry does not see human beings at the end of its transactions. It sees a bill, sees a diagnostic, it sees a treatment, doesn't see a human being. We were just talking beforehand, it's the only industry I can think of that's person-centric, where customer and consumer are not one and the same. And that's changing. And honestly, the companies that are going to maintain market relevance are going to be the ones that figure out how to make the system work for the end users. Doesn't today. Okay, let me try this again. Nope. I keep flipping it around in my hands, so what does the market have to say about all this? And you heard a lot in the CEO panel about getting better balance between health and healthcare. That's obviously what other countries do a better job of than what we do. So these are the 5 forces. These were harder to write about than the macroeconomic forces because many companies are doing all of these things. In fact, you could argue that you almost have to be doing all of these things in order to maintain market relevance. So we think the disruptive innovation that's going to bring down the castle is something we're calling 3D WPH. Rolls right off the tongue, right? But it stands for democratized and decentralized distribution. That's the 3D part of whole person health. Whole person health is not a radical concept. The Veterans Administration went to whole person health 15 years ago. And today, and that's when they started focusing less on buildings and more on things like housing and nutrition and addiction. And today, the VA, it's an incredibly bureaucratic organization, but the VA gets better outcomes with a sicker population at 2/3 the per capita cost of Medicare, whole person health. So it's going from fragmented crisis care to more logical whole person health. We treat the whole person. That's got 2 components, care redesign and care migration. The redesign is the whole person health thing. And in the book, Paul and I were looking for examples, non-healthcare examples of what the industry is dealing with. And for care redesign, so going from fragmented care to whole person health, fragmented crisis care to whole person health, our analogy was the auto industries in the 1970s. It's when the U.S. gave up its global leadership position in the auto industry, and Japan and Europe ate our lunch. And that was an era where the bean counters triumphed. Ford built a car called a Pinto that had exploding gas tanks. It would have only taken $13 to prevent that from happening. Ford fought that in Congress for 8 years, ultimately lost. But in the meantime, thousands of people either died or maimed by rear-end collisions. They were focused more. Roger Smith, the CEO of GM, said, people think we're in the car business. No, we're in the profit business. That's the mindset. The bean counters are winning here in healthcare. Ford's campaign in the 70s was Ford has a better idea. Some of you are old enough to remember that they switched in the 80s when they realized that their business wasn't working anymore to quality is job one, and they got back to engineering and satisfying customers. Quality is job one. Our analogy for care migration, and that's going from centralized delivery to decentralized delivery, community-based, in the home, virtual, and so on, which really needs to be the vast majority of care. Our analogy was even more audacious. And I'm not even really comfortable saying it, except I couldn't think of anything better. And it was the movement of Black Americans north, the Great Migration, from 1910 to late 60s, early 70s. 6 million people moved north. Isabel Wilkerson, in her book on this, won the Pulitzer Prize, describes it as vast, 1,000 currents, and leaderless. Essentially, it was individuals and families making the decision to move north and west for economic reasons, because of oppression, any number of reasons, but it was top down. It wasn't bottom up. And I found that example very powerful because over time, it turned into just this vast stream of migration that ultimately changed both the North and South in fundamental ways. But I thought about her terms. So vast, healthcare is vast, yes. 1,000 currents, absolutely. Leaderless, that's an interesting one. Is healthcare leaderless? And Paul and I came down and we concluded the answer is yes. It's not that we don't have leaders in healthcare, it's that they're more like warlords. They're protecting their massive realms. You saw the 4 industry. So we need individuals that can stand up, and the CEOs were starting to do that today, that stand up and speak for the industry as a whole, which means that you're speaking for the people as a whole. And let me just give you a couple of things. One is, I've talked about whole person health and fragmented care. We suffer from something economists, well, I call the reverse tragedy of the commons. Economists love to have fancy terms, so there's this term, tragedy of the commons. It's when you get individual overuse of a public good, so a grazing field. It's in all the farmers' interest to overgraze, but if they do, there'd be no there'd be no field. So what I say is, in healthcare, because everything else is so convoluted, we have a reverse tragedy of the commons. Our very public good is investment in whole person health, pro-health activities. When we do it, we generate an enormous return. People are healthier and more productive, but we don't do it. And why don't we do it? Providers don't do it, and you heard it today, because when they invest in pro-health activities, they lose volume and they lose money. So even though they give it lip service, they don't do it. Payers don't do it because when they invest in pro-health activities, premiums go up and their members switch plans. So I'm on the board of the HFMA and leading a task force we're calling Healthy Futures. And the whole idea is, how do we create payment models and metrics that enable payers and providers to invest in pro-health activities and generate a financial return? This is America, after all, and this is a business. So the final two, aggregators advantage, somebody's going to put all this together and make it easy. I mean, just think about our buying experience at Amazon. So all these point solutions, all this other stuff that gets in the way, all this friction, we're very close to having companies that can make it easy. And then empowered caregivers. This comes from Paul when he took over Amedisys, the home health company. It was $11 a share, was paid a big government fine. And think about home health. These are largely undereducated women doing the very hard work of going in and laying hands on people every day. And so after he got the job, he packed a suitcase and disappeared for 3 months and spent his time going on calls with the workers, meeting clients, that type of thing. And at every session, he said, what can we do to make your job better? He called it the golden rule principle of management, filled up a bunch of notebooks, and when he got back to Amedisys, that became the basis for the strategic plan. And it's really simple. You treat your workers well, they treat your customers well, they go the extra mile for customers, and the company does better. So you put these all together, this is where we're going, and we're getting there a lot faster than I think people realize. Part of what we did to make sense of it, we created this little acronym, CB2E2. Sounds like Star Wars, right? And it stands for, the C stands for cheaper. The first B stands for better. The second B stands for balanced, meaning more balance between health and healthcare. The first E stands for easier, and the second E stands for empowering for consumers and caregivers. And honestly, if you're not doing these things, all of them, the CB2E2, I got to work on that, man. The book only came out in November. Anyway, if you're not doing all those things, I think you're in grave danger of losing market relevance, and probably should be. So at the end of the day, it's still consumerism, platforming, and ultimately value. I'm not going to get into this, but the disruptive forces are primary care, focus factories, and asset-light delivery. And what's going to give them multiplying or better purchasing, which we've talked about, liberated data and consumerism. So new healthcare game has different math. The old math, revenues are flexible, expenses are less known. The difference is margin. The new game is revenues are fixed. State of Indiana is trying to pass legislation as we speak that fines hospitals where facility fees are too high and risks their state tax exemption if they overpay relative to Medicare. So increasingly, we're going to, kind of fixed revenues. And then managing expenses are essential, and the difference is profit or loss, creating value. It should be what drives people. And you heard it today too. And until we change the way we pay for healthcare, we're not going to change the way we deliver healthcare. But full risk contracting is coming, bundles for episodic care and capitation for population health. Today in Columbus, Ohio, JP Morgan is paying a company called Apri to manage the health of their 40,000 workers and dependents in and around Columbus, Ohio. Apri has partnered with a big primary care group, Central Ohio Primary Care. They're on the insurance card. It's a per member per month rate, no intermediaries at all, and they're benchmarking against other non-managed JP Morgan populations. How many of those do we have to have before we fundamentally change supply-demand dynamics? John Powers, you never heard of him. I guarantee you he was one of the first marketing gurus in America. He was the head of marketing for Wanamaker's, which is now part of Macy's, but a big department store in Philadelphia. First one to ever put prices on goods because they believed that everybody deserved to pay the same price. We shouldn't be charging more or less on anything other than price. And he had 3 covenants that related to marketing. And the 3 covenants were, you got to be interesting, right? If you're in marketing and you're not interesting, God help you. But the second one was speak the truth. Speak the truth. So treat your customers like adults, tell them the truth. And the third one was live the truth. So if you're speaking the truth but not living it, everybody figures out hypocrisy pretty quickly. My favorite quote of all time is, hypocrisy is the tribute vice pays to virtue. So speak the truth, live the truth. And if what you're doing isn't living the truth, then change what you're doing. So you can't say you're putting patients first and then put them first. So I'll leave it up to you. Are we talking about evolution or revolution? And it's time. So 10 years from now, you can see more, better, longer, fewer, less, lower. Our goal shouldn't be to be as good as Canada. There was one of the questions that didn't get asked in the last state last campaign or last session was, if Canada becomes our 51st state, do we get their healthcare system? And I've always believed our goal shouldn't be to be as good as Canada or any of these nationalized systems. If we can unleash the American innovation machine on healthcare with the right incentives, we can surpass other countries. But as long as we've got centralized pricing and ferocious private market exploitation of these complex models with perverse incentives, we're going to continue doing what we're doing. Enough already. Consumers need to win. And again, my punchline is more change in the next 10 years than the last 100 years. So people power, value rules, outcomes matter. So thank you very much. You can follow us at Foresight Health and yeah, go ahead.
We have just a few minutes for questions. So one easy one is your book available on audiobook?
Yes.
All right, so there you go.
Not me speaking, thank God.
We also have a question, which I find interesting because I've thought about this a lot, but why not regulate local hospital prices like utilities?
Yeah, I mean,
And what do you think about that?
Well, remember Terry's quote, cottage industry, but we turn the cottages into hotels. We may end up there. I hope we don't, that hospitals become a utility with fixed prices and so on, because every community needs some amount, but we actually need many fewer hospitals. I'm part of an initiative on the south side of Chicago right now, and we've got 9 safety net hospitals that nobody uses. And we're trying to think about how do we create a community health network with fewer hospital beds, many more clinics, one health record, community health champions, to give the residents of the South Side what they need, which is a health network. So I would hate for us to go to a utility model that locked in the current configuration. We really need to blow it up and build something new.
And then, well, the last one in the essence of time. So with technology advances, how do we make sure that those actually work for the consumer and aren't like hijacked by rent seekers, this question asked, but by others, let's just say.
Yeah, well, the healthcare industrial complex.
Yes.
So my advice to any and all of you is, channel your inner Gandhi. Be the health system you want to use yourself. And we need to empower consumers. We need to empower caregivers. As many said earlier, I mean, healthcare should be the greatest profession in which to work. We help people lead healthier, better, more productive lives. So let's do that. But that means, I think it means putting consumers back in the driver's seat.
Yep. All right. And with that, please join me in thanking David for his great talk.
Welcome, everybody. Thanks for being here. Once again, Joe White, and it's an honor to be here. But more important, I really get excited about the fact that you guys are here. Obviously, we hear the story of how healthcare costs are out of control, and change needs to happen. And I feel like this conversation is always the beginning. What we do after is going to be important, and we'll have a chance to reflect on that. So I read David Johnson's book and strongly encourage it. There's some good stuff in there, some great examples. The J.P. Morgan was new information for me. Some of the hospital systems that he talks about in there that are doing unique things is necessary to understand and be aware of. It can make a difference. And how do we import some of those ideas and bring them to Minnesota is what's going on in my head right now. Who can do something similar to that practice in Ohio and work with systems here in the Twin Cities? So it has to give us hope. One of the questions that came from a student one time to me was, okay, I understand we spend 18% of the gross domestic product, and it's gone from 6% to 18% of GDP. Good. We spend twice as much as European countries of GDP on healthcare. What do we spend less on? Understand? So as it went from 6% to 18%, what decreased? And it's hard to wrap your fingers around that, tried to get that. One of the areas is education. And if we can, and if you took some of that savings from healthcare and we plowed it into our school systems, I think it would be a good start. Okay. And not that our school systems are the most efficient, but we need to figure out some ways to make a difference here. And as Johnson said, we're on the verge here, and you can start to see the tipping points. So keep your eyes open and let's see. One of the areas, big areas, value-based care. And we've got some good panelists here today to talk about that. Good Q&A. I'm going to let them introduce themselves, and then we have some opening questions, but then we're going to look for questions from you guys. So thank you. Scott, you want to start?
Okay, sure. I thought I was going to be last, but okay. So I'm Scott Cullen. I'm a former primary care physician. I actually practiced in the Mass General system for about 10 years before I went into consulting, primarily in technology and then increasingly in healthcare management and strategy. And part of what I did when I was in practice was operate under a full subcapitated system for Medicare patients, which was highly successful in our group, but not in all groups universally. And we can talk a little bit about why that is. What I do now is I advise and am the chief medical officer for the Health Data Analytics Institute, which is a somewhat unique organization that has full access to the CMS Medicare database on a real-time basis and has used that to produce predictive models and drive a digitally twinned perspective on health risk down to the individual patient level, allowing many of our partner systems to drive unusually strong outcomes due to the visibility into risk factors at an entirely individual level. And so we can talk a little bit more about that later, but I don't want to make this an ad for HDAI. So.
Krista.
Well, good morning, everyone. Krista Skarupa. I'm also a family physician, and I still have a very small amount of practice time. I am our president at Essentia Health's East Market. So we're a nonprofit integrated care delivery system serving patients in Northwest Wisconsin, throughout northern Minnesota, and into North Dakota as far west as Bismarck. I have the pleasure of serving our colleagues and all of our sites of service out of our Duluth hub. So my husband and I moved up from the Twin Cities, where I've been in leadership for the past 18 years. So I had the great pleasure of going from an urban environment to a rural care delivery system, physician-led and fully integrated. So I'll talk a lot about the power of that today. I also serve as our Accountable Care Organization board chair, so feel very passionate both as a family physician and from our work at Essentia Health with value-based care about the future of this care model that we really believe is foundational to being a premier rural care delivery system like we are at Essentia Health. So great pleasure being with you here today. Cohort 29, I think I've got a couple of classmates, healthcare MBA here, residency here at the University of Minnesota, and happy to be here today.
Good morning, everybody. Before I start, I just wanted to thank the University of St. Thomas for offering me this opportunity to speak today, and it's very much appreciated. I'm Paul Pritchard, Senior Vice President and Senior Vice President and Chief Medical Officer of Prevea Health. You guys heard a little bit about them from Dr. Rai. I'm also an alum of the MBA here at Cohort 23. Nobody. Yeah, great. Unlike Dr. Rai, I'm a proud Packer fan, and I can tell you, I was waiting for the boos, but I can tell you it's very difficult to work with on Mondays now because the Lions, actually, they're good, which is disappointing to me. A little bit about me in terms of how I got involved in value-based care. There's really three areas I can look back to in my career now. I graduated in '99 from my residency, and I've been an internist since then. I still practice. And that's really my first, point, is that I'm always looking at this from a perspective as a physician, especially since I deal with a group of patients with cystic fibrosis. That's where I really learned how team care can be beneficial for our patients. We see our patients with a pharmacist, a social worker, dietary, and it was really the beginning of what I saw in terms of care management in my own practice with my general patients. So I've been dealing with those patients for 20 years now. The second area I got involved with value-based care was as the Chief Quality Officer at Prevea. That was my prior position. Dr. Rai, when he got the CEO position, asked me to take over that because before that really didn't have much structure. It was a check-the-box kind of department. But we really needed to get into value-based care and start looking at other models of care. We were the first certified NCQA patient-centered medical home in northeastern Wisconsin. My clinic actually was the pilot for that. And it was very interesting to see the results and how patients responded to that because they weren't used to that. Neither were my partners, for that matter. And then the last area I got involved with is Prevea decided to open up its own little insurance company. So I was asked to be on the leadership team for that. And that gives you a whole different perspective of the healthcare system. You start learning about medical loss ratios and utilization rates and all those types of things. So that's where I guess my perspective and or bias comes from. So again, I appreciate for being here.
Great. Thank you, Paul. Krista, Scott, thank you. Opening question, and we'll start with you, Paul. The definition of value-based care. What is it? What does it mean to your organization? And what's your primary goals related to?
Well, for us, it really is, the definition is, in general speaking, is you're changing the delivery model. You're going from this, what I tell my partners when I tried to explain it as a chief quality officer, is you're going from this episodic, siloed model to a much more continuous chain of information and touch points. So I used to give the example, I'd see a patient on, right before Christmas, say your hemoglobin A1C is too high, we need to get your diabetes under control. I wouldn't know what would happen to him for 6 months because we didn't have EMRs at the time. And then they'd come back in June and say, well, I was doing great until Memorial Day and I ate bad. And I'd tell them the same thing I told them in December. And that kept going on and on for years. So what I told my partners is this model that we're trying to get in from the provider's perspective is a much more continuous loop of communication, closing the gaps with the hospital partners, the nursing homes, getting social workers involved. The problem that we had initially was we put all the infrastructure in to do that, but had no payment models for that. And so value-based care for us was a way of doing our operations, but it wasn't the financial part initially. So that came along a little bit later. We did it initially because we thought it was the right thing to do. But when you're adding care managers, you're adding care advocates, you're adding data analysts, you're adding coders, that all costs money. And if you don't have a revenue stream to support it, it's not going to be very successful. So value-based care for us was really a delivery model where you're trying to improve outcomes, lower cost for the patient, and also improve their satisfaction.
Good, thank you. I want to back up a little bit and make sure people are aware of your organization in terms of the size and just, it's a little bit different than what we've seen in Minnesota.
Right. We are in northeastern Wisconsin primarily. We have 500 providers, but we have about 60 clinics because most of them are embedded in employer clinics. 2,000 employees. We started getting into Medicare Advantage contracts and things like that in 2013, 2015, but the numbers we're talking about aren't even close to what some of the other organizations are. Our organization is about $250 million a year kind of situation. So we're not huge, so we have to be very nimble and very efficient with what we do.
No hospitals.
No hospitals in our system. It's all ambulatory.
Want one?
No.
Okay.
We work very closely with our, Dr. Rice said in the initial presentation today, we work very closely with our hospital partners. In fact, because of the way our organization is arranged, there's 4 members of the HSHS team on our board. So any decision we make, the hospitals have input. So that became really interesting during the ambulatory surgical discussion where we said, we want to take people out of your hospital. But we were able to convince them, and it's been a great thing for our community.
Good, thank you. Krista?
Yeah, very interesting. And, I think in contrast, so, Essentia Health, certainly hospitals and clinics in the East Market, 9 hospitals with a big tertiary care hub at Essentia Health here in Duluth, 44 clinics around that. And, similar, we really see value-based care simply as higher quality care delivered more efficiently in a patient-centered way so that it improves outcomes for our patients, those paying for the care, our providers, and really society as a whole. And for us, it's really about the integrated care delivery model and really working as one team so that we're providing access to the right care at the right place at the right time and investing in care transformation. And a very tangible example of that is the work we've done in our regional practices. And we serve a really large geography, and about 85% of the patients we serve at Essentia Health are in designated rural areas. So access is, a geographic access is a real barrier to care. So we're investing in our regional practices to keep that lower acuity but high volume care as close to home as possible, and then extending that now even into the home as broadband access is becoming even more available. So, value-based care is our care model. We were talking before the panel. Is it possible to live in 2 different worlds? And I think the answer really is no. You can't do that very well. Essentia Health is going all in We were an early adopter with the MSSP ACO program. 23 value-based programs later, we're continuing to grow the lives served. We have about 265,000 lives in our value-based care contracts, and we're looking to grow that. We really believe it is the best care. It is the care model we're going all in on.
Thank you. Scott, thoughts?
Yeah, that's great. I mean, obviously my perspective is a little different because I'm not a health system leader. I am serving a number of health systems, both major academic medical centers, such as Houston Methodist and Cleveland Clinic, as well as a number of ACOs. So we have partners who are just ACOs as well. And so from our perspective, basically value-based care amounts to looking at the total cost of care combined with outcomes data and trying to find the path from where we are now to the best cost of care for the best outcomes. And for us, that's the definition of value-based care, and that's a bit more theoretical than what some of my co-panelists are dealing with on a daily basis. But we see results in those organizations that we have worked with.
Good. Some good questions from the audience. Takes a lot of pressure off me. Relax up here now. So, this is how do you characterize value-based care versus bundled payments versus capitation? Thoughts on that? Scott, you moved.
Well, I'm happy to take a whack at this because I obviously have had a national perspective on this. Those are just basically different flavors of the overall concept of value-based care, right? The historical bundles processes, as well as full subcapitation for health systems, are really different manifestations of levels of risk for health systems that are engaging in value-based care more generally.
Yeah, not much to add to that. I mean, it's basically, just different subtle differences in terms of payment methods or how you establish pricing, but they're all kind of trying to accomplish the same thing.
Good. Next question. How do we move from 93% fee for service to capitation? There's an easy one. Krista.
Well, and I'll maybe put a slightly different spin on that question. So 40% of our revenue flows through our value-based care programs, and that includes the fee for service, the quality payments, and the shared savings dollars. So I would say we have a slightly different way of thinking about it. Again, it's delivering the right care at the right time and being rewarded for it. And so, for us, it's all about developing those partnerships with our payers, like true partnerships with the payers, so that we both win, but ultimately it's in service to the patients that we're serving. So, that's really how we think about how to make the math pencil out, Joe.
Okay. Let me chime in here. So of that 40% of your revenue flows through value-based contracts, but you're at risk. I often hear the question stated, yes, but it's really only about 5%, 3% that's at risk.
And 80% of our 23 value-based care contracts have downside risk. So, and we're looking for more of that. That's where, there's more, you take on more risk, and there's also more financial reward to do the right thing.
Thank you.
I think the question was, again, how do we move it, right? I think my concern is, and we talked about this a little bit in our discussion group, is you have to start aligning the incentives. And what I mean by that is that if you look at my organization, I would say only about 3% of it is tied to value-based contracts. And that's Medicare Advantage, that's ACOs, that's some commercial is now working into that, but it's a very, very, very small portion. We've instituted and put all the infrastructure in place to be successful in the value-based contracts. We know we've done well in Medicare Advantage and ACOs, and we apply that to every patient that comes through our doors. We're payer agnostic, but it's hard to get to that next level because I don't think all the incentives are aligned. And what I mean by that is, somebody mentioned in the discussion, there's a $100 bill on the table. How does it get cut up? Well, you have the payers who basically look at once they get their premium dollars, their objective is to hold on to it. They don't want to be giving that, their stock, they have to report to their stockholders. Hospitals, as we know, have a business model where if they don't have heads in the beds and they're not performing procedures, they're not making a revenue. Physicians, we stink at standardization. I'm sorry to say it, but I mean, I went to my own group and looked at the number of labs we do, the number of x-rays we do, and you kind of scratch your head at times and saying, why aren't we more standardized and looking at this better? And then the last component of this little system that we often overlook is all of us in this room. I think our culture is resistant to changing to evaluate. And I'll give you two examples really quickly, or try to quickly. I was in a Chamber of Commerce meeting, much like this one, talking about how expensive healthcare was. We talked about all the different processes we could do at the physician level, at the hospital level, so on and so forth, site of service care, that kind of thing. And then we took questions from the audience. The first question I got was, why do I have to do my infusion at home versus the hospital? It's more convenient to do it at the hospital. And I'll get back to my response in a second. The second example I had is I had a patient, or still have a patient, and I know him outside of the office, so I can speak a little bit more freely to him than I could to other people. He's in a C-suite. Came in October with lower back pain. What do we all do up here in the upper Midwest in October? Go out and do yard work, rake leaves, all that kind of stuff. He had a lower back strain. At the end of my conclusion, or at the time I was talking to him, I said, here's your treatment plan. We got physical therapy. And he said, where's the MRI? I said, you don't need an MRI. You don't have any neurological compromise. There's no fever. There's no history of cancer, blah, 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 blah. After 15 minutes, and I timed it, I actually looked at my watch. I finally gave in and said, I will give you a call back in a week with your normal MRI results, and you can tell your employer why you've spent $2,000 on that, or whatever it was. Again, I could speak freely to him. He laughed at me and called me a jerk or whatever it was. But my point in that was that we can talk about these policies and procedures and all that stuff we want. But when it comes down to it and you're sitting across from your physician, a lot of people aren't willing to change. So all those elements, in my opinion, I don't know what you guys think, are playing a role into why we aren't flipping as quickly to value-based care as I would like to see it, because I really do believe it is a very, as you mentioned, a very important pathway. Sorry, that went too long.
Nope, beautiful.
Did you charge him a 99215?
No, I didn't. No, like I said, I mean, he's a great guy, but I'm like, you're being an idiot right now. I think I said those terms, but I could say that to him.
Well, from historical experience as well as what I've seen in the field, it's a slog. It for sure is a slog. There are cultural barriers, and most importantly, there are payment model barriers. But where physicians have been given two things, I think, is where they've been most successful. And the first is access to control over those dollars, right, that are allocated on a population basis is one of the critical first ingredients. The second ingredient that's even more critical is data and visibility into outcomes. I mean, you raised the fact that you saw a patient, typically, you'll see your diabetes patient, their hemoglobin A1C is off the charts, but you won't see them again for 6 months, right? And that's not unusual. But I think that having the kind of visibility that you were wishing for into what's going on in the interim, as well as what are the real clinical endpoints, it's more difficult to get at that data in a lot of cases. And it's even more difficult to understand, is this patient going to respond typically, or is this patient going to respond atypically to these kinds of treatments? Because I'm glad you raised the question of standardization. Standardization is important to a certain point, but it's somewhat asymptotic in terms of value, right? There is a point beyond which you need individual customization as well, and that's what gets you to the next level on outcomes. And having the visibility to understand how and when to apply that, call it mass customization, is probably going to be a critical factor in us moving along the continuum of value.
Thank you. Krista, you want to try that, and let's add into the conversation. Do you really think that payers are really interested in value-based care? And I'm going to say transferring of complete risk.
I don't know if I can comment on transferring complete risk, but we've got one example right now with a payer that absolutely. I mean, and I'm out in the field with them. In our co-branded product, sharing the outcomes that we're delivering together, that we are uniquely delivering together because we're both invested in each other's success. So yes, we've got a real tangible example where that is working really well, and we're welcoming more and more patients to Essentia Health because of that partnership that's working really well. So I do think it can be done, but I really appreciate, Scott, your comment. And we call a common phrase we are talking about with our clinicians is, standard as possible, unique as necessary. And the amount of waste, and it hasn't been really until through our payer steering committee, which is physician-led again at Essentia Health. We equip them with the data to really see just how dangerous from a safety perspective, care variation is, unnecessary care variation. Do they really start to buy into the importance of standard work and standard procedures? So again, very helpful, to be, in a physician-led organization and equip people with data, and then, support the actions that they clearly see that we have to take to be successful. So.
Thank you. Great questions, hard to choose. I think let's go with, first of all, there's a lot of overhead associated. That's a bad term. A lot of overhead associated with managed value-based care, correct? We all agree. What are you doing to minimize it?
This is really where technology is starting to immediately disrupt. And I'll give, just a tangible example with our physician advisor program. So we have a whole team of, physicians that I'd love to, be on the front lines providing access to direct care, but we use them to help us with our utilization management and empower them to help work with their colleagues on efforts to, make sure that we are being good stewards of our financial resources. Built working with Epic directly, and some of the tools, the population health tools that are, right here. I mean, they're on the immediate horizon, I think will be the game changer.
I
agree. I mean, technology, I think, is where we're going to have to utilize that the most. The last panel talked about that quite a bit with AI and how you're going to start to bring in AI to augment the work that we're doing. We did some things with Epic also with our care managers when they went from basically they were able to go from a panel of, say, 150 patients that they were taking care of to go all over 200, close to 300, just because of the way you were able to identify different risk patterns and things of that nature, so they knew who to reach out to. So we're going to have to really leverage technology to get better at delivering value-based care, because there's just not enough bodies around to do it.
Scott, if you can add anything on that, and
Absolutely.
then predictive models.
Sure.
Related to best outcomes for value, lower cost.
Okay. Well, AI is obviously a game changer in many ways, both predictively, but also operationally, potentially. What's ironic about that right now is that over the last 15 years, as we've added more technology in the healthcare delivery space, we have not improved productivity to the degree that other industries have found as they've implemented technology. And I think part of the reason for that is legacy technical debt, but also just because there's still not the level of integration across those technologies, either from a data perspective or from a workflow perspective. And until we reach that tipping point around the integration of these tools and their usefulness across a continuum of care, we're still going to struggle to increase ourselves along the pathway of actually getting to outcomes, right? We see patients in a very fragmented way. And even if we share data across those fragmented experiences, we're not always able to put together a coherent workflow using technology that will move us quickly along that continuum. And then as regards predictive modeling, a colleague of mine said once that right now data is more valuable than oil as a resource, right? So when you look at the financial value in the market of data, it has exceeded that of oil. And the reason for that is because the tremendous amount of value in having visibility into data is going to be critical. And one of the things that AI is going to bring us is the ability to predictively model your likely risk for an MI, or your likely risk for readmission, or your likely risk for a 30-day mortality. We can actually do that now. But one of the reasons why we can do that now is having large enough data sets, big enough numbers, right, that we can feed those models and train those models and make them more and more accurate as we go.
I might just add, going back to your original statement, we're finding, it to go all in on improving the data literacy of our workforce and really the digital mindset of our leadership team specifically has been a worthy exercise. And so I might just add, data rich, but sometimes insight poor. And so spending some time, investing in helping others understand how to use these tools, the power of these tools, I really think is where the multiplier effect will come.
Discuss, do you see clear pathways for value-based care and mental health indoor substance use and disorder?
The clear pathways, I mean.
A clear pathway to value-based care.
I mean, it's part of it. I mean, obviously, every aspect of dealing with a person's or patient's condition is important if you're going to be in a value-based care world. And mental health, I think, is paramount. If you do not have mental health, you will not have physical health. I can recall one particular patient of mine who came in, again, a diabetic patient. And I just, one day, because kind of, I don't know why I asked this, but I said, what's preventing you from being able to get to where we need you to get to? And he says, it's kind of hard to follow through on stuff when you don't love yourself. And that was kind of an epiphany for me. And we've all heard these statistics, if you have mental health, your chronic conditions are going to be awful. So in order for us to really be successful at value-based care, you're going to have a mental health system that's effective and easy to access, which is not easy to do right now because we don't have a lot of them. Did that answer your question?
I think that answers, I'm sure there's follow-up questions to that, but I'll let the panelists.
I don't know that I would say the pathway is clear, but it is incredibly important. Here's where I might just, interject the importance of partnerships too, and community partnerships in particular. I mean, to say that, any care delivery system, I think, can be all things to all people and do it really well is just not realistic. And so, how can we do a better job partnering with others that do provide, mental health services or, chemical dependency and addiction services in a way that still feels integrated and seamless. And so that's, where we're putting some upfront investment. And, a tangible example, we have a program called Resourceful. So as a, primary care doc, if I've got a patient in front of me and we've pre-screened them for, their health and safety at home, if they've got access to food and a safe home environment, all the other social determinants of health, it's available to me immediately. And when I'm seeing that patient in the room, and I can place a referral directly into our system to community partners that can provide that care more seamlessly. So that's the sort of, I think, integrated care and next level integrated care that will help us maybe pave a better pathway for mental health and well-being.
And do you think that referral is responded to in a timely manner?
And that's where we track it and using, data to understand who are at highest risk, where our care managers can kind of supplement that extra nudge if that care, referral was placed and they didn't seek the care, what are those barriers? And again, if I know that transportation is already a barrier, why would I place a referral, to see it's solving that transportation barrier first at the same time I'm placing a referral to a behavioral health resource in our community.
Good. Yeah, I agree with all of that. And I think it's also hard to get beyond the asymptote of what the health system as currently defined now under value-based care can do when 40% of the factors that have an impact on health are outside of what we consider to be traditional healthcare. And when we were in full subcap, when I was in practice, we were paying for groceries for people. we were paying for taxis for people instead of chair cars or ambulances for them to get to dialysis in a timely manner, et cetera. And, most people would say, well, that's not, how we should be spending our healthcare dollars. But it is if the outcome based on how we spent that healthcare dollar is twice as good as it would have been otherwise. And part of the problem is our perspective, widening the aperture on what we consider to be healthcare spending probably takes the $4 trillion number that Dave mentioned and blows that up completely. But it's going to be essential for us to get to an outcomes-focused improvement in health, which is the theoretical raison d'etre of value-based care.
Thank you. Dr. Pritchard, directed to you. How often do you think doctors avoid the hard conversation, MRI example, and just let the insurance companies deny it?
All the time. I mean, because you're under a time crunch. You're under a time crunch, you're under a patient satisfaction crunch, and that's part of the problem. We can talk as, I'm putting my administrator hat on right now. I understand value-based care from the business perspective. I also understand a little bit from the operational perspective of sitting in front of a patient, and I can tell you, once you hit the 15-minute mark, you're like, I got to get moving. Or this patient's going to give me a 0 on my patient satisfaction score because I didn't give him an antibiotic, I didn't give him an opiate, I didn't give him the MRI that he wanted or she wanted. So to answer your question, I think it happens a lot. And that's what I meant before when I was saying the incentives aren't aligned. So if you're going into value-based care and the patients aren't even on board, it's very hard to keep moving that. And let alone the payers, the pharmaceutical companies, the hospitals, the providers, patients still aren't on board. And that's part of our, I think, my opinion, part of our culture. You don't see that in some, socialized countries or Scandinavian countries or Japanese because they have a different culture. Ours is, I want it yesterday. I want it at the speed of McDonald's. I want it at the enjoyment of going to Disney World, the speed of Amazon, and I want it now. And it's, so to answer the question, just point blank, it happens a lot. And when I go out and talk to my partners about if there's a trend, like why did you order this many MRIs? I mean, I'm trying to be gentle about it because I know I've been in that chair where you're trying to argue with somebody and it's just not going anywhere. Now, sometimes I think it's a lack of standardization too.
And I would definitely say our primary care team, and they're the locus of the, the relationship with our patients. Will tell you it's gotten worse. What you just described has gotten worse as the trust has been eroded over the last several years in particular. So patient engagement, I mean, whoever solves, patient engagement will be the clear winner. So.
Thank you. Couple of, I think, related questions. And we've talked about this, shared some articles on it. We've been talking about value-based care for over a decade now. It's been 15 years, I think, since the Accountable Care Act was passed. Why does it seem like we're still experimenting? Okay. And value-based care models haven't changed healthcare significantly. How can we better align the incentives? So why are we still experimenting?
Because it's working for those people that are getting it right now. That's my opinion. Look at the 10K.
Current system.
The current system. The only people it's not working for are the patients. You have hospital systems that are doing relatively well. On the other hand, you have hospital systems that are doing very poorly, especially in rural areas and things of that nature. Pharmaceutical companies are doing very well. And I'm not trying to rip on any one of these components. I think
Healthcare Inc. is.
I think they're all important, but they all have their own agendas. And why would you change something if it's working well for you right now? You can get billions of dollars in profit. And that, again, it goes from my partners too. I always never want to say it's the insurance company's fault or it's the pharmaceutical company's fault. My partners, at times I look at the number of procedures we do, especially when they came out a couple of years ago with studies about treatment of coronary artery disease. Half the time we can get away with just medical treatment versus stenting or caths. We still do a boatload of stents. And the hospitals aren't complaining about that because guess what? They get the revenue. I think it's, to me, and I'm being very cynical right now, but there's no pressure to move it. And I really don't, and there's also, like I said, there's patients that once they get in front of their physician, they want it all. So they're really not really up for you telling them, well, I'm sorry, this has been rationed, you can't have that. That would not go over well in my office. So that's my cynical opinion. I can step away now before people
appreciate your
shoot me, but.
I mean, I might say, I think in rural care delivery in particular, we're closer to the tipping point where, the current system isn't working for more than, just the patient. So, certainly I'd say Essentia Health would attribute a lot of our current success with quality outcomes, financial stability right now, because we have decided not to treat this as an experiment. So, and you're going to see us continue to say that this is the right care, and we want to go more all in with payers and take on even more risk because we do believe that this is the right care. So I wonder if rural care delivery isn't more at the tipping point because we are, challenged with patients that have, compared to their urban counterparts, they're just sicker, they're older, and they have more access barriers to care. And so this is the future, we believe, of care delivery.
Thank you. Scott, any comments?
Yeah, I agree with everything that's been said, but not to oversimplify, I think there are two very strong forces that have left us where we are now. One of them is culture. It's our physician culture to some degree. As we're trained to be scientists. And what scientists ask is when an experiment, when you're reading a scientific paper about how somebody else did it, you look at how they did it, you look at their results, et cetera. The level of innovation that we're going to need to engage in over the next 10 years to meet a 55% increase in demand. Remember, that's 55% increase. Somebody framed it differently. They said something like 1 in 3 people would need to be providing healthcare by 2030. But that's because between the demographics and the disease burden that we're looking at, we expect to see a demand of 55% more than we have right now. We can't even meet the demand we have right now, by and large, in many places, right? So consider that. So, and so back to my point was really that as physicians, we are trained to ask the question, well, who else did it differently and what kind of results did they get? But the degree of change that we're going to need to engage in is not going to allow us to have that level of experimentation. And part of the challenge around that is the other factor, which is that experimentation and innovation are great when failure does not result in death or in really catastrophic outcomes for people. And so we tend to be more conservative in delivering healthcare because of the consequences of failure in innovation can be more significant. I mean, you have to be able to fail, right? So you have to design your approach in such a way that failure does not result in something really terrible for somebody in healthcare. So I think that's another inhibitor, but that's just my perspective.
Okay. If Congress passes a DOGE initiative to get rid of fee-for-service in 2026, what happens next? So I hadn't heard about this on the list, but anybody want to is it on the list?
It could be as of an hour ago. Who knows, right?
Somebody pull out their phone and look and see what happened. I mean, like, I think we've all talked about the fact is that we don't have a lot tied up in value-based right now. If you got rid of fee-for-service, there'd be a lot of overhaul. I don't even know how to answer that question. I really don't.
Things easier.
Well, I guess it depends. I mean, I don't know how to answer that. I'm going to just butcher it. Do you have a thought? Anybody?
Well, I mean,
goes away.
Having operated under full subcap, right, at some point in my career, I would say that if it's structured properly, it could be the greatest thing ever. I mean, when you listen to people who practiced critical care medicine during COVID, they were able to throw out the book on what they build and all the rest of it and just take care of patients. And it was a good experience for them. And eventually it was a pretty good experience for the patients. Now, that's not to say there weren't some missteps about putting people on ventilators that shouldn't have been on ventilators, et cetera. However, at New York Presby, where I was at the time, it really was an incredible cultural transformation for people to let go of some of the administrivia, a lot of the administrivia that we've all dealt with and that has driven us and our patients crazy. And in a full subcap model with no fee for service, you can do that. But it has to be structured in such a way that you don't lose your shirt, the system doesn't lose their shirts, and costs don't skyrocket. And so if we're going to have responsibility for the cost of care, which is the only alternative I can see to fee for service, unless somebody else has a better idea, then we're also going to have to rethink governance and how we measure outcomes and how we hold ourselves accountable for those outcomes in a much more meaningful way than we do now, because we don't do that very much now.
I agree with Scott. I was thinking more of this question, like if somebody turned off the thing tomorrow, the business models that we've all established, there would be so much disruption. But if you could ease into that, set up a structure where you'd say, yeah, we're going to have a capitated model, you're full at risk, but you have this, this, and this, it could work. It's just going to be very difficult to get all the stakeholders to agree to that, if that makes any sense. I was thinking of more of immediate, like you got hit by a tsunami, what happens? I don't know.
Got a letter in the mail.
You run. I guess.
We're done. Okay. What have been the most important lessons learned from implementing value-based models so far?
For me personally, for our system, or
Yes.
for everybody. I'll give an example. I think about this guy all the time. I had a 96-year-old patient a few years back, prior, even a little bit before value-based care. And he had the big Coke bottle glasses, and his family was complaining that he was drinking Pepsi and his diabetes number was a little high. And I remember looking at him and saying, "You like your Pepsi?" He said, "Yeah," and he shook his head and his goggles floated up and down. But I said, "Let him drink it. He's 96." So the reason I bring him up is I remembered him. The last 6 months of his life, we admitted him 4 times to the hospital, and he eventually died of heart failure. And his family and I are in good terms, and they said, "That was so sudden." And I remember thinking to myself, "Oh, it wasn't. He's been passing away for 10 years. And I mean, we've been fiddling with his medications." But my thought on that was I was very tunnel visioned. I was not thinking of the entire process. I wasn't thinking about the entire person. I was thinking about what were these numbers doing today and what was I going to do to fix it today. I was not worrying about, should we get hospice and palliative care and all that kind of stuff. So I thought I did a really crappy job of serving that patient, to be honest with you, and his family. So for me, when we started thinking about value-based care, you start looking at the entire picture. How can we make sure that we're coordinating with hospitals? How can we make sure we're setting up hospice and palliative care? How do we look at total cost of care? I mean, for example, this particular patient, I look back on it, I'm like, if I would have been looking at this as a better process and value-based care and communicating with them better, I would have probably saved $50,000 from admissions, and I would have given him a better life, better quality of life. So for me personally, it's trying to put an emphasis more again on the patient outcomes. I think if we focus on that, in many instances, the revenue streams, or not the revenue streams, but the expense reduction at the very least would be improved. So I don't know if I answered that question either, but that's what I've kind of learned from it personally.
I'll maybe go at this from a slightly different perspective. So this is my third integrated care delivery system I've worked for, and it feels significantly different at Essentia Health. And certainly it could be, again, that this is a rural care delivery system that understands that this is the future where everybody is likely to win. But I will tell you, I think the secret to our success is, the alignment all the way from the corporate board down to the front lines about how important it is that we, move move towards, fully integrated value-based care as our fundamental way that we deliver care at Essentia Health. And with that, I also, mission-driven, values-led organization, and teamwork is one of our values. And we are successful because we partner together as a team and truly an integrated care team. My specialists are all invested in the success of my patients' outcomes as I am in a primary care provider. That feels very different than it has in the other care delivery systems I've been. And then just this culture of accountability. I mean, we're a physician-led organization, but we hold all of our leaders, operational, physician, all accountable. And that's also, I think, critically important if you're going to go all in on a care delivery model change. So
Are your specialists productivity-based compensation?
A mixture, but integrated, all integrated, all on the same electronic record platform, and I shared this with my two panelist colleagues, not a single incentive quality dollar is spent on this. So it goes back to those intrinsic versus extrinsic motivators that Daniel Pink, really talks about. I was shocked when I joined Essentia Health that we had, neck and neck in the state of Minnesota for our clinical quality outcomes, and we didn't pay our clinicians a single cent to deliver high quality care. So.
Thank you. Paul, specialists compensated on productivity?
Mostly productivity. I mean, obviously, there's, again, instances when you need a particular provider in our neck of the woods. There's not a lot of gynonc, for example. So that's a salaried position. So it's a little different because we need her. She needs to be in our system, so we make exceptions. Some are production, some are salaried, some are a little bit of both. So it just depends on what's the environment in your neck of the woods. What can you really sustain, or what do you need?
But it does create a conflict between incentives, doesn't it?
Oh, definitely. Yeah.
Not much to do about it right now?
Not right now, no.
Okay.
I think that it takes really strong leadership and really strong culture to be successful, and that takes time to develop. Obviously, we've seen in the ACO experiments under MSSP and in other places, but that it is possible. But there are a lot of systemic barriers, there are a lot of structural barriers, and we need to get serious about trying to overcome some of those. But it's absolutely doable, and the results can be wonderful when you actually can align those incentives.
Okay, thank you. Patient behaviors and wants are a barrier to value-based care. True? Let's put that in there.
I think you've highlighted that very nicely. Yes, I mean, it is. Patient engagement in general,
Is patient satisfaction an issue if there's a pressure from admin to maintain, increase Net Promoter Score? Are you looking at Net Promoter Scores, patient satisfaction?
That's part of our monthly reports back to our departments, is Net Promoter Score, because it's tied to CMS kind of repayment models.
Yeah, but if I don't get my MRI,
right,
I'm going to give you
you're going to give me a big fat zero.
Yeah.
So yes, we do look at that, but it's also I shouldn't say it in this setting, but I did have a nice word for it the other day at our department chair meeting. It's don't be a jerk, but I replaced the jerk with another word. Because you're in a service industry. You want people to come back to you. You want them to feel comfortable with you. So there's ways about telling them they shouldn't have an MRI. There's kind of a happy medium there, or a balance where, yes, you need to have customer satisfaction, and you have to have providers be aware of how they're being viewed by the patients. But it also is, I think it's an issue where if you focus on it too much, like an urgent care department, they get very frustrated because we put antibiotic stewardship, which I think is important. We've also put opiates on their kind of quality measure. How many times are you giving out opiates for low back pain? How many times are you using antibiotic for bronchitis? That kind of stuff. And they're always worried about, well, what are my patients going to say in the Net Promoter Score when I tell them no? So it's a constant struggle in that.
Thank you. Thoughts?
It is, but I will also say, I mean, we know there's clear data that says, when you have higher employee engagement, you're more likely to have more engaged patients, and we know that more engaged patients mean, better quality outcomes. So, certainly you're absolutely right. I mean, it's a matter of, that balance, and, the artful way of saying no, and here's why. But, certainly an important focus and balance as you're delivering high quality care.
I think the how really matters, as you point out, which is that if you need to say no, right, you might need to say no conditionally and say, I don't think today, how about if we do this? How about if we have a contract where we wait a couple of days before the antibiotic and you don't see this, I'm more than happy to call this in for you, or call it into the pharmacy, but don't use it unless you really need to. I mean, some of those kinds of conversations can work. The MRI thing is always a tough one because everybody wants full body MRI now. I think the how matters a lot, for sure.
Good, thank you. The articles that we had shared before this panel discussion, one of them talked about how there's too much reliance on the metrics, right? And the metrics are getting in the way because standardization is good, but unique is necessary. And I think that applies to the metrics too that we're looking at for value-based care. I often think about back in my days at CLA working on compensation for provider groups, compensation for physicians, compensation for specialists. And it's per RVU, right? You could not get away from paying based upon productivity. I would often talk about, well, how, and then coming from an accounting consulting firm where the owners, our compensation was subjectively based upon objective data, right? Allowing some human element in there to say, boy, you've got good metrics, but you're gaming the system. Your metrics aren't good, but you're doing some other things that we can't measure that are really important, team building, et cetera. And so I always get concerned that we're a little bit too metric oriented in healthcare. And it's that scientific physician training saying evidence-based. And so hopefully we can move away from that someday.
I think there's another dimension to this when it comes to patient engagement to keep in mind too. I had a great conversation with the CEO of the Sutter ACO. And his point was that in healthcare, we do kind of a bait and switch activity. We are basically telling people we're going to take care of their heart failure or their diabetes, but it's really more like you're going to Amazon to buy that beautiful desk or that beautiful crib for your kid. And that's what you're seeing, right, when you click buy. And then when it comes to your house, it's in a flat pack, and you have to spend about 3 hours assembling it, and you may get it wrong a couple of times before you even get there in the end, right? So what we're promoting to people is a simple concept around health, but what we're really selling to them is something of tremendous complexity. And his position is that in healthcare, we need to take the role of absorbing complexity and projecting simplicity. And I think that there's a lot of opportunity for us to do that better, but it's a system level issue, right? This is not necessarily on each of us as individual physicians to do that, though we play a role, but also we need systems that are actually patient-centric, that actually focus on the individual at the center of the interaction, as opposed to the system, as opposed to what's convenient for us or what's convenient for the hospital because all the services are concentrated here. And Dave earlier had a really good point about how many organizations, as they mature, they decentralize, right? In other words, they're much more capable of offering services closer to their consumers, right, at a lower cost point. And we're really struggling to do that in healthcare.
I mean, the metric issue is the thing I worry about with metrics, and I don't know about your system, but we one time looked at all the different metrics that we're asking our primary care docs to evaluate during a patient visit. There were 37 of them. We usually have best practice alerts, health maintenance things, those types of things established in our EMR. And if if we haven't established the system well enough, which sometimes happens, those things are left for the physician to do. So they become a keyboard warrior. I noticed that myself once a couple months ago. I'm sorry I keep using these stories, but this is the best way to get my point across. I had a CF patient who was talking to me about, they was kind of giving me their history, and I started asking them the depression screen, and they said, of course I'm depressed. I have 15% lung function. And I'm like, well, okay, I'm going to put this away now, and I'm going to actually pay attention to what you're saying because this is stupid. And the metrics got in the way in that particular instance because I was spending way too much time focusing on those things and not who was sitting in front of me. So for me, I think a lot of these things are important, especially when you're talking about social determinants of health, and we need to get that information. But how do you operationalize it? How do you get it in there so that it's effective, but it's not taking away from the interaction?
I mean, I might just add, because I think a caveat to that is, we talk a lot about metrics that matter. So, in that individual patient interaction with my patients, what are the metrics that matter to the health and well-being of that patient in front of me right there? Absolutely. The biggest issue is in primary care right now. There are the quarterbacks of this, transformation from volume to value. Absolutely. But, we're empowering our front lines to help, select their sites of service. What are the metrics that matter to them today that they can work on continuous improvement? So, certainly with guardrails, given to them, but you will not be successful as an organization. And that's what we spend a lot of the time on our ACO board is saying, what are those key metrics that matter? And then driving all in the same direction and go all in on that.
Thank you. Last question. So some nice person shows up at your organization and they say, here is $1 million. I'd like you to invest it wisely and take into account value-based care. Where are you going to spend it? How are you going to spend it?
I was going to be a smart aleck and say I'd just take it and run to Jamaica, but that's...
We know that one. Scott, you want to apply that? If you were talking to one of your clients, where would you say we need to invest more as it relates to value-based care?
I think I would probably start with, do we have visibility into what's going to have the greatest impact on outcomes for your population? And if we have that, then that's an easy question to answer. It's often, for all of us in this room, the most problematic question to answer.
You?
It would be a drop in the bucket, but I would still say technology.
I agree with Scott. I mean, I think, we don't do enough into actually identifying. I think we know what's going on. I think it's transportation. Oh, it's money. But I don't really know if we know. So why would you put $1 million towards something if you don't even really know what's the root cause? I'm not sure we really have a full grasp of that yet.
Thank you. With that, let's wrap it up, and lunch is next. So, round of applause for our panelists. Thank you.
So next up, we're going to discuss the next generation of innovators in the healthcare industry. Moderating this panel is going to be Ryan Johnson. Ryan is a corporate healthcare attorney with over 20 years of experience representing healthcare companies in a wide variety of transactional and regulatory matters. He serves as outside general counsel for many of his clients. He co-chairs Frederickson's Life Sciences Group and is an adjunct professor of law and policy for the University of St. Thomas Healthcare MBA program. Please join me in welcoming Ryan Thompson.
All right, hi everyone, and welcome back from lunch. It's actually been over 25 years. The bio's a bit stale. Time flies. So we have a great panel on healthcare innovation. The way it's going to work, I'm going to have each of the panelists introduce themselves and tell us a bit about their company. I have a couple of starter questions, and after that, we're going to go to you. You've had great questions today, very engaged, so please send your questions up. We'll try to get to them, but let's get rolling. And we start here with Thompson and kind of go down the row and introduce yourselves and your company.
Good afternoon, everybody. Thompson Aderinkomi. I'm the co-founder and CEO of Nice Healthcare. Nice Healthcare is a technology-enabled in-home everyday care clinic that combines in-home and workplace visits with virtual care wrapped around with ancillary services like free prescriptions, in-home labs and tests, and imaging and x-rays. And the wonderful School St. Thomas is a client. Very excited to be here, to be part of the panel. And my background in healthcare is I'm a health economist, statistician that found his way to the provider side.
I'm Ty Cook. I'm with Tegria, where I lead strategy and business development for kind of our access transformation service line. Tegria provides consulting and IT services across the market. My background is I spent the first 10 years of my career at Epic leading the implementations of kind of the enterprise application suite across the country. I've also spent time in private equity-backed service companies, venture-backed AI companies. And I think I've landed in, a lot of that it can be useful if the operating model is actually aligned. And otherwise, we're only going to get so far with tech. So it might be a little bit of an interesting perspective on an innovation panel.
Good afternoon, everybody. Kyle Nelson. I am a recovering CEO of Healthcare Delivery Services, but am the current founder and CEO of EnviroCare Health. We are taking environmentally sourced material and reverse engineering medical devices and products to be used in clinics and hospitals all over the world. Our first product just went to market in October, and I know you guys just got done with lunch. Our first product is a way of capturing human waste, so I apologize for what we're going to talk about a little bit today. Thank you.
Thank you. I'm Mike Madison. I'm a neurointerventional surgeon, so I spend my time treating patients with primarily stroke and brain aneurysm. It was mostly in the stroke patient population that I have become deeply frustrated with the lack of planning that so many of us apply to our end-of-life experience. And the result of the lack of planning is that it's a lot messier and more dysfunctional than it needs to be. And we're in the business of care delivery. If we can do medical interventions and those medical interventions result in patients living longer and better, we do that. It's just when we get to that place where the medical interventions no longer promise either a longer or better remaining life, that's where it gets more difficult. And I think we find ourselves in our end-of-life experience in the healthcare delivery business often addressing those questions because patients haven't addressed them ahead of time. And that puts a lot of burden on their families, and it just creates all sorts of problems. And we saw this in COVID, patients dying alone in ICUs. It was very tragic. So I started a company, a digital advanced care planning company, to try to address this deficiency. And we're just trying to get more people to plan ahead for their deaths to help themselves and their family die a better death. So, and that company's called Thanacare.
Great. Well, thanks for the introductions. The first question deals with investment and sustainability. The healthcare startup space is very, competitive. So what are investors looking for today, and how do you balance, profitability with, focusing on, the patient? Maybe Thomas, we start with you.
I don't know, am I the right person to ask about what investors want? What do investors want? Investors want money and a return. So that's what they want. It has nothing to do with patient outcomes, lowering healthcare prices, increasing discretionary income for low-income, middle-income families in this country. So if you can demonstrate that you can put the word healthcare in your company's name and produce lots of profit, massive profits, and grow very, very fast, irrespective of your ability to impact healthcare, you will be able to convince healthcare investors to give you money. And if you do the reverse of that, you will not get investor money for your company.
Just go down the row here. Ty?
Well, I think Thompson framed it well. I think the part of the question that maybe I think of through this lens is, what's the right type of investment in healthcare? I'm not sure that private equity in a 3 to 5 year investment horizon works on a problem that is this broad. And I think the venture model can be helpful early on, but I'm not sure that growing for the sake of growth's sake into the complicated environments that many of you are familiar with is necessary once a company gets beyond a certain point. And so I think the stewardship of investment dollars has a lot of room for improvement. I think some of the investment community is realizing that, but I think it's also incumbent upon people that are playing and starting companies to know when to say no and when to say yes. I actually looked at acquiring the assets of probably one of the most well-funded companies, and the story was, they went into the board, talked about growth at X amount of dollars, and the investors said, here's 3 times that, go double it. And again, if they would have said no, that might have changed the trajectory of that particular company.
Yeah, to piggyback off of that, these investors that approach you or you approach them, they're looking for a big ticket return. We're talking 5, 10x in a very short window of time. I would suggest if you're thinking about going into this space and trying to innovate and start doing a startup, take the initiative and drive that. Push them back and find the right fit for you. Because when you do that, capital becomes more available from the right people. And when we talk about stuff like strategic partnership, every angel investor, PE, you name it, is going to tell you how great they are. But it's really what can they do for you to 10x your business.
I agree with all the comments. I would say, specifically Thompson's comments about not caring about the patient outcomes is a pretty important point of understanding. I think that when you go to scale, sometimes you need additional resources. Our approach has been to partner with in terms of investment, I've been to partner with the people we partner with, mostly the people in the healthcare delivery business who are equally responsible for determining patient outcomes. And so I think that's been our approach. And it's, I'm a big believer in win-win business. As I've left the cloistered medical environment of being a physician, you realize out in the real world, people don't really care if you win when you're in business. And so partnering with people who do understand why patients are important when it comes to investors, I think those are the kinds of investors we're looking for.
Thanks. So Michael, both you and Kyle mentioned, collaboration partnerships. How can startups, effectively collaborate with, larger players, hospitals, insurers, et cetera, and still maintain their sort of disruptive, innovative edge? Michael, we'll start maybe with you.
I think that it isn't always easy to partner, especially when you're a startup. Healthcare systems, the larger organizations, they are resistant to partnering with startups. At some point, you're around long enough that maybe you start to lose that label a little bit. But it is something that I feel that the resistance is real, and you have to be honest about it. We've gone around different ways of getting around that with pilot programs and programs that don't put them at risk to prove ourselves prior to larger expanded relationships. But I do think that those issues are real. I think that when it comes to technology specifically, we're a software business essentially, and when you're interfacing with hospitals and healthcare systems around here anyway, they all have Epic. So major roadblock. If you're not Epic and you want to get into a partnership on a technological basis and a software with a healthcare system, Epic is a major problem. Now they have control of the environment. I don't blame them for exerting that control. And they always have answers to whatever you're doing. Like they have an advanced care planning platform. It doesn't work, but they have one. So they kind of check the box, But interfacing with Epic is if you get to that place of a partnership with a healthcare system, we have to build out that interface, which we've done and we can do. It's real money, $150,000 to do it. And so usually we try to prove ourselves with these partnerships on a smaller scale outside of Epic before we ask them to incur the cost of embedding ourselves within Epic.
Great.
Sorry, I didn't mean to diminish Epic.
Actually, let's go to Ty.
Yes,
Let's
I
get
did,
your thoughts.
actually.
As a counterpoint. Right.
Did I say don't judge me one way or the other on? I would say when it comes to the partnerships, particularly early startups, your first customers are your partners, whether you call them that or not, and whether they are investors or. And I think choosing the first partner or the first customer out of the gate is as important as having a good product idea in many instances, because the reality is your product or your service is going to evolve once you actually get it live in the real world. And so through that lens, I would maybe answer the question directly, is it relates to working with the incumbent players, and they are real. Again, if you are trying to be a health tech company that is playing in an enterprise provider space, you're going to have to navigate those waters. There are ways to do it, and the partner is the key. The customer is the one who will need to act as your sponsor to take that torch forward for you. And it has worked in many instances, but you're right. Epic does throw its weight around.
Just to layer on top of that, we're pretty new to the market. Went into a couple different hospices across the country in October of last year, and we don't look at them as customers; they're stakeholders in our success. So keeping in constant contact with them, getting feedback, and we're new. We're trying to innovate and break through in our current product of capturing human waste. The standard of care right now goes all the way back to the 1800s. And so we're trying to break decades of thought in how to do that. So what we did is when we went, we had these delusions of grandeur that we were going to capture the Mayo Clinic and HCA and all this other stuff. And that's just a fallacy when you're hitting the startup phase. So we went back to the drawing board as the advisory committee and said, hey, who can we actually get for early wins and can become a champion for us as a stakeholder? And we went small. And we put our money where our mouth is and say, hey, we'll give you your money back. Buy X number of units. If you don't like it, by the time it's expired, we'll write you a check back. And to date, no one has asked for their money back, as well as they continue to buy from us. So it's really, you got to take a little bit of a gamble.
Thompson, any thoughts? Okay. So following up on that comment, one of the audience members asked, what's the business model for each company? You're talking a bit about how you structure relationships, but what's the business model and how do you generate revenue and what are your major expenses? Maybe starting with you, Thompson.
So Nice Healthcare, we're a fully capitated clinic, if you will. So we don't collect fees via fee for service. We do not accept any third-party reimbursement through Medicare, Medicaid, insurance companies. All of our fees come directly from the employer. So for example, St. Thomas is a client and they pay a fee per employee. And then that employee and their all their dependents get access to Nice for free. And then they can use the service as much as they want without any limits at all on the service. And the savings accrue to the patient because they're not paying out-of-pocket costs to access everyday care. And savings accrue to our client, the employer, because their claims expenses are being reduced. And our major costs categories are people. So we have an engineering team, a product team, like we have all those normal things in a tech company, but by far the largest expense are the clinical team, which spans nurse practitioners, physicians assistants, mental health therapists, and then the prescription drugs and x-rays and imaging that we provide our clients.
Our biggest expenditure is R&D. And, with a few of the panelists earlier this morning talk about politics, my other biggest one is tariffs. There's a lot of ambiguity out there as to what's going to happen with importing product. And so, right now we are producing revenue, but pumping all of it back into R&D for product number 2 and number 3 and going through the IP process with that as well.
So nationally, 10 to 20% of people have documents done regarding their end-of-life wishes. These include the pulse documents, who's going to be the most important decision, who's going to make the decision for you in the event you can't make decisions, and then some of the other broader advanced care planning conversations. So the documents aren't done in a very small number of people, and when they're done, they're often not available because they were done with a lawyer. They're at home in in the file cabinet or whatever. And so what we do is, we have different business models depending on who our customer is. And when it comes to hospitals and healthcare systems, we're mostly focusing in on care management patient populations because they are the sickest patients. End-stage renal disease, congestive heart failure. We get the documents done. It's all done by remote Zoom Teams meeting with the family members. We give them a QR code that they can launch the documents. They can carry it in their wallet. We make sure that we integrate all that information back into the healthcare system to get the documents done in those patient populations so that everything's clear about what they want. And why that is monetizable is that if they have the documents done at end of life, not only do they spend less time in the hospital, they don't die in the hospital, they die outside the hospital surrounded by their family, which is what they should be doing, and they spend less money. And so that when you're looking at reducing the MLR and value-based contracts, there's a significant return on investment within a relatively short period of time. And so it is a value-based contract conversation that is working and will work. And, it's a win-win for, the patients do better, their families do better, the caregivers do better because they don't have time for these conversations. And the hospitals and healthcare systems and payers who are engaged in these value-based contracts do better because they reduce the MLR and are better able to perform. So it's one of those few areas where we're not really restricting care that is perceived to be a negative.
Great, thanks. So the next question from the audience. The keynote speaker this morning led us to believe that the revolution will be bottom-up and consumer-based. Are you ready to scale your business? Tempted to start with you, Kyle, but I'll start with Thompson again. Yeah.
Really? Sure.
All right. So I think that's maybe a soft pass.
Since my product is capturing human waste, yeah, we're coming from the bottom up. That was too easy. Whoever wrote that, I want to thank you. And I'll give you a $20 bill outside. But there definitely has to be change in healthcare. I prior to starting this business, worked in a clinical setting in multiple different CEO capacities, mostly in the orthopedic space, and everybody out that was here this morning talking about change. It has to happen. You look at the overall marketplace and the number 18% was mentioned. That's a lot of money. And, I forgot who was mentioning it. What happens if in the next hour, they cut funding for Medicare, Medicaid, what have you? What are we all going to do about that? And I think we're in a space right now where we have to start just jogging with our team around what that means to each of our organizations and ours included. We have contingency plans for what if we don't meet certain sales goals, but for you guys on the delivery side, it's a rough water out there. So I sympathize.
I wasn't here for the conversation this morning. Could you repeat the question?
Yeah. So the question was, the keynote speaker this morning led us to believe the revolution will be bottom up and consumer based. Are you ready to scale your business?
Oh, that's wrong. That's 100% false. It's just not possible. And we've been trying for decades already, and we need to stop saying that, in my opinion. Because really think about it. What is the goal of the revolution anyways? No one ever says what the goal is. For me, the goal would be that there's more access and lower prices. The discretionary income for average everyday families increases. For that to happen, the price of healthcare charged to the end user would have to decrease. That would have to come through insurance premiums or our Medicare taxes on our paychecks. For that to happen, clinicians, hospitals, health systems would literally have to lower their prices. I don't know how they would do it. Maybe they'll pay people less. Hey, instead of a raise this year, you're going to get a decrease. We're so efficient. We're actually going to lower our prices because this AI thing made us, be able to treat more patients in less time. Think of what world that would happen on. It's possible, but certainly not in this country, anyways. And then if you couple that with the fact that healthcare is not a normal good, none of us have the choice to not buy healthcare. If you don't like barbecue sauce, you can buy ketchup. I mean, or you can not use any sauce, which is weird, but like, you have the choice, but we don't have the choice. So you cannot have a free market when the purchaser and user doesn't have a choice. They can't go to a substitute. You can do Disney, or you can do Netflix, or you can go to the movie theater. You can't do that in healthcare because no one wants to be in pain and no one wants to die. So the notion that you could have a free market driven by consumers that have no choice but to buy the service and get lower prices that could only be produced by literally paying people less, or just like closing half of the hospital and not staffing it, that is an absurd, proclamation that we need to stop saying immediately.
Any reaction from the panel?
Thompson and I had dinner last night for like 2 hours, and Ryan got to listen to the conversation. So we went deep here, and I agree. I think the problems we're talking about in our healthcare system, and it is a healthcare system. Often we look at the provider side and talk about prices, for instance, and it's like they don't really set the prices. That's influenced through what goes on in insurance and in pharma and in the regulatory landscape. And we have to look at it broadly through that lens. It's significant, as Thompson's talking about. That is a significant amount of institutional foundation that would have to radically change for true supply and demand dynamics to apply within the healthcare setting as it exists. I do think we are seeing some organizations that are tackling this problem in unique ways within the confines of our system. I'm aware of a group, for instance, they're a huge dental services organization that are in 26 states and have about 10,000 dental offices. And they're starting to put RNs and PAs in their dental clinics and offering primary care as part of that process. It's a different way, and I think you'll continue to see more and more entrants into the market looking at how do I take on chronic disease management and utilize technology like saliva detection and imaging. I think you heard about breath analysis earlier from one of the panelists. You will continue to see organizations pursue that. The pie is too large and the problem too immense to stop. But I often kind of think that it might be interesting to see what happens in more of our developing countries where they don't have some of the infrastructure that we do that we have to work around, but they don't have that. And what would happen in India or in Africa where mobile is widely adopted, you're continuing to see the access to information grow. It'll be interesting to see if they beat us to the solution because of the relative lack of kind of barriers that they have to work around in their particular areas.
So in with Thanacare, I'm not trying to solve all the world's problems. I'm just trying to get everybody getting their advanced care planning documents done. And so that's my mission statement, and that's our mission statement. And so there the issues are, we spend a lot of money and continue to do that on product development, putting it in every different language, making sure all the different cultures and religions are represented because everybody's got the specific set of issues and concerns. And that's a work in progress. But we're making rapid progress in that regard. Also, it's interesting kind of applying a version of AI, and that is that people who have specific diagnoses have specific issues that are reproducible. The end-stage renal disease patient population, there are a series of small number of questions that related to that conversation, to dialysis and things of that nature that are
are present in the entire population. So we're kind of incorporating all those into the discussion with those patients. Many of these conversations at this point in time are not self-directed because they're too complex for the patient to understand and their family to understand. So we have to help them through that. That requires people. That's a cost. You know, we're trying to work on self-directed. We may or may not get there. I don't know how soon. I do think the patient populations that we're dealing with are generally Medicare and older, you know, and so these are not the most, you know, as a member of, you know, they're not the most technologically comfortable patient populations. And so they like people talking to them about important issues like this. And so I'm not sure it's really even a good idea to eliminate the personal contact, but scaling is possible. Our healthcare system partners don't often have the people. We have to bring the people to the table, but we can find the people because they can all work remote, and people like to work remote. So we can pay them to do this because it's all done on Zoom and Teams. So they can, my nurses can be sitting on a beach in Florida having these conversations if they want to.
Okay, thanks. Let's start with you, Michael. What advice would you give someone looking to drive change in healthcare? We start with you, Michael.
At this point in time, you really do need a clear message about how you can make care better and how it can be less costly. I mean, the healthcare systems are struggling in ways that I've never seen before. I've been in the business for 30 plus years now, and I've never seen or experienced year over year difficulties that they're experiencing. I completely disagree with those who think that value-based care is going away or not going to happen. It is going to happen. I don't see a day when the federal government is going to say, hey, we're going to start paying you more to manage this patient population. It's not going to happen. If Elon Musk is not going to do that. So we're going to have to figure it out. And I think that means we have to be cognizant of the fact that the historic model doesn't work. There's too many Medicare patients, there's too few commercial paying patients. And that's the way it always did work before, commercial paid for Medicare. That doesn't work anymore. So we have to be honest with ourselves and try to find those opportunities where we find them. The end of life experience for our patients is one of those opportunities.
Kyle?
I would make the recommendation, and I think all of us may agree, that do not fear failure. Feel free to trial error, use the scientific method, fall on your face. You know, it took me 3 years to get a product to market. I could have probably got it there in 18 months, but I wanted to make it just right so that it wasn't going to fail. But I was willing to fail over and over and over again to try to get this to where it actually had a sales pitch to it. Came up with the idea based off of conversations I had with people in the healthcare space, and you know, tried to then reverse engineer it back, but it took a lot of time, effort, money. I have not taken on an investor yet. It is all me. So I've written some big checks, but yeah, feel free to fail. You know, even in the clinical sense, get weird and make some just random decisions, not execute them, but throw them out to your team and see what happens.
Yeah, I think to build on that, I think you be bold, but also be focused and measured. Growing too fast often can be the death knell. So stay focused, build a product that really works, that solves a problem, and then expand. And I think the more you can do that, the more that you can control where you take investment or don't need to take investment. You can control more of your own destiny when it comes to the direction of your company. And that becomes really important at the board level. But the first and foremost, that you solve the problem, like, and be bold in it. Don't be afraid to fail. You'll learn a lot regardless.
Alan?
I couldn't say it any better. Yeah, absolutely.
We'll start with you, Thompson. There's a discussion we had last night at dinner, which I think this relates to. Is healthcare innovation truly improving equity or just benefiting those who already have access? So we'll talk about healthcare innovation, technology. Who is it helping, and what are the problems?
Okay, so Let me see. Let me buckle in real quick. So, I mean, who is healthcare innovation helping? Let's just go down the list. The first group it's helping are the financiers, are the people that have the money that are funding these so-called, I don't even want to say innovation. Like I get like acid reflux saying it. It's not real innovation. They're just funding technology. They're funding games, and they're the ones that benefit the most, from healthcare innovation. Because you can look throughout healthcare history. Let's just look at the last 75 years. How much innovation have we had in the last 75 years? Just think of like major innovations. Think of color TV, the internet, computers, EMRs, fuel efficient vehicles, more effective ways of building buildings, AKA the hospitals. I mean, telehealth, oh my God. We've had all these innovations. Now tell me, what was the cost of healthcare in 1950? It was 4.5% of GDP in 1950. Think of all the technology that we have accrued unto ourselves as a society between 1950 and today, and ask yourself, as it was applied to healthcare, who benefited? All that happened was that the financiers and those that control money, capital, if you're looking at neoclassical economics, we have capital and labor, capital benefited. But that big capital L stands for loser. Because we lost, as labor, L Riz, as my son would say. Seriously. So you don't have to do some big research project. You don't have to look back that far in time. Like, we know exactly what's happening, but we like to tell ourselves these magical stories that this technology, this time, AI, this time is for real. It's gonna make things better. The benefits will accrue to the masses. But if history has taught us anything, it just won't happen. And even if you didn't believe history, then you just have to do an Einstein-like thought experiment and ask yourself the question I asked earlier: what would have to happen for all of us to benefit through the application of a new technology to the healthcare industry? We just heard it, value-based care. The only way value-based care makes sense is if in every measurement period, the government's like, you know what, I'm gonna pay you 5% less. And we're just gonna keep doing that until it gets as close to zero as is economically possible. That is how you lower healthcare costs. It's top down is how you lower healthcare costs, not bottom up. I'll stop.
No, we're going all day. Ty.
Well, I was at the Vive conference earlier this week, and I heard somebody make a comment that I think is apropos. I think we're all paying the AI tax right now. That there's been a ton of investment, a ton of excitement, maybe hype, and we're starting to normalize on like what's real. And I do think it will be interesting to see if that actually leads to a reduction in the cost of healthcare being delivered. On the near term, I'm not quite optimistic on that. I think there will be winners, and those winners will consolidate capital. In some instances, and ambient's actually an interesting one, it might become commoditized. And if it becomes commoditized, then there is a potentially an opportunity for price to be driven down over time, but it won't start that way. And so I think that's what we have to, as leaders in healthcare, we have to be mindful of kind of where is this AI being developed? Is it really producing hard ROI that we can measure and share, or are we simply adding more and more expense into our delivery system, but we're calling it technology instead of some other category?
Can I give my time to Thompson so he can keep going? No, we talk about healthcare equity, and my product, I have this altruistic view of what I can do with it from an environmental standpoint, but also on a care delivery side. I've gotten a lot of fun conversations ongoing. One of them is with a doctor in Omaha, Nebraska, and she actually is the head research scientist in the country for Ebola. And we're having a conversation about sending the waste capture product over to Africa. And I think our endeavors and what we're looking at is not just on the domestic side, but as EnviroCare Health is, we're looking at it as a global mission and driven system. So, Thompson, I would love to have dinner with you and chat more, but I'll cede my time.
Thank you.
I mean, I think it's a difficult question to say that technology is going to save us. I agree with the comments. I mean, we spend 18 to 20% of our GDP on healthcare. No other developed nation spends more than 10. We're not getting more for our money in terms of lifespan, or what I prefer, health span. And so patient satisfaction, I think nationally, is not really high. I think the cost of the care is really debilitating to so many of us. Those of us who are in the provider business, these aren't the best of times. So it's not, easy to see a lot of positivity, but I don't think we have any choice but to keep moving forward and to keep trying to do better and to try to do it at a lower cost basis. And because that is what's going to happen. The federal government who pays Medicare is not in a position to pay more for Medicare. And so we're going to have to figure out how to deliver care as best as we can at a progressively lower cost basis. And I think that when you think of it that way, the application of technology, as it has in other industries, should give you at least some reason for some hope to think that we can find technologies to potentially mitigate the cost and make it easier to deliver that care at a lower cost basis.
And thanks. A follow-up question from the audience. Is our healthcare system too focused on innovation at the expense of fixing fundamental problems? And Michael, I think you started answering that. Maybe you can elaborate. We can come down the row.
Yeah, again, when it comes to value-based care, fee-for-service essentially created three buckets. There were providers, physicians in my case, the healthcare systems, and the payers. We didn't really like each other very much, and in many ways, those feelings are still kind of present. Now, if we're going to succeed in value, we really need strategic partnerships that are going to involve everybody. They're going to involve the patient, they're going to involve the caregivers, the healthcare systems, and the payers. And we all have to come together, the four different parts of that, and everybody has to win, and everybody has to participate. Value-based care contracts, if you're going to manage a patient population, you can't do it for a year and then have that patient boogie to a different plan. These have to be ultimately 4 or 5 year plans if they're going to work. If you're going to engage in care management for a patient population, you can't do that for 6 months and expect that you're going to have measurables that are going to get you to where you need to get to. So we need a long-term commitment from the patient, and the patient's going to have to take on responsibility. In return for being insured at a relatively low cost basis, you will participate in care management if you're defined as somebody who needs care management. You don't get the choice. There has to be a contract where the patient tries to help us by taking care of themselves. Most people, I think, would reluctantly sign up for that if the price was right. I think that the hospitals and the healthcare systems and the payers have to learn to trust each other and behave accordingly. That's not present today, which is one of the reasons why these things don't work perfectly. Notably, the payers have all the information, and they're not that quick to share it with the rest of us. And so as healthcare systems specifically have to become insurers, when they take on downside risk, that's essentially what they are becoming. They need information, and they need a partner on the payer side who's going to give them that information so that they can succeed. Most of the time, you can identify the MLR, the medical loss ratio. You can track it. You start out by not taking downside risk. You understand that you're leaving money on the table. You start taking on downside risk, and you focus on the patient. I think if we do those things and we all commit to actually making sure that we all win or we all lose together, we have a chance. If we don't do those things, I don't think it's going to work.
I think innovation, much like value-based care, is muddy right now. It's not clearly defined, and it is causing impediments to kind of making leaps and bounds forward with the healthcare changes that are necessary in the United States. I think at times we as individuals, as innovators that are up here, get laser focused on what we do and only what we do. And sometimes you need the reality check to step back and go, okay, how am I affecting other areas, not only in my business space, but elsewhere throughout the entire healthcare system itself. So yeah, I think focusing on innovation is great, but I would rather shoot with a rifle than a shotgun right now, just because we need to find better focus.
I think we turned on our digital front door and there was no place for the patients to sit. And so I do think we have to get back to kind of fundamental principles of aligning the demand of the populations that we serve and we care for with the supply of clinical expertise, and get doctors out of the business of doing things that a nurse or an MA could do, so that you can then have a baseline from which to think about where technology innovation can even be applied. And I think that's, kind of the heart of what I've learned in my career is you can't cheat that principle. And when patients need it, it's a different, I think we're quick to say patients are consumers. I think they're a whole different classification altogether. Because when you need healthcare, you need it immediately. It's a reluctant buying experience. This isn't buying your shopping cart on Amazon. And I think we have to adapt our approach, but start with that fundamental alignment of, do we know who we're taking care of, and are we putting them with the right person for their specific need at the right time? And there's a lot of room for improvement there.
I like to argue that we have to abstract up a couple more levels from the logistics and operations of healthcare when we're talking about innovation, because clearly it hasn't worked, because there's been plenty of so-called innovation, in the last 75 years. We all have to go back to Econ 101. Like, think back to Econ 101, everybody. Think about those charts with the supply and demand and the little Q and the arrows and the lines. Like, you got to go back that far. You got to get that basic when you're trying to fix healthcare. And here's the thing, is that if you define fix as it's more accessible and it's more affordable, well, in a classical economic model, if you want something's price to fall down, then demand has to fall down. But that we know that's not going to happen in healthcare. Okay, then let's increase supply, and that should cause the price to go down if you increase supply. Well, that's not working in healthcare either. We've built more hospitals, we've built more beds. There's like freaking 10,000 X-ray machines that cost way too much all over the place. So it's like, that part of the chart is not going to work. So how the heck? And I'm staying up high. So how the heck? What is the fundamental problem of healthcare that we must solve? It is lowering the price. How do you lower the price of something that does not respond to mechanisms of demand and supply? You just set the price. Like, literally. Like, everybody wants to get all fancy, get their PhD card out, and like have all these conversations, and have all these discussions and votes and policies, and rules and regulations. Like, no, you just set the price. You just say, no, that apple is not allowed to cost more than that. And then you build the infrastructure around that apple so that the apple does not cost more than that. Like, it's that simple. Like, all these conferences, you know how I feel about Vive. I mean, we talked about it. Like, all these conferences that people are going to, like, and talking and the panels. Like, no, just bloody set the price. Then you do some other things that are more tactical, right? Like, you make medical care or medical education free, so that you don't have that be a barrier. You get cross state licensure. Just have one. You apply once for your license and you can practice medicine anywhere in the country. Like, there's some practical things that you could do, but at the most fundamental level, we in the healthcare industry need to abstract up a level. Then I will end with this point. I know we're in the kind of the business school, kind of pretty close to all the businessy types. I have an MBA too, so I mean, I'm going to hate on myself for a little bit. But we have to challenge the primacy of the shareholder. I remember when I was in my ethics course in business school, the Carlson School of Management, and we're talking about the shareholder and ethics, and I just raised my hand, and I was just like, well, I don't care about the shareholder. why should they get to tell me what to do? And like, it made the professor very angry. I'll tell you that, because it just like, dismantled the entire semester. Because there's literally, you have an entire semester in ethics in business school that's literally telling you the most important thing is the shareholder. Like, it's more important than Jesus, Buddha, the Bible. Like, it's more important than anything. Shareholder primacy over everything. That does not belong in healthcare. The patient is the most important thing in healthcare. You need to get the shareholder out. So that is the second fundamental problem of healthcare we need to solve. We need to solve the price, which does not respond to supply and demand, and we need to solve the issue of the shareholder meddling with all of our healthcare.
So a follow-up question. So how do you foster a patient-centric organizational culture and not focus on returns, not focus on shareholders? How do you get the organization to focus on patient care?
This is the hard, because now we're going down to the tactical level. Before I was talking at the higher abstracted level, which I do think is feasible and possible. But how do you focus on patient care? Well, the first thing I think that's required is you have to solve how do you pay for that patient care. Because if you don't solve how you pay for the patient care, you can never actually get to focusing on the patient care. And this is one way I think it could work. We talked about this last night. In my opinion, I believe that cities and counties should take over our healthcare. Just like they manage our roads, our schools, our sewers. Like, we let them do all that other stuff. We let them raise our property tax every year, the rates, but somehow lower the property value. Like, we let them do all that stuff, right? So we should let them take control over the cost of our healthcare. And what that will do is it will create a competitive environment between counties and cities. Because as we heard already, and I fully agree with this, healthcare is measured in decades. Well, most people don't move that much. Like, there's some people that move a lot, but most people stay in the same place for 10, 20 years. So that should be the epicenter of healthcare and the economy of healthcare. So if we tax you through your property tax, now we're all in it together to become healthier, and we're generally all staying in the same place besides a few people that move around. And once you do that, once you've elongated the timelines, and once you've taken a payer of healthcare that literally has an incentive to keep you there. Can you imagine if the city of Minneapolis had better healthcare than the city of St. Paul? I mean, Minneapolis is, well, okay, I won't say that, but you can imagine the competition that would start to happen between the two cities. Now Duluth gets in the game. Oh, come to Duluth. Like, your healthcare is covered, and we'll do this and this for you, that and that. Then businesses are gonna be, oh, well, I got to put my business in that city because they cover the healthcare, and the people are healthier, and they stay there longer, and they're happier, and all this kind of stuff. And now you're measuring things on 10, 20, 30-year timelines. Now, once you have that in place, now the providers at the tactical level can really focus on patient care. But absent all of that, the provider will always end up being beholden to some shareholder somewhere in the ecosystem.
Yeah, I think Press Ganey had an interesting chart, and it played into a comment that I think Paul was making on an earlier panel about there's a one-to-one correlation between healthcare patient satisfaction and the healthcare organizations that are in the top quartile for employee satisfaction. And so I think that concept of I only have 15 minutes to see a patient, that I'm not really talking to you as an individual, and that I can't actually tell you what you should do because you're going to be mad at me or you're going to want that MRI contributes to it, in addition to what Thompson said. I mean, the structural stuff. But I'm saying, like, tactically today, it's trying to give your clinicians more time to spend with that patient, and the security, the reinforcement to tell them what they should do when it's the right clinical decision and direction that they came to you for in the first place. And I think if you don't do that, and there is this kind of dichotomy between the clinician having to do what they think they should do rather than what they should, that's going to ultimately impact that patient satisfaction on a long enough timeline, even if that initial visit gives you a 0 on your net patient score. So I think the clinicians need to lead. Additionally, that if you're looking at technology to help reduce that burden, for some reason over the last 10 to 15 years, we forgot that operations and clinicians need to lead that engagement. that applying that technology with just your IT team saying, yeah, you should go do this, or somebody who doesn't actually understand the specific use case and the specific needs, that's not going to be a winning strategy either.
I agree with both these gentlemen. I will add on to that the educational component of this, as a keynote speaker touched on, the consumer has more information at their fingertips out there right now than any other time in human history. Whether it's correct information or not, that's debatable at times, but they are going to start driving that bus forward and trying to make decisions for themselves. You know, we've all had loved ones that have had serious illnesses, and at times us as caregivers or the patient themselves have to drive that bus harder because there is a volume issue right now. As former CEO of a care delivery company, it is that every 15 minutes, every 10 minutes. In the orthopedic space, it's 8 to 10 minutes and you're out the door. So as a patient, they're going to start demanding more as they educate themselves even bigger.
I mean, these are, I almost wish the panel was over. These are very difficult questions.
So we can move on to some other questions.
Yeah.
I'm not sure how to take the applause.
Yeah, I mean, 10% of the patients spend 50% of the money. I mean, so, you know, I mean, I think we have to really change, we have to focus on those 10% and try to help them in ways that help us by the fact that they get healthier and they spend less money. I mean, I'm kind of intrigued by Thompson. Again, it gives me a break from my Trump-dominated news feed. But I'm kind of intrigued by the idea that we would be rewarding ourselves for staying healthy. I'm a really big fan of health span and not lifespan. And, you know, a lot of us work hard to stay healthy. We don't spend very much money on our health care. And I think that we should be rewarded for that, not just obligated to pay for everybody else. And so I don't know exactly what that looks like. If you get some kind of a healthcare spending account that counts, you know, that if you don't spend it, you get to keep the cash, something like that, you know, that would allow you to be rewarded for being healthy. But I think we really have to focus on our sickest people first and foremost. We've all taken care of that, you know, 2 packs a day smoker, you know, with lung cancer. That, you know, the classic story that they can't stop smoking. And I'm not saying that they're responsible exclusively for their disease or that others who are obese are responsible for their diseases, but they need help, and they're costing us as a society a lot of money, and we need to try to help them. And I don't know that, you know, most of the time these care management algorithms, you know, if somebody says no, they say no, they have the right to say no. And I'm not sure if they should be able to do that. I think that they need to participate on some level if they're identified. But the big question is we do need to spend less and we need to deliver better care. The trust in our healthcare system is eroding rapidly. The whole terrible, disgusting response to the shooting and how Luigi was made into a hero is it just if that's not a wake-up call for all of us, because it's not just the payers that are held in that regard. They notably are for some of their denial policies, which are real and disgusting. But we're not far behind the rest of us. And, you know, I think that we do need to do better. And so I'm glad that we're having these conversations, because I do think we need to continue as difficult as they are and as hard as they are to contemplate and to see victory. We need to continue to do this. And I think that, you know, here in Minnesota, we have one of the best healthcare environments in the entire country. As bad as things are here, I mean, I love to visit Florida, but I've told my family, if I ever get sick in Florida, put me on a plane. I don't care how sick I am, and get me back here. You know, so it's not, we can be proud of the fact that we have a very high quality of healthcare here in the state of Minnesota, but it can be better. And I applaud our willingness to contemplate the difficult conversations that are required to make it so.
All right. So last question, Michael. And this one, we're going to start with you. And I'm going to combine two questions. What's one emerging trend in healthcare innovation that excites you most? And how do you think recent political changes will impact innovation in healthcare? Sorry to bring you back to your news feed, Michael, but if we can start with you.
Yeah, I think that AI's, I don't know, kind of scares the hell out of me in all honesty. But I think we're going down the path. So we're going to find out one way or the other what it does and doesn't do. Hopefully it doesn't decide we aren't necessary any longer. But I do think AI has the opportunity to point out areas of opportunity for us, in the healthcare delivery space. So I think that clearly that probably would be a potential point of optimism. I think that with regard to the political environment, again, it's hard to draw the conclusion that we don't spend too much money on healthcare. It is. If you're spending twice as much as everybody else, and the car you're driving around isn't any nicer, then you could ask your question, why am I spending so much money for that car? So I think that what's going to happen, I don't know, I pay attention to the news like everybody else. It seems like there's going to be more and more disruption. The downward pressure on healthcare reimbursements that have come forth from the federal government over the last 10 years, I would say in the near term, I would forecast they're going to only increase somewhat. Again, the president promised not to touch Medicare, but I don't trust politicians. On the right or the left, so, who knows? I do think they're highly motivated to make more cuts. That's what I would predict.
Great, thanks. We have about 2 minutes before it's our time for a bio break. Just kind of go quickly through the panel. Kyle?
Real quick, I'm an internal optimist. I just got back from Europe a couple of weeks ago, where I spent 2 weeks there on a sales mission. And everyone asked Trump, 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 Trump. And my response at the end of the day kept being, I hope he's 51% correct, and I hope he means well, because that's a majority, and I'll take it. I think politicians, to your point, it's weird. And I try to avoid it at all costs. So I'll hand it off to you guys.
Yeah, I think I've given my perspective. I think we have to kind of focus on the brass tacks and stuff in front of us rather than chase shiny objects around innovation. That actually allows us to pursue innovation from a stronger point than we are today. And I think I'm an optimist too. I think somebody put it earlier, there are at least conversations starting now. The starting point may differ for all of us, but they're on the table. So let's lean into those and have that discussion around some of the challenges that we've had. I think if we do that, we'll end up in a good spot.
And Thompson?
I'm an optimist about everything except for healthcare. So it's not going to be pretty, my friends. It's not going to be glorious. It's going to get worse. And if human history is anything to be trusted, usually there's catastrophe, violence, chaos, destruction before something beautiful comes out of it. And so I do believe in that. I do believe that out of something much worse than even what we're talking about today, that something beautiful and productive and healthy with lower prices will blossom from that thing. But we still have a long ways to go through the valley of the shadow of death before we get through to the other side, in my opinion.
So, on that super optimistic note, let's have a big round of applause for our panelists.
So our next session, we've already kind of touched on this throughout some of the other talks that we've had. So really, we're going to take a deeper dive into AI. Our next panel about AI will be moderated by Kirk Ryerson. Kirk began his healthcare technology journey at Health East and Hennepin Healthcare prior to joining United Health Group and Consulting. Kirk is also a managing consultant for Tegria Services Group, where he leads digital healthcare strategy and planning. As a St. Thomas Executive MBA alumni, he is grateful to continue his support of St. Thomas through his ongoing instruction, where he teaches healthcare innovation and project management. To complement his technical certifications, Kirk is also finishing his PhD in business and technology. Please join me in welcoming Kirk Ryerson.
Hey, everybody. Great to be here. I love this conference. I think I say that all the time. The time's going to go fast, and I've been warned because I have a tendency to go overtime that I can't go overtime. So we've got Andy starting right at 3 o'clock, closing out the conference. I have some wonderful guests here. Thank you for being here, by the way. Justin and I were like, I don't know if they're here. You guys are all over onto the side. So we have perspectives on AI from Mayo, from Fairview, and then faculty perspectives from the Morrison School of Business and the School of Engineering, which I'm super excited about because it's about, healthcare, MBA, but we have Morrison Engineering Schools represented as well. So the way we've mapped this out is basically four buckets of questions. We're going to start with the process of AI evaluation, like in a healthcare context. Then we're going to move into what are we seeing for value? Like what are we seeing for outcomes? Opening it more general to like interest. Where's the interest coming from? Are you seeing it in the classroom? Are you seeing it out in the community? Other things we'd love to do, but we can't do because the tech's not there, or it's too costly. And then an educator perspective on education and training and materials. The one thing that I get asked all the time, my day job at Tegria, I do digital strategy, like we said. We went live with a conversational AI solution in Milwaukee, Freighter Healthcare System in May. That took almost 2 years to get it off the ground, not because the tech wasn't there, it's the change management, it's the culture, is that what does it mean for our organization? It's a scary thing, but it's even more, and I think someone else said this too, scary to test and balance innovation when there's so much risk or so much at stake, right? So I teach a class called Innovation and Entrepreneurship with a healthcare and business twist, and I'm in the healthcare part right now. My students, thank you for tolerating me. I'm very disorganized, but I love what I do. And part of the thing that we do in this class is get people to be creative and be inspired. And so I'm an optimist. We do this thing in the classroom and we do animal personalities. I'm an otter, and otters are very optimistic. If you're an otter, if you know what that means, thank you, I'm an otter. The optimism comes in when we think about innovation. Now, I've been on the applied innovation side. I've been in the provider and payer side. So it's practical innovation that actually is getting something done that isn't wasting our time and money. So I worked at Hennepin. I worked at Health East Fairview. If you know, and if you're in this space or you're thinking about joining healthcare as a career opportunity, highly recommend it because we absolutely need you to think about healthcare, not just as a casual opportunity, but as a pursuit. It's mission driven for sure, but there's so much opportunity in healthcare today. So if you're thinking about it, you want to know more about it, obviously reach out. But so why are we here? Why are we talking about AI? Everyone's talking about AI. We started this conversation 2 years ago at the University of St. Thomas. I think we hosted several discussions. You'll hear from Justin and others about all the work that they're doing to advocate and promote this topic. But I'm the realist. I grew up in South Dakota, grew up in a rural community. Anyone from South Dakota? Anyone? I hear who? Yes. All right. Watertown, South Dakota, right here. I mentioned that because everything was about value. It was about output. It was about the reality of money and time are commodities that are in short supply. AI started. We were at a couple of conferences. I think Thompson mentioned his feeling on conferences, which is totally cool. A lot of hype. So we're here to talk about the reality of it all. And if you're in a healthcare system today and you want to know what's really going on in Mayo or Fairview or in the faculty practices from clinical perspectives or engineering, you have the opportunity to do that. So I'm probably talking way too fast. I've had a couple of, good, okay. Part of why we're here too is so you can get engaged. So if you're in one of my classes, engagement's pretty important. This fills my cup because I learn. Every time I go to a conference, I learn so much from all of you, from the stories, from these inspirational messages, from the authentic rawness of where we're at. It's kind of a difficult spot if you really think about it, right? I've heard this version of they call it the silver tsunami. Have you heard that? That aging demographic resource thing. And I'm an optimist. So I believe technology has a role to play, but it's not the only role and it's not the only tool. We've got culture, people, process, all that stuff. We're going to hear about that. So I'm going to take a breath. I'm going to open it up all the way to my left. We're going to do some introductions. Where you're from, what do you do, and maybe something fun about yourself. So,
all right.
Yeah.
Hello, everyone. I am Brenna Lofek, and I am the Director of AI at Mayo Clinic with a focus in regulatory and quality. My job is to help innovators take their ideas from ideation through translation to implementation into clinical practice. I am curious, are there any fellow endurance athletes out there? Runners, bikers? Great. I love to run, and when I was younger, I really struggled with asthma. My treatment was not well controlled, and so come race day, I was pretty anxious that I would maybe have an asthma attack. At Mayo Clinic, I've been partnering with innovators that are looking to solve problems, to advance disease diagnosis or treatment. And in fact, I've been working with a really incredible innovator named Dr. June, who's building a remote patient monitoring program for pediatric patients with a diagnosis of asthma. They're building an AI-enabled algorithm to run in the electronic health record and identify patients that are going to be at risk for future asthma attacks. It's really cool to see a problem that I had when I was a kid that I now get to work on. So just going a little bit back to kind of my background, I started in industry. I worked at Medtronic for many years in their cardiac rhythm and heart failure division. So I have a med tech background where I helped bring products from research to commercialization. My primary forms of interaction were with the FDA to bring those implantable devices to the market. But I really wanted to be closer to the patients, which is why I eventually transitioned to working at Mayo Clinic, where I get to do this really incredible job. I get to see incredibly diverse products, all while uniting my passion also for research. So I'm also a part-time doctoral student studying patient safety issues related to AI-enabled clinical decision support software. So let me see. I said who I am, what I like to do, jog, and do nerdy things like work at Mayo Clinic. And I actually grew up in this neighborhood. So I'm 55105, grew up in St. Paul. Thank you.
Good afternoon. My name is Dr. Leila Warsame. I am honored to be here today. I am a board certified physician and clinical informaticist. I trained in Pennsylvania at Geisinger Health System, so have worked in a system that integrates health plans as also a provider for healthcare for the patient. Currently at M Health Fairview, I'm a hospitalist that works at St. John's, but I'm also an associate CMIO for advanced clinical decision support and digital. I also primarily help with AI governance in our institution. So I help set up the governance structure and also do the evaluation of the tools that are coming in within our ecosystem, and also help as a subject matter expert when we are monitoring and looking at the performance of these tools when they're on a clinical side. What else do I have to say? Something fun about me. I think I've lived in probably 20 some cities in North America. So I'm a Somali by background, and we're nomads in culturally. So I think I brought my nomad blood with me when I moved to America, and I just tend to move around a lot.
Love it. Thank you.
Hello, good afternoon, everybody. I'm delighted to be here. My name is Dr. Laura Beasley, and I work in the School of Nursing just across the street. I am still in uniform because I had to teach lab this morning, so excited I could make it to be with you all. So that's what I do. I'm a professor here at the university, and a little bit of I'm from South Dakota as well. I did not know that about you. Yeah, so we'll have to talk later. A little bit, I mean, that's kind of my background. It's not, I feel like I'm the least interesting person up here, but I'm excited to talk about AI because basically every day I'm trying to teach our nursing students how to use AI appropriately. And that has been an uphill battle that I do not have all the answers to yet, but I know I have a very big task to prepare them for what they are heading into in the future. And so I look forward to learning more today and making some more connections on how to bridge academia and healthcare, because we're kind of on two separate islands right now. And so I'm always actively trying to figure out how to help our students. A little bit of fun about me. I'm having a hard time with this microphone because I like karaoke. That's fine. Yeah, I'm like,
Sing. Feel free to sing.
if there's any music, we could probably, just kidding.
can do
All right.
that.
Thank you.
Yeah, thank you.
All right.
Love it.
Awesome. Well, yeah, so hi, everyone. I'm Justin Grammons. I am a lifelong learner and a very curious person. I have my feet in kind of three different categories. One is I'm an entrepreneur. I have a business that I run called Lab 651. We do custom software development, but we also help companies implement AI, everything through strategic thinking and trying to figure out how in their business they can use AI to become more, kind of build operational efficiencies within their business. The other thing is I started a nonprofit in 2019 called Applied AI. If you're not familiar with it, we run conferences, meetups, workshops. I have a podcast. We do YouTube channel, all that type of stuff. And the whole point of this is to build AI leaders here in the great state of Minnesota. And so I encourage you to check out appliedai.mn. We are across all various industries, which is one thing that I like to see. I like to see technology applied in a lot of different areas, right? AI touches so many different facets of what we're going to do. And what we're going to talk about today is healthcare. But one of the things I believe is you can learn from other industries very similar techniques that you can bring into healthcare, right, to hopefully speed it up. So AI is a tool, right? It's not the answer, but it's a tool that I think we can use. And so very passionate about building communities. That's one of the things that I'm going to touch on today. I also teach here at the University of St. Thomas. I'm an adjunct professor. I've been here since 2015, teaching students around machine learning, right? That terminology has been around for a long time. Now people are calling it AI. But been teaching students around machine learning, artificial intelligence, and Internet of Things, which is sensors, devices, very much what Brenna was sort of talking about. Teaching engineering students on how to build this technology, right? So we can start getting data. And once we have data, we can start making better decisions. And then over the past couple of years, I've really started diving into healthcare, specifically around home care and hospice. And I see a huge opportunity there, specifically around a lot of these associations that are going on around the entire United States. I'm speaking at a conference in Chicago in a couple of weeks, because a lot of them are underfunded. They're nonprofits. They have very little money at their disposal, and they're trying to solve a lot of hard, challenging problems. And the question they're coming to me is how can we use technology to help us be more efficient, right? So that's the perspective I'm going to have here today. I guess I am a graduate from St. Thomas. Go Tommies. Somebody was saying 2029 or 2020 whatever, or 2019. I'm 2006, so I might be one of the old people in here, I guess, with regards to graduates. But yeah, I'm very, very proud to be here today, and thank you so much.
Awesome. Thank you for all of the intros, the backgrounds. Obviously, I have a lot of fun. One of the cool things I get to do in meeting and working with students is also connecting with some of these amazing thought leaders. So if you Google Justin and see his podcasts, his organizations, his companies, these leaders in this space advocating, promoting this, a big part of what we bring back into the University of St. Thomas too is the educational component, the realities of what's happening in the business. So now we already have questions, by the way, okay? So we're going to add some questions into our existing questions. All right, so we're going to throw this question to Brenna. Are you okay with the first one? The AI selection process at Mayo, and what was the biggest roadblock to AI adoption in that use case or prioritization model? So question one, how do you prioritize? And what's the biggest roadblock slowing down that prioritization selection process today?
I'm going to be honest with you. We don't have a great prioritization framework at Mayo Clinic today. Healthcare institutions can be highly decentralized, and that makes sense when you have different departments or divisions that are delivering really distinct types of care, right? But when it comes to developing AI, trying to educate an organization about best practices, regulations, standards, you then come to this pretty big roadblock of trying to do organizational cultural change. So I will confess that I think that decentralized nature really has led to a challenge with prioritization. Right now at Mayo Clinic, we have around 400 digital health technologies that are being developed by staff at Mayo Clinic. That's just the ones that Mayo staff are developing, not even the ones that we're bringing into clinical practice. And about 80% of those have some type of AI-enabled capability. Right now, we tend to prioritize the lower risk products. The reason for that is because higher risk products have additional regulatory hurdles that they need to go through. Healthcare institutions are not set up to bring medical devices to market. FDA has reviewed around 1,000 AI-enabled tools that span many different therapeutic areas, mostly radiology and cardiology, but it's really diverse. Only one healthcare institution has ever commercialized an AI-enabled technology as that healthcare institution being the legal manufacturer. So we prioritize by looking at risk of tools. We really address the administrative support ones because we can get those through pretty easily. We don't have to face regulatory bodies. We also prioritize clinical decision support software, especially ones that help us with triage, that different kind of resource decision making. And then for the medical devices, we prioritize that under research. And then when we want to consider commercializing them, we have to look for other avenues like licensing those tools or forming a spin-off company. So I would say that one of the biggest challenges that we see in healthcare organizations is that they have incredible talent, but they don't have staff that are experts in how you would take a model, productize it, and integrate it into the clinical workflow. So healthcare institutions have to think about how will they retrain existing staff, or how can they accommodate in their budgets to bring on additional experts, likely from industry, from medtech organizations, in order to help with that translational activity. It's far less costly to have your own staff doing these activities than trying to hire an external consulting firm in order to provide ad hoc advice.
Wow. Thank you for that. I mean, so a lot of things you said, I just want to, of course, add to this. This is a conversation. So who would like to pick up on that? Would anyone like to continue that? So prioritization and then roadblocks.
Yeah.
Yeah.
I'll pick it up.
Okay.
So at Fairview, we have a comprehensive AI program. I like to think about it as a layered cake. We have a tops down, bottoms up approach. At the top, we have our AI strategy, which kind of nests and settles in between our Fairview strategy and our digital strategy. And on the bottom, we're looking into building our capabilities for artificial intelligence plus digital capabilities. That includes machine learning pipelines. We're looking at data governance. We're looking at AI literacy in the system and building that workforce and in terms of engaging them. And in the middle of that is initiatives that we want to focus on, mostly clinical. And there are some business cases that we follow, but mostly clinical. Just because our central role, our central mission is our patient. So that's what we are more focused on. AI governance, we have a structure that sits on top of two subcommittees. One that basically does intake and evaluation of all AI tools coming into the system. We have developed an internal risk categorization tool where we are leveraging the knowledge of compliance, legal, we're looking at regulatory, we're looking at data scientists within our midst that are informing us of those decisions, looking at the performance of the model, looking at how it performs within our patient population, the bias, the equity of that model. Is it fair? Do we need to have a different workflow when it's not performing well in certain subpopulations? We also go through a monitoring subcommittee. The subcommittee that we have for monitoring looks at the AI tool from implementation all through the life cycle. So we have, if it's a vendor product, we are asking vendors, can you give us performance and validation of your tools, whether quarterly, businessly, or annually? And if it is something that we can integrate in our system where we can monitor it and be able to validate it with our data scientists, then we use that. It is definitely resource intensive. So you're talking about roadblocks. It's the resources. We don't have the resources. The other roadblock, cost. It costs a lot of money to have these AI models because you have to build the infrastructure for it. You have to have the proper people to be monitoring it. So we don't have a lot of data scientists working in the healthcare industry in an organization. We might have 2 or 3, but we don't have a capability of monitoring an entire slew of AI models and making sure that they are safe for our patients. Cost, we have to be very, very deliberate in what we are picking to try out, because those costs are based off usage currently. So the more times they're being used, the higher the cost it is for us. And therefore, we have to figure out where is that money coming from and how do we then put it into the system in a way that we are also getting some financial incentive from it. So if it's something that we can co-develop with somebody, we ask, can we do IP with them? If it's not, then we are looking for ways that we can use this to be able to increase revenue.
I can jump in a little bit with regards to barriers. I mean, just having been in this business for, building technology for 25 years, I think the biggest challenge that I see is just you got to show your return on investment, right? And a lot of companies, and myself in particular, right? I'm a technologist. I see something cool. I'm like, let's go build this, right? And I think companies far too often don't actually take a baseline and say, okay, what does this cost to do us today? And now, what's it going to cost for us to build a new solution, AI enabled, for example, right? We're going to build all this technology. And how much is that differential going to be? And how long is it going to be until we actually get a return on investment? And so, I've worked with R&D groups at 3M, at Cargill, at Honeywell. All these groups, we're throwing a lot of stuff at the wall, which I think in some ways can be okay, but to actually move it up the chain, to actually have somebody sign off on we're going to go in this direction, I've realized that you need to show the business use case for it. And far often teams just jump into working on an implementation before they've actually solved that problem, which is the money problem. I think the other problem is actually just good storytelling. There's this idea around why are we doing this, right? And everyone on the team needs to understand why, and you need to get buy-off, and you need to understand the more or less the intrinsic value of the product that you're developing, and be able to tell a good story, right? Be able to understand how this product is actually going to get into the market. And for me, I kind of bring it back to the applications, like you were talking about, Kirk, was basically, the classes that I teach, the students always have to build something. There's always a capstone project at the end of the day, right? You need to build something that is useful in the world, and it doesn't need to be useful to anybody beyond you. That's fine. But let's build something, and we actually use the technology, and at the end of the course, they actually get up and they present for 15 minutes and show the new thing that they built, right? And put a bit of a business use case around it, which is the final thing I think I'll say is far too often, we are in 2 different camps, right? Laura and I were talking last night, right? So School of Nursing, we got an MBA program here. We've got the engineering departments, right? We're actually spread across Minneapolis and St. Paul. But I think one of the things we're trying to do here, and I think every university needs to do better at, is just that cross-discipline approach, right? And so more people you can bring into the room together, no matter what you're building, I think will help with your understanding and help overcome a lot of those barriers.
Fantastic. Moving on to the next, okay. This one could be for a group. This is this combining 3 questions from our audience. I think this is great. We were actually talking about this in terms of the use cases. So at the recent conference, a lot of things about AI scribes were coming up. So this is the question. Utilizing AI in a mental health space, specifically ambient listening to help with documentation, comes with challenges of patient buy-in and discomfort. How do you suggest we help with this? And then I'm going to add to this because they're similar. Is this an ethical dilemma that needs to be addressed? Like the idea of consent and privacy, what you're comfortable with. And should patients have the option to opt out? And so I don't know about you, but I was recently, I think it was a dental appointment. And sure enough, they're like, hey, can I get your verbal consent? And I'm like, I'm really bad. I shouldn't say this out loud, but I usually just like, yeah, sure. Yeah. And they're going with the procedure, but instead of, that we had this conversation at the table, the backs to the patient, it's not very personal. It's kind of like awkward a little bit. It was all being grabbed on their system, ported into their record keeping. But the question about whether it's mental health, whether you should be able to opt out, are there ethical implications? I'd be curious, anyone from the group or maybe multiple points of view, how do we disclose? How do we share that information? Is it going to be, and I think I've heard this everywhere, like we were just talking about this, the microphone is on and recording. Now there's nothing anymore as private. How are we addressing opting out, privacy, and then even the specific use case of mental health? Anyone on the panel want to take a first swing at, or parts of it?
To answer your questions, I personally feel yes and yes. So is it an ethical concern that we have to address? Yes. Are there issues related to privacy? Should we allow patients to opt out? Yes. We give patients the option to opt out of any sort of other procedure, right? So if this is integrated into the clinical workflow, we should sufficiently notify patient that these things are happening when feasible and give them the option to opt out. FDA released a guidance document on the AI lifecycle for submitting medical devices to them for commercialization. And they had a long section in this guidance document about the importance of publicly available summaries for AI tools that are used in clinical practice. And there was a really interesting line in this guidance document about how disclosure of these tools builds public trust. And really, public health can only advance if we have the trust of our patients in that relationship with a healthcare professional. So I say a resounding yes, with an asterisk that I understand that in some scenarios, it is hard or impossible to get a patient's consent for a novel tool that they're not used to being integrated as part of standard of care practice. But when feasible, yes. And I think we can look to practices that we're very good at under research. So when we're doing things involving human subjects research, we know how to consent patients. We know how to use plain language to articulate to them what is happening and whether they're okay with it going forward. And I think especially because in the example that was provided with a mental health scenario, there is some added sensitivity around the use of that tool, as well as the content that would be generated for it. So I'm a yes and a yes.
Love it.
Go ahead.
No, feel free.
All right. As a clinician and one who has tried the ambient documentation tool, I will tell you that it was one of the things that I struggled with at the beginning. So we currently tell our providers that they should ask their patients for permission before they use it. I had gone to an orthopedic visit, and my orthopedic was using a scribe that was not the run-of-the-mill scribe. I think it was just a regular scribe that you find on the internet. And it made me very uncomfortable because he didn't even tell me that he was using it. I just noticed his phone on there, and I just noticed the timer on it. And I was like, are you using a scribe tool? And he goes like, yeah, it makes my life easier. And I was just like, you don't ask if you should use it? And he was like, oh, but it just makes my life easier. And I'm like, yeah, I understand. But you should tell people you're using it. But so we usually tell the patients, hey, I'm going to use something that's going to listen. It's going to record the information. The information is not going to go anywhere but your medical record. And this is one of the things that we do as the AI governance. We look at where that information is going. So our privacy people look at what Nabla or Abridge or Ambience is doing with that information and that audio documentation. Where is it going? Is it being encrypted going out, coming in? How is it getting integrated into the EMR? How long is it staying? Because there's also a medical legal standpoint for providers. How long is the audio going to be there for? What if it did not transcribe the right thing and I just put it in? And we also tell our providers, not only consent the patient, but actually read the transcription, understand what is being said and edit it to be what you will stand behind legally. So I think ethically we should tell patients that we are using these tools. I also think that federally, we are not seeing any laws, but I believe California just passed a law that says that we should tell our patients and disclose when we're using AI tools for their care. So federal laws might not be there right now, but I believe they'll get there eventually. So we should start practicing that right now.
I was just going to say, I 100% agree. If someone consents to it, they should be able to opt out. What I've seen in the industry just across the board is what I would call data exhaust, which is basically other things it's picking up, right? So, for example, in home care, they're talking about putting cameras in people's homes, right? Or even in senior living housings, actually having a microphone on all the time. Right, and actually being able to track when the person. I mean, some of these people have dementia, so they might just leave. So there's proximity sensors, right? When are they there? Where are they not? The challenge with that is what if their caregiver comes, right, or their daughter or whoever it is. Now they're getting picked up, right? And did they provide consent? Right, and I think that's where the challenge can come in. Is you can get consent from the patient, but is there other data that's being picked up? And a lot of these companies that these are startups, they have great ideas, all that, but there's getting a lot of pushback because it's like, what other data are you picking up along the way? And if they haven't consented, you could be basically in a world of hurt, right? So there's challenges beyond just the patient to doctor relationship that can span, especially with these ambient technologies, right? I would say if somebody has a wearable on, right, then you're just getting data from them, right? It's a much more clear cut that this is a biometric sensor that's coming off of that person. There's no chance of picking up all sorts of other video feeds or audio that maybe wasn't consented.
Are you good? I got another one for you if you don't. Yeah. Okay. How about this one? Hang on 1 second. I had it. Okay. How about this? What's one AI buzzword or phrase you wish would disappear? Is there a word or a phrase that comes up that you're just so over with? Like Ty talked about a little bit, digital front door. That was like, oh, the door. Or like, and LLM and all these different terms. You hear terms that are just kind of like, did they annoy you at all? You wish they would go away, deleted? Like the new word I heard this week was agentic. Have you guys heard agentic? Yeah, that's like the new, like people are rebranding conversational AI. Autonomous bots are now agentic
AI.
bots. Yeah, and I was talking to someone like, oh yeah, well I guess you have a bot. It's like, well, we prefer the term agentic right now. I don't know if it's taken off, but is there a term out there, or maybe for the group, that you're hearing in the class or hearing from anyone that's just like, oh, stop already? No, nothing? Okay.
I'll say artificial.
Okay.
I hate people using artificial intelligence as a catch-all.
Love it. And you hate it, why? Because it's like overgeneralized?
Yes, because when we are doing the evaluation or intake of these tools, they'll just say, oh, it has artificial intelligence. And you're like, okay, is it machine learning, natural language processing, is it vision? What are you doing, Gen AI?
Yep.
Like, and they can't tell you. Oh, we'll get back to you.
Oh, yeah.
And I'm just like, it's not a buzzword.
But it's being used like a buzzword. That's all that noise versus signal. Yeah. Mm-hmm.
Yeah, for me, it's everything is Chat GPT.
Right.
Like
that's
everything.
That's another one.
And it's like, I think there's more than that out there, but that's just something that I've
Right?
heard a lot.
Speaking of which, terminology, there was a case. Okay, let's get on the Chat GPT. What role does generative AI have compared to traditional AI models like machine learning in improving healthcare and healthcare, I think it's financing maybe, or framing? But there's another add-on to this too, is large language models combined with blank in a Chat GPT. So different models stacking on different things. You got the agentic, autonomous bots. Like, maybe just break it down. What role does generative AI have compared to other models? Or in healthcare, in the business, what models are you seeing that have the most potential, most value, given what you're trying to do with them? Maybe we could talk about the models that you're going after and why.
Yeah, I can share what I'm seeing at Mayo Clinic. So in the generative AI space, we see kind of two broad categories of application today. We have generative AI being used for data extraction. So taking data in one location and putting it into another location. And that often is combined with summarization capabilities. And then you can add on to that too, the chat functionality. So we have everything from a really cool tool called Record Time. So if you're a patient, you're coming in, you've been seen at, 3 other healthcare institutions, you have these outside records. Your healthcare professional is now new to this information, and they want to quickly look and find, maybe some lab results or some diagnoses. They can use Record Time, which has generative AI enabled capabilities to do that data extraction, and then it does some light touch summarization. Epic itself actually has a ton of features in it today that do summarization with very simple prompts, but you get more complex when you can actually not only ask one prompt, such as give me a summary of this patient's history, but it gives you that summary and then you ask further questions about it. Then we're getting into really complicated generative AI technology that is actually ripe for error, but is really exciting. So I think we see healthcare professionals looking forward to applying generative AI in their practice for the purpose of reducing administrative burden so that they can focus more time with their patients. But we also have healthcare professionals that are suspicious of this technology as well, because they've seen firsthand when they play with ChatGPT or they put something into Google Now, how erroneous it can be. And so maybe I'm getting a little too far away from the question here, but just as you all are advocating or thinking about high quality healthcare that uses AI or generative AI enabled tools, I like to talk to innovators about 3 things being true if we're using generative AI in clinical decision making. I want the output to be explainable, transparent, and traceable, so that the healthcare professional can think independently about the output of the summarization tool and whether or not they think that that's correct given the context for their patient. And one thing that we really encourage innovators to do is at the end of a summarization sentence, have a hyperlink to the documents from which the large language model is pulling content. And you can do a lot of really interesting design things actually by making it easier for the healthcare professional to do that sort of checking, so that if you click on the link, you don't then have to go to another system and log in, because then they're probably not going to as readily look at those documents. Maybe you have a panel on the side of your website that you click on the link and it just pops up right there. And that's just a lot easier to use, and it's more likely that people are going to check those sources and confirm that the summarization makes sense for their patients.
Anyone else or good?
I think she hit most of most of what we think about in clinical space, which is we want it to be explainable. We want the provider to be able to trust what the output is. And so Epic has gotten better at that. Initially, their Gen AI tools never gave you where the sources came from, but they've gotten better and technology will get better. So I am fairly optimistic about that. I think with Gen AI tools, what I consider important is to have a human in the loop initially. I feel like this will reduce the bias that we have in terms of we always think that it's saying the right thing. And so we want to make sure that we are having a human review that information and just say, okay, this is correct, this is not. And we are seeing Gen AI being absolutely useful in administrative tasks, not only for the clinicians, but for the coders, for the people in the back office. So it's absolutely great to summarize your email, summarize a thread of emails. We get a lot of those, and it's like, oh my God, I don't want to read the first email to figure out what the last one meant. But it's great for that. But in terms of clinical records, we have a lot of data that's inside the patient record that we cannot access unless we read every little progress note to figure out what was said. So this will definitely save physicians and clinicians time and also will reduce cognitive burden. And that's one of the good things that we've seen with a lot of this Gen AI tool is the decrease in cognitive burden for the physicians.
Yeah, one thing I was going to kind of maybe clarify is, so people like the world changed in November of 2022, right? We all had this thing called ChatGPT, right? And all of a sudden we could open up a little text box and start talking to it. I mean, who had the aha moment? It's like, oh my gosh, this thing is actually responding back to me, right? But the thing is it took us decades to get to that point. People were playing around with language models and trying to build them up more and more. In fact, that was GPT-3, and then we moved on to 3.5, right? But there was a GPT-1 and a GPT-2. People just didn't really know about it. And I was playing around with GPT-2, and it was terrible, right? The challenge was we didn't have enough data, right? OpenAI had not crawled enough stuff, right? But they just kept plugging away at it. And they kept using this concept called deep learning for us to build these neural networks for the system to get better and better at predicting the next word. At the end of the day, that's what it's doing. It's taking this body of knowledge and saying, based on everything that I know, I'm going to run this through my neural network, which we think is similar to how our brains work, right? Run through the neural network, and I think the response should be this. And so it wasn't until GPT-3 and 3.5 is when they were actually able to really build something that felt human in a lot of ways, right? And it's just gotten better, right? It's just getting better and better. And what's happening now is we're building even larger large language models. That's what's powering all of this. There's a thing called a large language model underneath the covers. But it turns out, I feel like in the industry, we're moving towards small language models. And you might hear this term. We're starting to build language models that don't actually try to capture the entire internet. They might just actually capture a patient's EMR, right? Just that information. And those language models can be very, very small, and they can be very, very powerful. And they don't require as much compute to even build. And in fact, they could even run on your phone, right? So we don't need these huge data centers to build these things. And so what's interesting to me is I think we're going to start seeing, and they're less complex, way more explainable, right? We don't have all of this other stuff in there, right? So I feel like what we already are seeing in the industry, I'm going to see more and more, is language models that are smaller and smaller, that are tuned very specifically on things that we know, we can explain, and we're going to have a lot less hallucinations. That's the other word that I hear a lot around, right? And that's when the large language models make stuff up, right? Just hallucinate. So we're going to have a lot less of those. And once we start reaching more and more confidence in these language models, then I think we can have more and more trust in them making the right decisions. But per your point, a lot of the current technology is hallucinating. It's making things up. It's pulling in a lot of other data from other disparate sources, and so we always need to have the human in the loop. And number one, I mean, I think we will need to have the human in the loop in a lot of different ways. Number one is fact checking, but let's say fact checking aside, somebody needs to take this data and then actually personalize it to another human. And that will probably lead into some of our other questions, right? Are humans going to be replaced or by this technology? But that's where I see a lot of these large language models going, is actually shrinking and being much more focused and actually much more effective on specific tasks.
Fun question. Would you rather have an AI boss or an AI coworker? Why or why not? I was reading this and thinking about it. I couldn't come to I don't know. What are your thoughts?
Well, it just depends on the day.
On the day, right?
I could have used an AI boss today, but I probably an assistant, I think, more so.
An assistant?
Yeah. I feel like I have that already. It's wonderful.
How about from the audience, AI boss or AI coworker? What would you prefer? Coworker? Boss. Okay.
Split.
All right, split. All right. Going into a serious topic that comes up all the time, and I'm glad this was surfaced. There's about 3 or 4 questions here that I'm going to bundle. So this could be a question on failures, and we'll get to successes before we close. On a high note, optimistic otter than me. Failures, bias, quality, and malpractice for $200. So lumping this came up a couple times. We did some contract reviews. If something goes terribly wrong, malpractice, license, who's at risk, organization, the doctor, that gets into disclosing how you're using the information. But the other thing that comes about with the data, the knowledge that Justin was talking about, small versus large, the bias that's injected into these models and having to do some cleanup. One of the comments made by Mayo, whenever they go into an organization and look at the data set that they want to leverage to analyze that data, 9 months on average to clean up the data to even make it usable. So bias, malpractice, and maybe the worst, is there a negative downside? So one of those topics, so downside, malpractice, or bias, anything that we know about those that we're actively going after to address those challenges.
Maybe I'll start with an academic lens to that. We just had this conversation today in the lab with the nursing students, and we're working on documentation. And I took the electronic health record away from them, and I am having them write out an entire head-to-toe note for their head-to-toe assessment. And I took the EHR away because I don't want them to check boxes. I actually want them to write because it stimulates critical thinking, organization of thought, adjectives used to describe things. I want them to create that themselves. And then I asked them, I'm like, okay, if you were to put this in an EHR, what you just wrote, is the quality of data good enough for if it generated out ideas for you to take care of your patient based on what you put in there? Is the data good? Is the data quality? Is it going to know what you mean? Then whatever AI may push out to you as far as ideas on how to care for that patient, are you going to be able to look at what it generated and know what it means, number one, and stand behind it to implement it? Are you going to know what it means? Are you responsible for what that puts out? And I want to say, yes, you have to be. And that's the challenge I'm having right now is a lot of our students are using AI as foundational knowledge. And that scares me to death. Because are they going to have AI when a code is occurring? I mean, you can't pull out your phone and type in, hey, what do I do during a code? Like, I don't think it's clicking for them yet. And so I'm really trying to push it very hard for them that whatever that AI puts out, you're responsible for it. And not only for it, but delivering it and in a humanized way. So that's the struggle I'm currently having and tackling each and every day.
Yep.
Yeah. I'll bring up something that recently happened. How many of you guys know what sepsis is?
Sepsis?
Okay,
Yep.
great. I don't have to explain it. So one of the EHR algorithms they have is based off predictive modeling on a sepsis. So it's able to recognize a patient when they think the patient is septic so that you can act on that earlier and be able to sort of make more better choices and hopefully save the patient. So that's just what the predictive model does. We had deployed this in LTAC facility, but it wasn't performing well. The performance was 1 in 40 patients correctly recognized. And so we, as the AI governance, went and talked to the sepsis committee, and we were like, we really think you should not use this in this particular population because it's not performing well, and we don't think it was trained on the right data. Because when you look at the data that model was trained on, it was trained on people who are inpatient. And LTAC people tend to be on vents. They tend to be sickly. They decompensate frequently and stay in the hospital for a lot, or in the LTAC for a long period of time, months on end. So, but here was the problem. They were used to it. So what are we supposed to use now to recognize the sepsis patient? So when we're talking about these tools and how we implement them, we have to recognize there's a de-skilling that might be occurring at that time. People tend to focus on what the tool has helped them do for so many years that they forget what their clinical acumen used to make them learn how to recognize the sepsis patient before all these tools became available. And currently, we're trying to work with them to see if we can try other tools for them to recognize a sepsis patient and not utilize that algorithm. But it is fairly difficult when they have that tool and they get used to it.
Or it's readily available. It's like in the pocket. Like you said, that they're using the technology. They may not even know. We've had conversations like HR, onboarding new employees, what's right, wrong uses of AI. Sometimes it's education, yeah, it's
No, and even if we educated, it still was like,
yeah. We've got a little less than 10 minutes and I have 42 questions left to go through. So I'm going to move on to a fun one, but comes up frequently. This is a big concern that we have in this space. I'll save my comments on it. I'd love to hear from the panel. What is at least one healthcare job, or broaden it out, that AI will never replace? And then can you predict which roles might be positively influenced or impacted by AI's role? So name a healthcare job or job that you think AI will never replace. That's never going anywhere. Or predict which roles might be opportunities for AI augmentation. And go for $250.
For the experts.
I'll take it.
Yeah.
Okay.
Yeah.
I need some money.
Let's
Okay.
do it. Let's do it.
I don't think it'll ever replace nurses. I don't think it'll ever be a replacement, but it will be a good assistant if used correctly. I don't think we can ever replace human touch with an AI thing. And I heard this just recently that people using AI will eventually replace people not using it. So I feel like there's always going to be a nurse at the helm in some way, shape, or form. So I don't think it'll ever take away that.
Yeah.
No.
Like it, yeah.
So I agree. And I would say that I'm not really seeing positions blanketly go away. We are seeing positions change and have individuals have to acquire different skills. But where I do see AI potentially replacing people is in specific environments. So think about environments in which maybe a certain expertise is not available in that exact moment. Think about maybe there's an emergency and you have a number of healthcare members dealing with it. It's away from a hospital and they don't have like the exact specific expertise to take care of that patient with a particular skill set. There may be AI-enabled technology that can help guide them, whereas if they had been in a hospital setting and had access to those experts or those resources, I don't think that AI would replace it. So I think we might see like a risk-based triage approach where when the absence of a human or a particular subject matter expertise is available, that AI may augment the care delivery itself, but that expertise is still necessary in certain environments where we would normally expect it.
Yeah, I agree with that. I mean, I think anything where you have the human touch, anything where there's emotions involved, right? Sympathy, empathy, those are things that I don't think are ever going to go away. I mean, we're carbon humans, right? And these other devices are silicon based, right? And so there's actually a book out by Mustafa Suleiman where he talks about it's not going to be artificial intelligence. He's going to call it alien intelligence because these things are actually going to make decisions that are different than what we normally would as humans. And there's a lot of human intuition in what we do. Yeah, my dad was a hematologist, oncologist for 45 years at Fairview, actually. And, you know, I've been talking about AI for many, many years, and he kind of comes down on that same side. But what I also think is what portion, so what it means to be a doctor is going to be different. And what it means to be a software engineer, like the people that I hire at my company, that's going to be a different. What it means to be a nurse is going to be different. Like the role jobs, like Brennan was saying, the tasks that you do during the day are going to change. Right. And so ultimately you want to end up using this tool to augment what you have. Now, obviously this large language model has got a lot of information, more information than my dad ever had, even after doing this for 45 years, right? He can't go up against this language model that has ingested way more information than he could ever do. But as humans, I feel like we can connect the dots. We can see the bigger picture and use the tool when we need the tool in our day-to-day basis, but then make these broader-based decisions, level up, right? And I think those are the types of things that I think humans will always be very, very good at because we understand the patient, the doctor-parent, patient relationship. We understand how the job works and the day-to-days of it. When this tool is just really good at answering a question based on a lot of information that it's ingested.
5 minutes left. We can each express at least one example of where you've been wowed and amazed by what AI is doing for you, or super excited about the future, about what it might be able to do for you in the future. So either something it's done that you're really excited about, or something that you're working on that you're excited about. It could be a use case, healthcare or business, but I'd love to hear from our panelists before we have to wrap up. So. Who'd like to go first? Something you're excited about or you've seen healthcare?
I can go first.
Yeah.
I'm not an MD, so I'm going to try and explain something, but I apologize in advance if I'm not getting all the facts right. So if you're a patient that is undergoing radiation oncology, you're getting radiation treatment, sometimes what has to happen is you get a variety of imaging done, and then a trained expert goes into those images and kind of carves out the areas that will receive the radiation and areas that won't, and then different dosages too, right? That work is highly manual. And as you could imagine, as you're getting treatment, as you're getting radiation over a period of weeks or months, ideally, what the target area that should be receiving dosing shrinks. And so you can imagine that on a periodic basis, you might have to have that imaging done again. Those experts have to go in and kind of carve out what those target areas are going to be for the dosing. And at large healthcare organizations like Mayo Clinic that have massive radiation oncology departments, they have staff that can do this pretty quickly. But think about those healthcare organizations or radiation oncology sites that just have a person or two who's doing this and supporting a whole community, right? And so Mayo Clinic has partnered with Google to develop this auto contouring product. So that's the process of like going through and doing that highlighting of the different body areas and identifying what those different dosages are. And this is definitely where I'm not totally sure, but what I heard is that if there's a certain delay in your radiation treatment from one session to the next because you have to have re-imaging and recontouring, you can see significant outcome changes. So I think it's lung cancer patients, if you have something like a 2-week delay because you have to have re-imaging done and you have to have that contouring done again, you can see a percentage decrease in your survival likelihood. And so that is huge if you're a patient. If you can have these auto contouring activities done and you can get in to be seen with these new images, new dosing areas, I think that it really has blown my mind because it may democratize the speed that large healthcare organizations can deliver healthcare for organizations or locations that don't have access to that sheer number of resources. So I'm really excited and passionate about that. And please, Layla, please correct me if there's anything I'm saying wrong.
I'm not going to correct you. Okay. I think the one that has been really exciting to me lately is a tool that I came across that is able to extract radiology findings from free text. And that tool to me is great because as a hospitalist, you get tons of imaging on your patient, and sometimes you're more worried about why you sent the patient to the imaging, and all the other things kind of sort of go to the wayside, and you're like, oh, follow up with your primary care. And the primary care might not notice that either. And so this particular image extraction tool is for pulmonary nodules. So if you pick up a pulmonary nodule early on, before it gets to the point where it turns to be cancerous, you would then do follow-up imagings with a cadence, like every 3 months, every 6 months, or every year. And for me, that's like potential of saving a lot of people's lives because you're going to pick up cancers way ahead of time, be able to intervene and do stage 1, stage 2 treatment before it gets to stage 4. And so that's very exciting for me. And if we can do that to all other incidental findings and have a follow-up that automatically comes up for the providers, I'm all up for it.
Love it. Got 5 minutes.
Okay,
Yeah.
I'll be fast.
Yep.
Well, I'm excited as an educator to turn my 60-hour work week into a 40-hour work week, which it should be. But it's been helpful for me as an educator to take course objectives, and when my brain is dead, putting into ChatGPT and be like, can you please help me develop some learning activities that are engaging in the classroom? And it puts it out. It used to take me hours to create a case study. Anyway, so from an educator standpoint, that's exciting. From a student standpoint, I am excited about AI in that we have students that come from all over the world, and some have problems with English. And what it used to be is students would have to sit here and read something, translate it back to French, then back to English again. And it would take them a long time to really understand a concept or how to explain something to a patient in simple terms. And now they have that ability to be like, can you please help me with this? You know, help me to explain this in terms that I can understand. It's helping with tutoring. It's helping them to develop flashcards and studying and stuff like that. So I think in the future, you know, AI might be very helpful to specialize learning to everybody's individual needs instead of throwing blanket solutions out there for different groups of people, really getting down to the individual learning needs. And I think that's exciting.
I just want to tell her that Khan Academy is actually coming up with AI.
Is it really?
course.
Is it really?
Khan Academy.
I love Khan
Language.
Academy.
And language didn't come up in today's session, but language support for AI, if you look at that, it's amazing what they're doing with real-time translation. Close this out.
Well,
what are you excited about?
so many opportunities.
seconds.
I mean, and it's really around personalization, I guess, is kind of what you were getting at. A personalized learning plan, I think, would be great. I mean, has anybody here used ChatGPT on their phone and just turned on conversation mode, right? Turn on the audio, right? I encourage you to try that, because what happens is it's a completely different interaction. You just use it to brainstorm. I mean, I'm a marathon runner, so I'm like, come up with a marathon plan for me. Okay, great. What should I do week 1? Okay, great. What food should I be eating? It just adds on to this conversation. And your voice and conversational aspect is way better than your thumbs. Believe me, way, way faster. And the whole idea around audio and being able to interface with these large language models just through voice is going to completely change. And I would guarantee that probably most of the population is not using that. But once you start using that in that type of context, kind of the world opens up, because you become even more productive. You're just telling this assistant what you want it to do. And for me, the awesome thing that I'm looking forward to one day is when I open up my inbox and my AI agent, because that's the buzzword of the year, is agentic AI. It has just handled all of my emails for me, right? And I think we're going to get there, right? Over time, it'll understand how it should respond. Or at the very least, I could say, so-and-so emailed me, just shoot him a quick reply saying, yeah, XYZ, right? And it just go ahead and do it, right? So that's the world that I'm looking forward to, is all of this communication that we've been sitting at our desk, spending an hour in the morning, replying to emails from yesterday. That's going to go away. I'm excited to have that happen someday.
Got to quote Justin on that.
All right.
So thank you so much. Awesome conversation. Thank you all for doing this. Andy's up next, and I think I'm only 4 minutes late.
Good job.
All right. Nice job, everybody. Thank you for the questions, everybody. Thank you.
All right. Thank you, everyone. We're moving right into our final session. I'm excited for this one. It's going to be on global health. Please welcome again Joe White to introduce our final presenter.
We have a great ending here today. We've to conclude the conference, right? I'm very excited about this, and I think you will be amazed about what you're going to learn. I'd love to be a futurist, and I think Andy's got a little bit of that in him. And so Andy's going to close out the conference here as our keynote, and he is the Global Health Technology Lead at Accenture. He spearheads the transformative healthcare solutions worldwide, okay? And if you don't know Accenture, take a look, $17 billion in revenue, $261 billion market cap. It's big time, so this is cool. With decades of experience in health IT, interoperability, and digital innovation, he has been instrumental in advancing technologies that enhance patient care and advanced operational efficiency. Beyond Accenture, Andy has significantly influenced healthcare data standards and policies. A board member and chair of Health Level 7 International, HL7, he contributed to the creation and adoption of standards like fast healthcare interoperability resources, revolutionizing data exchange. As a member of the U.S. federal government's Health Information Technology Advisory Committee, HITECH, he provided strategic guidance on national health IT policies and co-chaired the information blocking task force for the Department of Health and Human Services. As a delegate to the EU, he drove the standardization of healthcare data across the European Union. So he's at that level too. And he continues to serve clients globally and advises governments on enhancing healthcare delivery through technology. Okay, this is where we're going. He's going to discuss key trends poised to reshape industries, including healthcare, and the implications for all of us as patients and professionals, and his views on the opportunities ahead of us. As he delves into this transformative trends and explores the specific impact on healthcare, he will share insights on leveraging AI and digital innovation to create more efficient, accessible, and patient-centric systems and what this means for all of us. Please join me in welcoming Andy Truscott. Let's hope. Thank you. There it goes.
Good afternoon. Good afternoon. Well done. Okay. My name's Andy Truscott, as you probably just worked out. As you can tell, I'm not originally from these parts either. So if my accent gets in the way and I get a bit quick and excited, then just wave at me and slow me down a little bit. I'll try and oblige. Embracing technology is kind of something we should be talking about today. There's a lot of people been up in here. I listened to the last two panels and I'm like, how the heck am I going to go after that? So we'll see what I can do. But it's also the last session of the day. And, you know, for those of you who are paying attention to the slides, you know, I'm trying to sex it up a bit. Okay. Most of you in the room should recognize the font at this point, okay? The embracing technology, returning, because it's actually really kind of back to the future. Now, the Easter egg on this slide is, what's the Easter egg? Look at the license plate, okay? We are at a tipping point inside healthcare globally, okay? It's my great privilege and also one of my big fears that I see the same trends taking place in every single country in the world. Do we have enough healthcare professionals in this country? No, we don't. About 17% vacancy rate right now on average across the country. Was it the pandemic that made it all happen? No. We had lower levels of people entering nursing schools, medical schools over the last 25 plus years. The pandemic just caused more people to leave at a quicker rate, but we were always going to have the problem that we have right now. So are we out of time? Okay, for a responsive audience, you went very quiet all of a sudden. I hope not. And, you know, a few years ago, these incredibly smart people came up with the idea of the transformer, you know, one of the core pieces of AI, generative AI. I hope, and we're going to touch upon some more of those facets today, that actually we're not out of time. We actually have a great opportunity to bend the curve, as we like to say in the consulting world, to get things back into a place where actually everybody has better access to healthcare. There is a better experience of care delivery and better outcomes that are being generated. But there are going to be some issues as we go, but we're going to talk about Gen AI a little bit more today, I'm sorry. And we need to reinvent how we deliver care. Because how we deliver care right now actually isn't really working. It works for those who are very sick. But for the vast majority of the population who just want to be consistently well, it isn't actually working. Some people are looking at me slightly skew with, some people are nodding their heads sagely, and it doesn't. So we do kind of need to reinvent where we're coming from because we have less people. If we have 17% vacancy rates, we're missing 1 in 5 healthcare professionals. That's a problem. So we are seeing this generalization of AI infused into many, many different aspects of everyday life. I'm going to ask you guys a question. This is a little bit interactive, this conversation today. So those of you with your heads buried in your phones, you might want to pay more attention because I'll pick on you otherwise. The idea of autonomy and automating things has been around for a long time. AI is not something that suddenly appeared last year. AI has been kicking around since, well, basically when I entered technology consulting in anger, which was last century. You know, I'm really quite old. And but we have at the center this idea that computers can think. Okay. Those of us who remember, 2001: A Space Odyssey are quite scared about what happens when computers think. I'm afraid I can't do that, Dave. Okay, a couple of people remember that. Okay, there we go. And then we have this, the essence of all this is trust. And we're going to talk about trust a bit today as well. So who has used generative AI? Okay. Who's used general AI? It's kind of a trick question here. What is Gen AI? And depending on who you talk to, you have a different definition, general AI or generative AI. But what do we use generative AI for? The vast majority of the population, which means the vast majority of patients, they use it as some kind of really cool Google. Okay? Which is great because it always gives you an answer which might actually be correct. Because we do have these things called hallucinations, because at the end of the day, underneath all this, it's a really complicated bit of maths. That's what's actually going on here. And we were talking over there in the corner earlier, and if you ask a generative AI model the same question repeatedly, it gets absolutely more and more confident that it's giving you the right answer, because you're asking it more, and it's doing the maths more and more. So we do some work every year. And we think about what are the core technology trends that we see going on across all industries. And this year, recently published, and it's actually a bit of a shameless plug for my LinkedIn. If you go and look at my LinkedIn, you'll see some commentary about this. We see 4 massive trends going on right now, and they all sit around generative AI. We know that generative AI is transforming who we are as a society and a culture. And these are those 4 trends we see: the binary Big Bang, you'll face in the future, when LLMs get their bodies, and this concept of a new learning loop. So the first one, the binary Big Bang, that takes place when, quick one, trust, okay? We're going to get onto what those trends are in a second. When we go and see a healthcare professional and actually want to get better, we trust them, right? We trust that they're going to do the right thing, that they're listening to us, that they understand who I am and understand the care that I need. And they've got these eons of learning behind them, and they understand that medicine is an art and not a science. Who's a healthcare professional in the room? Okay, so when we took the Hippocratic Oath, we got that actually it's not just about a set of rules. It's not just about something that's built in silicon that can make a decision. It's actually about the empathy and the art of providing healthcare. And so we have to trust that. But with autonomy comes an expectation of trust. Otherwise, autonomy doesn't really work. And that's something we see as a key trend coming across everything we do in generative AI, is that we need to have trust. Trust as a patient and trust as a clinical professional. So if we get into them a bit more, the concept of the binary Big Bang is that every single piece of technology and information technology we trust right now is being impacted by AI usage, okay? But it means specific things when it comes into healthcare. We have this concept of the cognitive intelligence that sits in the middle, okay? And we have a shift going on. We heard it I was really happy to hear this at the end of the last panel, this concept of agentic architectures. And we're going to touch upon that a bit more detail in a minute. We also have this idea that we can provide very predictive, high resolution, high speed, high fidelity, predictions very quickly. And that we have a future of AI-enabled healthcare. AI is not going to be something which just disappears. And so the shifting to agentic architectures means that we have a good understanding of data, information. There's a wonderful piece of old prose, the rhyme of the ancient mariner, water, water everywhere and not a drop to drink. We have data everywhere and not a drop of information. And there's a delta there. And AI gives us an ability to sift through massive amounts of data very, very quickly. And as I said about a hallucination, come up with something which may or may not be accurate. because that's where the art of medicine comes in. We are able to integrate multiple agents into workflows to provide guidance and support. So all clinicians in the room, we've used clinical decision support for a number of years. It's embedded in how electronic medical record systems work. Agentics gives us the opportunity to do more with those decision support agents. And it enables us to do enhanced decision making. The real-time nature here means that we can really efficiently share data. We've been trying to share data between healthcare systems for years. Generative AI means we can actually do it really efficiently, not just using coding, but using narrative as well, and enables us to do predictive analytics, and enables us to do this concept of autonomous coordination. So we actually can allow digital agents to manage resources without humans having to step in, because we have a workforce shortage. And then the future here of the binary Big Bang is that we can drive transformation throughout healthcare by leaning on AI, not replacing us, but leaning on it. And it's pervasive. It can touch every single system that we use. The second concept is that of your face in the future. So AI, actually, who can remember the metaverse? It was that thing that happened before the pandemic, yeah? Okay, and we all had those nice visors that we put on, and we could elect to go and play football with soccer, as I like to call it, with my friend in Australia, and it was all kind of cool and groovy, right? And maybe he looked a bit blocky, and who can remember Max Headroom? There we go, okay. So you had that, but if we are gonna use those kinds of technologies enabled by AI, and we're gonna look at some of those in a moment. Demonstrations are always really scary and nervy to me, but we're going to get there. If we're doing that, then what is the face that we want to put out to the outside world? Okay? That's the first part here. There's also the concept of biometrics. Okay, we've all used biometrics, right? Okay. I've got a really cool gizmo on my app that actually lets me do my pulse in real time. Just by looking at the screen. It also does my O2 saturation just by looking at the screen. It also does my A1C value just by looking at the screen. My creatinine rates. It actually does a whole bunch of my vitals just from looking at the screen. And first time I saw this, I had the whole Theranos moment. Everyone knows what I mean? Okay, cool. And I had that whole Theranos moment, and I was like, I'm going to see myself on the front page of something I don't want to be on the front page of if I get too into this. So I promptly went off and actually had all my labs done and looked at and compared the results. It was bang on. It's frightening how good. Now, that technology has been enabled because we are now able to miniaturize the algorithms by using generative AI. So generative AI is a tool that we can use to create other things. Now, it's not by accident that all the hyperscale companies of this world, hyperscalers, if I said that? Okay, so the Azure, the GCP, the AWS, they're all really into it because of the massive amounts of compute you can easily suck up into driving these big models. But the things you can create and then use the things you've created is astonishing. And that's what this app actually does. The algorithms, which were massive, are now completely miniaturized and optimized, and they run on my device. And those of you interested, I'll show you later, and you can sit there and go, oh, my A1C is never that high. But that's kind of important too, because we can actually use these concepts to create technologies to allow us to do things better. Wouldn't it be great if you were sat there doing a type 2 diabetes chronic disease management effort, and you actually had your patients being able to look at their A1Cs at home without pricking their finger, without coming into a lab? Okay. Imagine if you had a pandemic and you cared about the respiratory rate of a population on a daily basis. Imagine if, because there will be another pandemic. So we have this concept using your face in the future that you can personify AI. We are going to look at this in a minute. When it comes to biometric side, you can actually have this dynamic two-way look at who people are, understanding who they are, and we're going to talk about that in a moment. So there's lots of things I'm saying we're about to talk about. But we do have this ethical dilemma about how invasive do you want to be. And healthcare is littered with ethical dilemmas. Okay. We talk about, should we intervene with a patient if they don't want intervening with? Okay. That's pretty profound. Should we be monitoring them remotely if they don't know? It's profound, but if I walk through an airport right now, they know exactly who I am. Okay. So we have a lot of things we need to get through as a society in embracing generative AI before we can even really contemplate if we trust it. And the two go hand in hand. We've been using surgical robots for decades, okay? Decades. 32 years ago was the first actual surgical robot to actually start getting used. 32 years. It wasn't overly successful, to be fair. There was a bunch of lawsuits, but it was around. But the things like the Da Vinci robot, who heard of the Da Vinci robots, okay? They're great. When LLMs get their bodies, it's about how we can actually utilize LLM-controlled technology, personify it and embody it in a surgical robot. It doesn't have to be a robot. It can be a moving device which comes around a senior's ward and actually engages with seniors and takes their stats using the technologies we're just talking about. It can be the enhancement of Alexa so that it keeps somebody happy at home who's otherwise quite lonely. There's all these embodiments that we can do with LLMs sitting underneath. And but so you're going beyond simple automation and actually empathy and engagement. We were talking about this a bit earlier as well. Who's seen the research that says that actually patients feel more empathy towards a chatbot than they do their doctor? Okay. I would counter that that's something to do with the fact that the doctor's telling patients stuff they don't want to hear. And one of the things about generative AI, and someone was just saying you should do the whole communication with ChatGPT. ChatGPT will tell you what you want to hear. Okay. Can I get better from this? Oh, God, absolutely you can. Okay. But my doctor's going to say, well, you got to put some effort in. Okay. So that level of innate empathy which exists in some of these generative AI technologies can be misleading to a patient. And again, we come back to trust and the fact that data has to be private. And there isn't one size fits all. It's all very, very personal. I'm sure if I went through this room, what's that? Maybe 100 of us in this room, maybe a couple of hundred, I can't count today. We would all have a bunch of different opinions about what my data means to me and whether I'm happy for it to be utilized in certain ways. And that's okay, because we are all human. And then we have new learning loop, this fourth trend. And I really would encourage you to go and look at my LinkedIn, but actually look at the write-ups of these, much more exhaustive than I'm doing today. So with the new learning loop, we like to do things better, okay? So AI can act as a highly collaborative partner in informing the care we're delivering, learning from the outcomes that were being experienced, and then dynamically putting them back into how we do the education and learning going forward. And it's used to augment. Who would be comfortable with a generative AI robot sitting there and making all the decisions about your healthcare? Who absolutely wants to have somebody to blame if it all goes wrong? Okay. And that's one of the really big dichotomies in this. We've all, I hope, seen the reports where 99 out of 100 diagnoses that are made by generative AI are right. And the same diagnosis, 95 of the 100 were right by a person. It's better than people. But then who do you blame when it goes wrong? The coders? Well, they're not medical professionals. The doctor who told me to use it, well, they didn't actually do it. So we have this real struggle right now ethically about where liability sits for the usage of these kinds of technologies. AI regulation is coming. I do not feel equipped to comment on politics in this country right now. With the concept that regulations are going one way, whereas the need is going the other way when it comes into this topic. However, globally, regulation of AI is absolutely being put forward. There is fortunately a lot of sensitivity to the unintended consequences of over-regulating here. So that's being put more gentle, but the need of us as individual organizations to grasp the fact we need to self-regulate should not be lost on us. And that ties back into that liability as well. And then AI-enabled learning, I'm not going to go about this much more today, but the idea that actually, who's utilized electronic medical record systems before? Okay, and who's found them really, really frustrating sometimes? And there's two main ones here in the US, and you get this thing called at-the-elbow support, where you can go and call a friend and stuff. Well, being able to utilize generative AI to actually dynamically help you at the point of care to navigate you around the system is pretty compelling and pretty useful. So we have these two concepts, though, we like to talk about: comprehension and understanding. Generative AI, which one does it do the best? Okay. Judgment versus facts. Which ones does generative AI do particularly well? Some people are saying that. So the idea that machines and humans work better together is something we should be embracing, especially in healthcare. Machines are really good at comprehension and facts. Okay? They know what the words say, but do they understand what they mean? That's for a human. And humans bring judgment. So coming back to what I was saying, it's all maths. Maths does not have understanding. Maths has comprehension. Okay? Maths is really good at facts. It's this or it's this. It may or may not be wrong, but it's this or this. Whereas a human could impart judgment and make it more meaningful and make it more trusted. Because at the end of the day, medicine is an art and not a science. So I'm going to dwell a bit more on ogentics, these wonderful new word that seems to have crept into our vocabulary in probably the last 9 months. And it sounds cool, right? Okay. I think it sounds pretty cool, actually. So I'm going to talk about digital humans, back to the metaverse, playing soccer with my friend in Australia with a very blocky guy, or maybe basketball. I was pretty good at that, actually, on the whole thing. But so right there, that somewhere around the screen that's kind of overlaid on the top, that's Sophie on the right-hand side. Okay, she's a digital human. And digital humans are a great way of actually putting a face on generative AI, putting a face on the logic, putting a way for patients and providers to interact with the technologies we're putting in place here in a way that feels natural. Because I'm missing 17% of my workforce and patients are getting sicker. Actually, are patients getting sicker? Or are we getting better at detecting disease? Okay. There's actually some quite good research come out from the UK, where lots of good research comes from. It's actually, there's lots of evidence that says we're just getting better at detecting comorbidities and early onset disease. Patients are not getting necessarily individually sicker, it's just we're better at understanding it. And so as you're doing that, the idea that you could use digital humans in conjunction with generative AI for some kinds of aspects of care, that's quite compelling. If we can use them to help patients stay out of more needy treatment, that'd be quite cool too. We're going to talk about that in a bit more. But so the idea is that you can take these digital humans and put them in front of generative AI and come up with a way of enhancing how you deliver to patients. And there's several use cases we can do this, but digital humans generally are pretty versatile. They're just silicon, bits and bytes in every day. We can make them diverse. I think I'm allowed to talk about diversity still. I don't know. I've got my passport with me, it's fine. They can be very flexible in what they're wearing. We can make digital humans resonate with the people using them. When you see a doctor, okay, if I go see a physician, okay, I really want them to be old and grey-haired like me, because that resonates better with me. When I was in my early 20s, some time ago, I really wanted a young doctor that I could actually have a chat with, because old doctors don't understand me, because I'm young. So we can make digital humans as diverse. Something we've found as we've been developing these is that people do respond better to something that looks more like them. People have empathy for the bits and bytes on screen. People have actually come back to us in research and said, can I have the one that I saw last week? Because I got on much better with her. And I'm like, it's the same conversation. They're always available, 24/7, okay? They don't take vacations. And whenever somebody wants to engage with one, they're there. No waiting in line, no having to jump in the car in this ridiculously cold weather, which I live in Texas, so, and going and see somebody, they're always available to me. And multilingual, okay, so, and I am going to show you one in a minute, okay? Actually live, fingers crossed, internet access, is it working? They're multilingual. So we built these out and they can talk 170 different languages. You can switch language in conversing with them and they will just switch language. That's kind of cool, because when I have a population which is diverse and has many different languages as their native tongue, then being able to switch languages and have the right level of meaning, that's cool. Expressive. Well, underneath that box, it says, we can make these agents empathize with you. We can tailor it up and tailor it down. And you can do that on the basis of who the person is they're engaging with, or actually, do you want this to be a direct, clinical, precise conversation, or do you want it to be more verbose, more luxuriated? And again, depending on what the role someone has, if it's a clinician, they just want the facts, man. But if it's a patient, you actually do want that level of empathy, because the patients we have engaging with these are under duress. They're worried. Interactive. Okay, this is where it gets kind of cool. Conversational AI. Now, we had conversational AI kicking around for some time. Who can remember Dragon Dictates? Yeah, okay. Years ago, it became Nuance, which then got bought by Microsoft. But Dragon Dictates was actually primitive conversational AI. Primitive. It would understand what you were saying, and it would transcribe that out. And then later versions were able to respond back to you. But now we can actually have proper conversations, all empowered by this new transformer-based technology. They can be familiar. Again, if you're comfortable with someone you're engaging with, even though you know it's bits and bytes underneath, although some of these do look pretty good, it becomes relatable. It becomes something which you're very comfortable engaging with, and it's always the same person. Who's actually been to a doctor recently and had the same doctor they saw last time? Okay, a handful. Those of you with private doctors. But it just doesn't happen really regularly that you see the same person twice. But with these guys, you can. And they're effective. They are really effective. All the research we've done on these is they are consistent, they are repeatable, and you get a really good quality of care. And this is how they kind of hang together. The idea that you have this agentic core, which has a digital human put in front of it, which has a human user engaging with it, and then you can have a series of agents with different capabilities. So something we've learned is having these monster large language models sitting behind this kind of stuff sucks. It becomes inconsistent. They hallucinate. And all a hallucination is, as we all know, is it adds stuff to you. It doesn't have the right answer, so it just tells you what it thinks the right answer could be. Fills in the gaps. You know, I got it to write one of my colleagues, who's a very, very serious man. He's an MD and a JD. And I said, just write a biography on him. And it did. It swore that he was a member of the Bolshoi Ballet. And so we fill in the gaps. But with agents, you can have very tightly constrained LLMs and GPT sat around it. You can restart them back from scratch. I was talking to Sam from OpenAI, and I asked him, I said, so how does it actually work? And he goes, I have absolutely no idea now. I know how it worked on day one when we turned things on, and every time we put a new GPT model out, but the entire neural network gets rebuilt, and it builds itself, and it's a scale so massively, trillions and trillions of digital synapses inside these models. So they don't know exactly how it works, only on day one. But with constrained agents, we can. And then you have both long-term and short-term memory. So the long-term memory, the trainings, the constraints we put around that. It's very important, the constraints. We're going to come back in a sec. And then short-term memory. Within my session, what have I talked about? Because asking me the same question 20 times is not really going to be a great user experience. So we have short-term memory built in. And we integrate with existing systems. Who's heard of HL7? Great. That cheers me up. I've spent a lot of time around HL7. It's great. But HL7 Fire, we use that to integrate to a bunch of existing systems which are out there because that gives more meaning. Otherwise, these things are just standalone. And we want an agent to actually interact like a person. A person can hit a keyboard, okay? Now we've got the agents to be able to do the same thing as well. But not just EMR systems, all the various systems that sit inside a healthcare ecosystem. And there's a bunch of opportunities which emerge because of this. Many different ways that these agents can be utilized to optimize and improve and accelerate how we deliver care. And those of you taking photos, by the way, of these slides, we will give you the slides, okay? They're not top secret. Most of them. I stay away from politics. They're not top secret, okay? But we are going to just dwell upon patient education, which touches upon two of the themes, the Big Bang and your face in the future. And okay, so question, what am I? Look at the screen, I can read the statistics out. 28 million a year worldwide, 51,000 of them here in Minnesota, maybe, depending on which bits of Minnesota public health I read and did the analytics on. So maybe it's 62,000 a year. Or 3.5 million a year in the US. It'll be 4 million in 2025. What am I? No. It's a type of surgery. You're like, well, no, not colon. Really? No, not colon. It's cataract surgery, okay? And it's the most frequent surgery that we perform. It's more than double the next closest. Who actually thought about cataract surgery recently? Unless you're not, okay, you're not pathologists, okay, fine. Apart from y'all special people. So cataract surgery, kind of important, and there's a lot of it going on. So cataract surgery, according to the American Ophthalmic Association, has between 30 and 60 minutes of guided patient education associated with it around the surgery, what's going to take place, the wound and how to care for it. And then if you're a sufferer of a certain bunch of comorbidities, different stuff about how to care for it because you had UV exposure or you got high blood pressure or something like that. So 30 to 60 minutes per patient, every single one of those 3.5 million patients last year in the US. So time to meet Sophie. That's Sophie. Say hello, Sophie. Oh, you did as well. That's fantastic. Okay. So now I need to try and use a mouse on a big screen and hope this comes up. Oh, look at that. Okay. Here we go. Demos are always very risky, I know. There she is. Hi, Sophie.
Hi there. I've reviewed your medical record and would like to discuss with you some conditions that may affect a cataract procedure. Would you like to discuss these now?
We'll get to that in a second. Okay, so Sophie is trained on the American Ophthalmic Guidelines, or CPG, Clinical Practice Guidelines for cataract surgery. She understands exactly what patients need to know. She's also got the current NDCs for the entire what's prescribable in the US, and she's highly constrained. I could ask her about an auto loan and she won't go off, but I could ask her about any other clinical conditions and she won't go off. What she does is she sits here inside this pseudo team session and all she'll do is talk to me about my cataract surgery. And she's integrating using FHIR into my clinical record, so she actually has some pertinent information about my history. And then, fingers crossed here, allow the microphone. Yes, please, that'd be great. Oh, guys, the team promised me the microphone was enabled on the computer. Okay, so you have to bear with me. I will type it. That's why I use this version. Yes. What will actually happen normally is she'll listen to me. and she'll talk to me.
I see you have ultraviolet radiation exposure and smoking. Exposure to ultraviolet UV radiation is a known risk factor for developing cataracts. Studies have shown that people who are exposed to high levels of UV radiation are more likely to develop cataracts. This risk is further increased for individuals.
I'll turn her off now because there's no point in me just listening to that and not being able to talk to her. So, Sophie, she's trained. I could ask her questions about my wound care. I could ask her about what's my expected recovery length of time. That interaction that should take 30 to 60 minutes, okay, I can make it as long as I like. Cataracts are normally, as you might expect, suffered by older people who want to have a longer conversation. They want to understand more. When we put this to a trial, we had one lady and she came back and saw Sophie 17 times. Well, what's wrong with that? She was worried, she was concerned. She wanted reassurance and she couldn't get it from a physical person because how the heck is she going to go back and see that person? Okay, so Sophie, you have a future ahead of you. When I actually do the maths, because I care about the maths around this a little bit, I see that across the US, a low range of 30 minutes to a high range of 60 minutes saves me time. It saves me between 420 and 840 whole nurses a year. That's a big number, right? Why aren't we doing this? What's stopping us? There is nothing stopping us right now. HIMSS is coming up in a couple of weeks, the Health Information Management Conference. We'll be showcasing this across many of our clients because this is a great way of addressing the workforce shortage that we have right now. And the money is one thing, but the fact is we have a shortage. It's not that we're displacing anybody. We are doing labor arbitrage. What does that mean in Minnesota? We do less cataract surgeries here in Minnesota, but it does mean 6 to 15 whole nurses available here in Minnesota because of this type of tech. I don't know about you guys, but I would like 15 extra nurses here in Minnesota right now because we know we have problems. And then if we expand that out, behind that box, it actually says about 2,500 FTEs addressable in North America and about 37 here in Minnesota. If we expand it to other high-frequency surgeries, because there are clinical practice guidelines which are highly constrained on every single one of these. This is what a patient has to know before they can legitimately consent. And because, not on this computer right now, but in generally she can listen to you and hear you, you can also capture consent. You can capture the entire conversation. Something we've done with Sophie is to also capture the questions that patients are asking and tailor her training based upon it so that she is now more informed. These are the types of questions that get asked. For example, can I go and drive home after your cataract surgery? Well, no, you can't. I will explain to you why, but that's a frequent question. Okay, so cracking on a bit. This allows us to have people, our nurses, our physicians, spending more time directly caring for patients as opposed to having a conversation which is rote. The training that you have to provide these kinds of education, it doesn't change every single conversation, not 95% of it. So less time talking at a patient and more time caring for the patient. So portraits of the future. When you all go and look at my LinkedIn, yes, Andy. Yeah, okay, cool. When you go on LinkedIn, you'll see that having come out of talking about this generative AI stuff and the tech trends, we're doing what we call portraits of the future. So casting our mind forward to where this technology could end up and how it touches upon some of the tech trends we're seeing. And we started last week, we started. All these images, you'll see 3 now, these are all generated by DALL-E, which is another great generative AI thing because it's a much better artist than, well, I am, and frankly, anybody inside my firm. So calm into the chaos. That was the prompt I used, and that's what it came up with. I may have said hospital as well. So it's an emergency room. And it's saying, look, in the emergency room, it can get quite fraught, right? There's a lot going on. And how can we bring about a bit of calm, a bit of automation into that environment? And so we talk about augmented triage. When a patient walks in, we start capturing stuff about them. We can analyze the actual patient's symptoms, their vitals. I was talking about, I can do it on my phone. We can definitely do it with cameras in an ER. And the moment they step into the room. So we don't subject patients to lots of testing. We actually have those insights right now in the palm of my hand. And then you can assess the patient. How do they walk? Okay? How do they talk? All those micro expressions. And we're not saying this is about to happen right now, but it's going to happen in the next 5 years. There's actually Houston Methodist, which is one of the big systems down in Houston. They're experimenting with this right now. This ambient technology, you can sit around that. Second one here, I like this one. The spoken word and the furrowed brow. I was getting all creative again. I already talked about some poetry. And so the idea here is that using ambient technology, and this one will be published, by the way, on Monday next week, if anyone's interested, you can actually start assessing based upon the unspoken aspects of the conversation. So we're all trained as clinicians for the primary care consultation, okay? How you go about engaging with a patient and how you pick up from what they're saying, what they're not saying, how they're looking, the fact their eyes get cast away when they're not focusing on you. Maybe they're not being completely honest with you. If they look down to the left when they're right-handed, then they're under duress, down to the right when they're right-handed. You can pick that all up digitally and feed it back real time to the surgeon or the physician who's trying to treat. That's kind of cool. There's research going on in Germany around picking up early onset Alzheimer's from looking at the way that you pronounce diphthongs and blends and how your speech changes. There's work, I think it might have been Mayo actually, with Park. There was the Parkinson's early prediction as well. Does exactly the same thing. So this is not fantasy land. This is not Star Trek. This is here. It's available and it's coming to the fore. This is where it gets a bit more interesting. So the concept of the unseen healer. Nanotechnology is really good and getting better, okay? We can start embedding biosensors in very, very small components that you can swallow. We can guide them around your body so they'll go and sit in certain places as well. We can deliver therapeutics right to the places in your body that need them through nanotechnology. You swallow the right tablet, off it goes, it finds the right bit of tissue, and yeah, it delivers a therapeutic. This is very forward-looking, but the work's going on in pharmaceuticals right now. This will be in about 6 weeks, we'll publish this one. But it also allows us to do timely interventions. It allows us to prolong life, and I'm going to touch upon that. I'm going to accelerate a bit more what I'm talking about, because we're having to start with some big ethical dilemmas now around saying, if we're getting better at prolonging life, what does that mean to the quality of life? And also, as people get older, they get different types of conditions. We have no idea what a 125-year-old is going to suffer from. We have no idea what happens to your brain when you've got 130 years of memories crammed inside it. You can live, but are you having life? And there's very difficult questions for us to start getting to grips with. So how do we respond to all this? Well, do we embrace it or do we fear it? Because I think all of us have a bit of it going on. The idea that you can have treatment that takes place wherever you want. We've tried to do community care for years, but just care inside my own body, that's a realistic thing that's coming out here. We could get rid of chronic disease that you can't see. We can get and address it in advance. But then over on the other side, this week we published another one of those portraits, which was called The Last Generalist. And we contemplated that actually the family doctor might be becoming a thing of the past. We all know that medical practice has become hyper-specialized. Okay. The family doctor might just be a coordinator across all those hyper-specialties. So, yeah, the death of the family doctor, and it says the rise of the AI overlord. We should fear that because that takes us out of control. This concept that actually this is going to cost money. Well, only the wealthy then can get access to that care. We should fear that too. But bottom line is that human dignity has to be at the forefront of all of these decisions which are going on right now. But what does it mean for our careers? all of us have to understand this. We have to understand how AI, generative AI, can work with us, can make us better at what we do. And the human skills, judgment, as well as facts, comprehension, as well as understanding, is going to become so much more needed and rare that you can do that with the technology. So my message at the end of all this is to be conversant. It gives us more time to spend with patients, which means we can spend more time with patients. 25 years ago, you could sit down and spend 30 minutes with a patient who got a problem. You can't do that right now. These types of technologies, as we embrace them, can mean that we do. So my final thoughts here is that, in case you hadn't noticed, AI is redefining who we are as a society and what we do with our careers right now. It's not just technical expertise, but it's our ability to think through how we deliver better care, how we experience as physicians and patients better care, and how we deliver better care outcomes that really matters. And we are part of a future right now where medicine is more precise. When I look back over the last 50 years of medical development, I'm blown away to think that we could in any way maintain that level of cadence, let alone accelerate as we are doing right now. So I absolutely believe that in the next 5 to 10 years, we will find a cure for many of the diseases which have evaded us for generations. Ebola, HIV, cancer. It's going to happen. And we are getting better at it. But this future is not inevitable. It all depends on us getting behind this type of tech and utilizing it right now and embracing it and not being fearful, not fearing the AI overlord, because we know that we can control it. And the careers are going to shift. And that means that we can spend more time with patients. Who'd like to see another final throes of a digital human doing something kind of cool? Yeah? Well, one person nodded, so I'm off. Okay, so here we go. This is Brooke. I hope it's Brooke. We'll click on her. This is actually a second generation. We've got 3 generations of digital humans now. So this is Brooke, and we've already established the microphone won't work for me, so I'm going to have to type to her, even though I say yes. Okay, she'll say hello to me in a minute. They assured me this was a high-speed bandwidth.
Hello. I'm Brooke, a demonstration digital human here to show how patient access can be improved. I can assist with access to healthcare services in the Minneapolis area, help with basic health and wellness advice, and create appointments with primary care and specialty clinicians. How are you doing today? May I know your name before we begin?
Okay, so I'm Andy. Okay. Oh.
Hello, Andy. It's nice to meet you. Could you please confirm if your name is Andy?
What did I,
If so,
did I mistype?
I can
I can't see
proceed to
the
look up
screen
your
from-
records through the Minnesota Health Information Exchange.
Okay. What did I mistype? What did I say my name? Oh, my word. Okay, fine. Hang on a second. Sorry, oh, goodness me. Let's see if the microphone does work. Otherwise, this is going to be really, really turgid. I'm sorry, my name's actually Andy? No, okay, fine. Let's blame IT. Okay, so my name is actually... Okay. You guys are loving this far too much. I'm going to go back to the beginning and just see if I can remember my name from the scratch. Okay. So what she's actually doing, I'll just fill you guys in. She's talking out to the Minnesota Health Information Exchange. Okay. So she's talking using HL7 Fire. And so
Hello.
she's...
I'm Brooke, demonstration digital human here to show how patient access can be improved. I can assist with access to healthcare services in the Minneapolis area, help with basic health and wellness advice, and create appointments with primary care and specialty clinicians. How are you doing today? May I know your name before we begin?
Okay, here we go. A N E. Is that good? Okay. So she's gone out and we've told her who Andy actually is. And you'll be able to tell this is exactly my care record.
Thank you, Andy. Please bear with me while I look up your records through the Minnesota Health Information Exchange. I've sent a one-time passcode to your cell phone. Could you please provide that passcode?
Okay, so, a little bit of security. We can't just say, oh, I'm anybody and off we go. So 1, 2, 3, 4, 5. There you go. The most common physician password in at least one hospital in this country.
Thank you, Andy. Would you like me to summarize your overall health and wellness based on your records?
Oh, yeah, I would actually. I'd like to know that because she's actually gone and retrieved across 6 different EMRs through the HIE a bunch of vitals. They're synthetic. It's not actually my health record, as you'll be able to tell. So she's going to pull them out, and there's 2 Epics, 1 Cerner, and 1 Meditech. That'll tell you pretty much who they are.
I'm looking into this now.
Okay.
Andy, your health and wellness summary indicates that you are in peak athletic condition. Your cardiovascular health is strong, with an optimal resting heart rate and healthy blood pressure, cholesterol, and A1C levels. This reflects your disciplined training and nutrition. To maintain your excellent health, I recommend continuing your current lifestyle and perhaps consulting with a specialist to ensure all aspects of your health are monitored. Would you like me to help schedule an appointment with a specialist or provide any other assistance?
Okay, so she's going to do scheduling for me. So actually, I'm going to say no on that one. I don't need you to do that. One of my colleagues, I have it slightly rigged, so every time he says his name, it tells him he's a physical wreck. She won't do anything
Andy,
else apart
if you
from
have any
referring
other
to a
questions
well-manned
or
clinic.
need assistance in the future, feel free to reach out. Take care and keep up the great work on your health and wellness.
Okay, so I'm going to say, actually, I have a rash on my arm. Okay, she's not going to do diagnosis. We don't allow that. That's not
Just a
ethically.
moment, I'm working on your request.
So she's going
I'm
off and
sorry
saying,
to hear
okay.
that, Andy. Rashes can be uncomfortable. It's important to identify the cause to treat it effectively. I recommend seeing a healthcare professional to get a proper diagnosis. Would you like me to help schedule an appointment with a dermatologist or a family medicine physician?
Okay, so those of you paying attention, a couple of things have happened in there. One is she's worked out that my rash actually sits on a particular branch of SNOMED. SNOMED? Yep, standardized nomenclature of medicine, one of the terminology sets we use. So she's taken the narrative of the rash, she's stuck it on the right branch of SNOMED, and she's worked out that actually if I'm going to have a referral, it's either going to be to a family doctor or a dermatologist. Okay? That's the intelligence gently coming into play in a way that's meaningful for me as a patient. So, oh, bugger. There we go. So actually, yeah, I do want to have an appointment. So I'm going to say YES. So she's now going to go and look and find me a dermatologist in the Minneapolis area who has some availability for scheduling. How many times have we actually started calling and finding
I
someone to go and
recommend
see?
scheduling an appointment with Dr. Linda Brown, a dermatologist at Sunrise Dermatology. The clinic is located at 8282 Cedar Boulevard, Minneapolis, Minnesota, 55485. Would you like to schedule an appointment for one day this week or next?
Yes. Well, actually, I can mistype. Tomorrow at 9. There we go. Fortunately, she's actually calling dumb schedules. I'm not actually making an appointment. So should I
I've
create
scheduled your appointment with Dr. Linda Brown, a dermatologist at Sunrise Dermatology, for tomorrow at 9 a.m. The clinic is located at 8282 Cedar Boulevard, Minneapolis, Minnesota, 55485. I'll confirm that the appointment has been created and will be available in your patient portal. Would you like me to send you appointment reminders and directions?
So obviously the answer is yes. So around patient access, this is one of the big barriers we see time and time again, is patients actually knowing where to enter the healthcare system and where and who to call, and actually whoever you go and call, whether they have access to actually all the availability that's going on in Minneapolis right now for my rash on my left arm. So that's Brooke. She's real. Oh, actually, here's a good one. Who speaks a language other than English in the room? Oh, great. I can just tell you this works. Okay. If I say, please answer in French. I'm done. I'm about to get the hook off, okay. And she'll say in French, Come book.
Bien
Let me
sûr,
down.
Andy. J'ai programmé votre rendez-vous avec le docteur Linda Brown, dermatologue à Sunrise Dermatology, pour demain à 9 heures. La clinique est située au 8282 Cedar BLVD, Minneapolis, MN 55.
There you go. And it's right. She speaks French too, and she speaks 170 different languages. Thank you very much for your time. Technology is shifting stuff around, and we all will benefit from it. Thank you.
All right, everyone. Thank you very much for your attendance and attention today. I know it's hard sometimes to take time out of your busy schedules, but I think that this was very well worth it. I learned a lot. I'm sure all of you did. A few takeaway points that I caught. So obviously we're thinking about and talking about the coming healthcare revolution, but really talking about just overall driving health transformation. And some key takeaways I got was consumer or patient engagement, using technology to assist. And well, the question I think that hangs over all of our heads is, will we have an AI overlord? Stay tuned, come back in 2026 to find out. But really, thank you all again for being here. And thanks again to our sponsors, Clifton Larson Allen, Frederickson, Bank of America, and Tegria. Take care, everyone. Drive safe.